Chapter 31. Neurologic Emergencies. Introduction. According to the Health and Stroke Foundation of Canada, cardiovascular disease, which includes heart disease and stroke, is the leading cause of death among Canadians, 29% of deaths. Clearly, you'll encounter many neurologic emergencies. Patients with acute neurologic emergencies or chronic neurologic disabilities can be extremely vulnerable or even helpless. Many of the reflexes that protect an awake person may be temporarily or permanently impaired when the nervous system is compromised. The eyelids do not blink away dust and irritants. The larynx does not gag and cough in reaction to secretions oozing down the airway. The body does not seek a more comfortable position in response to compression of a limb in an awkward position. The tongue goes slack. The airway is at risk. In this chapter, the anatomy and physiology of the nervous system are reviewed first. Then the general pathology of neurologic conditions is explored, laying the proper foundation for discussion of their assessment and treatment. Anatomy and physiology. The nervous system is the most complex organ system within the human body. It consists of two major structures, the brain and spinal cord, plus thousands of nerves allowing every part of the body to communicate. This system is responsible for fundamental functions such as controlling breathing, heart rate, and blood pressure. But the real beauty of the nervous system is found in its higher level activity. Reading a good book, like this one, enjoying music, having a discussion with a friend, and even watching television require the brain to engage memory, understanding, and thought. Here is where the true complexity of this system can be seen. Figure 31-1 shows the basic structure of the nervous system. The major structures are divided into two main categories: the central nervous system, which is responsible for thought, perception, feeling, and autonomic body functions, and the peripheral nervous system, which transmits commands from the brain to the body, and receives feedback from the body. Consider the case of Justin, a child riding a bicycle. This common and seemingly simple activity is rich with both conscious and unconscious functions. It is a beautiful summer morning, so Justin goes to the garage to get his bike. Already the brain is hard at work. As Justin enters the garage, the brain must determine which object is a bike. Justin scans the garage. The images produced by his eyes are transmitted via the optic nerve to the occipital lobe of the brain. There the image, which is transmitted upside down, is reoriented. The occipital lobe then pores through tens of thousands of stored images. Has this image been seen before? Once the image is recognized, an existing pathway is accessed to the temporal lobe, where language and speech are stored. Now, as Justin walks through the garage, he is able to put names to what he sees: a car, a workbench, a bike. When Justin was learning to speak, he often became confused about the names of objects. As he practiced, he received reinforcement for the correct names and redirection for the incorrect names. In his brain, more pathways were established between the image of an object with two wheels, a seat, and pedals, which was stored in the occipital lobe, and the word for that object, bike, which was stored in the temporal lobe. As Justin retrieves his helmet, the frontal lobe of his brain springs into action. The frontal lobe, which controls voluntary motion, sends signals out of the central nervous system along efferent nerves to the arms, shoulders, chest, and hands to perform the task of picking up the helmet. The efferent nerves lead the brain through the peripheral nervous system, and convey commands to other parts of the body. Which way should the helmet be applied? This motor memory is stored in the frontal lobe. The brain stores memories in the areas that are initially stimulated. As he places the helmet on his head, Justin needs to make fine adjustments to its position. His brain is receiving impulses from nerves within the skull and muscles of his head, indicating that the helmet is uncomfortable. Justin senses pressure, and possibly pain from the improperly positioned helmet. The afferent nerves, that send information to the brain, transmit signals of discomfort to the parietal lobe, where the body's sense of touch and pain perception are found. Signals sent from the parietal lobe to the frontal lobe make the body adjust the helmet until the pressure signals have stopped. As you have been reading this tale, huge amounts of information have been pouring from your peripheral nervous system into your central nervous system. Signals are sent from organs, muscles, and areas of the skin to the spinal cord until they reach the lower portions of the central nervous system. The position of your legs, the distribution of your body weight, the sensation of the pages in your fingers, the state of your renal arteries, all of these data are being sent to the central nervous system. How does the brain manage this massive amount of information without confusion and misdirection? By using the diencephalon and brainstem. One major role of the diencephalon is to filter out unneeded information from the cerebral cortex. Imagine if you had to think about shifting your weight on a chair when it became uncomfortable. The signals of pressure or pain being sent via the peripheral nerves initially stop in the diencephalon. The body's administrative assistant then decides whether the big boss, the cerebral cortex, needs to be bothered with this information. In the case of an uncomfortable bottom, the diencephalon simply sends commands so that you move slightly. Unless you were concentrating on how you were sitting, you would never even know that you moved. How did Justin know it was time to get up this morning? His internal alarm clock went off, of course. The midbrain, part of the brainstem, is responsible for regulating the level of consciousness. You often get tired at the same time each day due to the functions of the reticular activating system. Justin is wide awake and thinking clearly thanks to his reticular activating system. How are blood pressure, heart rate, respiratory rate, and breathing pattern controlled? Again, the brainstem is responsible. The pons, which is located just inferior to the midbrain, regulates your respiratory pace and the depth at which you breathe. The medulla oblongata controls the blood pressure and heart rate. Of course, these functions need to occur constantly, but Justin could not ride his bike if he needed to spend time and energy consciously controlling his pulse. The brainstem frees the cerebral cortex up to engage in higher-level activities. Justin now mounts his bike and begins to ride. The smile on his face reveals that he is having fun. Emotions come from two main areas within the brain, the limbic system, where rage and anger are generated, and the hypothalamus, a part of the diencephalon, where pleasure, thirst, and hunger are found. All emotions are then mediated by the prefrontal cortex, so people can choose how they are going to act in relation to how they feel. Justin begins to pick up speed. As he approaches a corner, he must turn or risk crashing into a tree. The excitement increases his heart rate and blood pressure. The hypothalamus communicates to the pituitary gland, a member of the endocrine system. The pituitary gland, in turn, sends chemical commands to the adrenal glands to release epinephrine and norepinephrine. The release of these chemicals by the sympathetic nervous system gives Justin the increased strength and cardiovascular reserves that he needs to handle the bike in a tight turn. Just as quickly as these chemicals act, they are shut off to prevent the body from depleting its reserves. Too much epinephrine and norepinephrine can also be damaging over the long term. Justin shifts his weight and makes the turn successfully, due in large part to his cerebellum. This lobe of the brain, located in the posterior, inferior area of the skull, manages complex motor activity. When Justin first learned to ride a bike, he had to think about what to do, where to shift his weight, and how to hold his upper body. Eventually, the frontal lobe of the brain got tired of sending the same commands again and again, so this task was transferred to the cerebellum. This lobe keeps track of Justin's body position at all times, and helps to manage activities such as walking, swimming, and riding a bike. All of this wonderfully complex activity is made possible by the synapses. Nerve cells do not actually come in direct contact with one another. Instead, a slight gap separates the cells, which allows for a far greater level of fine control. The synapse, which is present wherever a nerve cell terminates, connects to the next cell via chemicals called neurotransmitters. A host of neurotransmitters are present in the brain and throughout the body. Dopamine, acetylcholine, epinephrine, and serotonin are all examples of neurotransmitters. These chemicals take the electrically conducted signal from one nerve cell, a neuron, and relay it to the next cell. Nerve cells respond to these signals in an all-or-nothing fashion. They either fire or they do not. A neuron cannot fire weakly. How do the neurotransmitters achieve a greater degree of control than that permitted by simply wiring the cells together? The answer lies in the connections made as the signal travels from the cell to the synapse. 1. The first neuron fires and sends a signal along its axon to the axon terminal. 2. The impulse reaches the axon terminal, where neurotransmitters are released and trickle across the synapse. 3. Dendrites detect these chemicals and are triggered to send the signal to the cell's nucleus, which then transmits it down that axon, and so on. 4. Dendrites release neurotransmitter deactivators so that one impulse from cell 1 generates one response from cell 2. The complexity in the system derives from how the cells are connected. In Figure 31-6, each cell is connected in a straight line fashion. Although this is a reliable method of getting a signal from point A to point B, gaining more control requires more complexity. In Figure 31-7, 3 cells are brought together to connect with the same cell. Cell 4 will not respond unless it receives simultaneous stimulation from cells 1, 2, and 3. The same concept can be extended to the situation in which one cell sends signals to many different cells. In Figure 31-7, for example, cell 4 stimulates cells 5 and 6. As a consequence of this joint action, Justin is able to see his bike, recognize the object, know its name, instantly know how to use it, know how to make the muscles of his mouth say the word bike, and appreciate how it will feel to ride the bike. Neurons may or may not have myelin around their axons. Myelin, a protein wrapped around the nerve cells, acts as an insulator. It helps prevent the electrical signal from leaving the nerve cells and entering the surrounding tissues, but its major function is to increase the speed of conduction. Myelinated nerve fibers are predominantly found in vertebrates and higher organisms, all of which rely on rapid nerve conductions to allow higher thought and brain function. Table 31-1 summarizes the structures of the nervous system and their functions. Pathophysiology. The pathophysiology of the nervous system can be examined from several angles. Discussion of cancerous, degenerative, developmental, infectious, vascular, and multifactorial causes of neurologic conditions will be followed by a review of increased intracranial pressure and its effects on the nervous system. Neoplastic, cancerous, causes. Neoplasms, the medical term for cancer, are caused by the abnormal and unregulated growth of cells in the body. Many neoplasms are related to errors that occur during cellular reproduction, especially during the unwinding and reproduction of the DNA during cell duplication. These errors are not critical enough to cause cell death, but allow the unchecked multiplication of the cell, and thus the development of a neoplasm. Neoplasms can be categorized as either benign, non-cancerous, or malignant, cancerous. Essentially, benign neoplasms are not very aggressive. They tend to remain within a capsule, so their growth is limited. In addition, these tumors are usually relatively easy to remove. By contrast, malignant neoplasms may forcefully take over blood supplies, grow unchecked, and move to other sites within the body. They create finger-like projections into surrounding tissue, spreading and invading new areas. This growth without regard to other cells explains why many malignancies are fatal. The process by which cancerous cells move to sites distant from their site of origin is called metastasis. Metastatic neoplasms of the neurologic system are tumors that arise elsewhere in the body, travel through the bloodstream or lymphatic system, and take up residence within nervous system tissues. Lung and breast cancers are the two most common types of cancer to metastasize to the central nervous system. Degenerative causes. Degenerative conditions result when a normal structure is altered over time. Such damage can occur in several ways, for example, due to wear and tear. Consider the effects of osteoarthritis on the knee joint. Every time a person falls on the knee, a small amount of damage is done to this joint. If the damage is not completely repaired, it may continue to accumulate until the patient experiences pain. With enough damage, the patient experiences limited mobility and pain to the joints. Degenerative conditions may also occur through autoimmune effects. The body has the ability to determine which proteins are self and which are non-self. This recognition enables the immune system to attack the bacteria in a cut yet leave the surrounding skin cells alone. In autoimmune disorders, the body begins to attack its own cells. The immune system is no longer able to distinguish friend from foe. Under normal conditions, myelin coats the axons of most nerve cells and allows for smooth transmission of signals to their target cell. In multiple sclerosis, however, the body believes that the proteins making up this insulation are foreign. It therefore attacks the myelin, creating gaps in the insulation that produce the signs and symptoms of multiple sclerosis. Developmental causes. Developmental conditions arise when portions of the nervous system are not formed correctly. Such an error can occur at any point in the development from embryo to fetus. The earlier the error occurs, the more severe the damage. In the case of spina bifida, embryonic growth does not proceed correctly. Soon after conception, the fetus is a ball of cells, each cell identical to all the others. Within just 8 days, however, the uniform ball of cells is ready to give rise to an embryo. One of the critical changes that must occur is the formation of the neural tube. Around days 15 to 20, a layer of cells will fold in and form a hollow tube that will eventually become the entire nervous system. In spina bifida, some cells do not fold correctly and remain outside the neural tube. This creates an outcropping of nervous system cells that expands as the embryo grows. The ultimate result is a child born with part of its nervous system outside the body. Even if the fetus is formed correctly, other problems may occur. If an infection or chemical agent gains access to the growing fetus, it may damage areas of the brain. Likewise, a temporary decrease in oxygen may lead to brain damage. These mechanisms are postulated as the causes of cerebral palsy. Genetics appear to play a role in many diseases, which has implications for developmental causes of neurologic disorders. DNA provides the recipe for building every part of the body and outlining every process that should occur. If the recipe is perfect, then the body part will function normally. If the recipe is only slightly off, the final product may function normally but may not be able to handle stress or wear and tear as easily. However, if the recipe is very wrong, a person will have an obvious disease. This concept helps to explain why some people seem to get diseases very easily while others do not. Consider a man who has been smoking for many years. Although smoking often leads to cardiovascular disease, this man lives to be 90 years old. Another man who eats well, exercises every day, and never smokes dies of a heart attack at age 45. Why? Some of the answer lies in how their coronary arteries were created. Perhaps the smoker had larger, more resilient arteries than those of the 45-year-old patient who had a heart attack. Although the first man makes many unhealthy lifestyle choices, he benefits from the greater capacity of his coronary arteries, which prevents them from narrowing dramatically. The second man, even though he follows a much healthier lifestyle, has narrower arteries at the beginning, so even a small amount of narrowing has a more profound effect on coronary perfusion. This basic concept is becoming more important in understanding disease incidence and severity. Infectious causes. Infectious diseases result when bacteria, viruses, fungi, or prions, a certain type of protein, gain access to the body, where they reproduce and cause damage. These organisms have the same basic goal as humans do, to continue to live. When they begin to attack the body, they are simply looking for fuel so that they can create the next generation of bacteria, viruses, or other organisms. The damage that these invaders inflict occurs due to one of two mechanisms: the body's reaction to the infection or the activities of the attacking organisms. The most common sign of infectious disease is the presence of a fever. Many organisms prefer to grow in a very narrow temperature range, so an increase in body temperature of only 1 or 2 degrees can slow down the reproduction of some viruses or bacteria. This allows the immune system to get the upper hand. It also provides valuable time for neutrophils, the body's soldiers, to find and kill the invading organisms. Finally, it signals the rest of the body that an attack is underway. In response, more white blood cells are produced, and chemical mediators are released to improve the body's effectiveness at finding and eliminating the organisms. If the temperature of the body becomes too high, however, the brain can be affected. The increased temperature may make a person's thinking dull, make it difficult to concentrate, and lead to a headache. Neurons are highly sensitive to temperature changes. As the temperature rises, the effects on the neurons can become more profound. Eventually, a person may hallucinate, become delusional, or lose consciousness. The random firing of neurons might also produce a febrile seizure. Infectious agents may also damage the body by destroying cells. These organisms may produce endotoxins or exotoxins that alter living cells. Endotoxins are proteins that are released by gram-negative bacteria when they die. Exotoxins are proteins that are secreted by some bacteria or fungi to aid in the death and digestion of other cells. In poliomyelitis, for example, the virus responsible for the disease attacks the axons directly and destroys them. This virus shows a preference for motor axons, the neurons responsible for making muscles contract. Without these axons, the patient can experience weakness, paralysis, and respiratory arrest. Vascular causes. Blood vessels are needed to supply nutrients and oxygen to cells and to remove waste products. If a blood vessel suddenly becomes blocked, as in an embolism, the cells beyond the blockage may become ischemic. As oxygen and glucose levels drop, brain cells resort to anaerobic metabolism to stay alive. Unfortunately, this mechanism is only a stopgap measure. Anaerobic metabolism creates minuscule amounts of energy for the cell and generates acidic byproducts. If circulation is not restored quickly, the cells will not have enough fuel to survive. However, there is some recent research indicating some brain cells may regenerate under certain circumstances. While still new, it may have potential to help repair cell damage in certain parts of the brain. Vascular emergencies may occur either suddenly or gradually over time. Sudden occurrences typically result from emboli or aneurysms. Emboli are insoluble objects that float in the bloodstream until they reach a point in the artery that is too narrow for them to pass through. Common types of emboli include pieces of a thrombus that have broken off or small clots, called thrombi, that are produced by turbulent blood flow within the heart. Patients with atrial fibrillation, for example, need to have their heart rhythm controlled and take anticoagulants to prevent clots from forming in the heart and traveling to the brain, which could cause a stroke. Other types of emboli include globules of fat from long bone fractures, air bubbles infused from an intravenous line, or a portion of an intravenous cannula that has been sheared off during insertion. These objects stop blood flow distal to the blockage, causing ischemia and necrosis of tissue. Artery walls consist of 3 layers of tissue. An aneurysm is a weakness in one or more of those layers. The process of aneurysm development is as follows. 1. A small tear or defect occurs within the wall of an artery. 2. Blood penetrates between the layers of the artery. 3. Pressure builds up and the initial small tear increases in size. 4. If the buildup continues, the wall will become so damaged that it can no longer withstand the normal pressure of blood within it. A bulge may then develop. If the weakness is severe, the bulge may leak or fail catastrophically, causing an intracranial hemorrhage. Gradual processes occur as plaque accumulates in blood vessels over the years. This buildup creates turbulence within the artery, allowing thrombi to form on its walls. The amount of plaque buildup reflects a combination of lifestyle choices, how we eat, exercise, and relieve stress, and family history, how we process food, manage fats, and the elasticity of our blood vessels. Over time, the buildup narrows the diameter of the arterial lumen. Eventually, the narrowing becomes so severe that blood flow is either diminished or cut off. Even the blood vessel itself may cause difficulties for some patients. In trigeminal neuralgia, the normal functioning of facial blood vessels produces severe pain. As the blood vessels change in diameter to meet the needs of the surrounding tissue, their pulsations can irritate the trigeminal nerve. This nerve is responsible for receiving signals related to pain, temperature, and pressure on the face. Multifactorial causes. Most diseases or conditions are multifactorial, meaning that they have multiple causes. Just because a person gets an infection, that does not mean that he or she will experience tissue damage. Just because someone eats unhealthy foods, it does not mean that his or her arteries will definitely become blocked. The following factors explain why many people get diseases. How? Well, the body system was created during development as an embryo or fetus. How effective the body's defense and repair mechanisms are. How severe or prolonged the factors trying to damage the body are. Thus, a health-conscious person may have a body that is less effective at repair and maintenance. In contrast, a person who smokes, drinks alcohol, and does not pursue a healthy lifestyle may have a body that is very effective at repair, which can help minimize the effect of those unhealthy activities. Intracranial pressure. Hemorrhagic strokes that cause bleeding into the brain place patients at risk for increased intracranial pressure. Treatment of these patients is directed at providing some degree of control over this potentially deadly effect. The skull, cranial vault, is filled with three substances: brain, blood, and cerebrospinal fluid. These substances exert a pressure, intracranial pressure, against the skull, and the skull in turn exerts a reflected pressure. This balanced exchange allows the brain to fit snugly within the skull without permitting any voids. If the skull contained empty spaces, with head movement the brain would slam into the skull and cause damage. When the pressure within the cranial vault begins to climb and remains high, it creates two major problems. The brain may either become ischemic, due to lack of blood supply, or herniate, push through the ligaments that compartmentalize the brain, such as the tentorium. As intracranial pressure rises, the amount of blood available to the brain decreases. Cerebral perfusion pressure, the pressure of blood within the cranial vault, then begins to fall. Cerebral perfusion pressure can be calculated by the following equation. Cerebral perfusion pressure equals mean arterial pressure minus intracranial pressure. The mean arterial pressure is the average, mean, pressure within the blood vessels. The average pressure is typically 70 to 100 millimeters of mercury. Normal intracranial pressure usually ranges from 5 to 15 millimeters of mercury. Normal cerebral perfusion pressure is, therefore, in the range of 60 to 80 millimeters of mercury. The lower end of normal cerebral perfusion pressure is around 50 to 60 millimeters of mercury. With cerebral perfusion pressure below 50 millimeters of mercury, the brain begins to become ischemic. Intracranial pressure changes constantly. Coughing, vomiting, and bearing down, for example, will increase intracranial pressure. These momentary spikes in intracranial pressure are not harmful. By contrast, if there is blood, swelling, pus, or a tumor within the cranial vault, intracranial pressure will increase, and remain high. Because the volume of the cranial vault is limited and inflexible, pressure increases as more substances squeeze into this space. As long as there is no significant drop in blood pressure or significant rise in intracranial pressure, the heart will still be able to get blood into the brain. However, if intracranial pressure rises sharply or blood pressure falls critically, patients may experience serious problems. Consider a patient with meningitis, an infection of the membranes that cover the brain and spinal cord. The battle between the infecting organism and the immune system causes fluid to accumulate around the brain, which in turn causes intracranial pressure to climb. As long as the increase remains moderate, the brain will continue to receive adequate oxygen and nutrients. If the infection goes unchecked and travels to the general circulatory system, however, sepsis and septic shock may occur. Then, as the organism continues to grow and feed, capillaries may begin to leak. Eventually, the blood pressure will decline, and the mean arterial pressure will fall. At a certain point, cerebral perfusion pressure may drop so low that the brain starts to become ischemic. Another potential outcome of intracranial pressure is herniation, or displacement of the brain out of the cranial vault. Herniation results when pressure increases within the skull, and the brain is pressed down through the foramen magnum, or large hole at the inferior portion of the skull where the spinal cord exits. Pressure on the medulla oblongata, located directly superior to the spinal cord, can result in rather bizarre vital signs and other findings, including slowed heart and respiratory rates. Given how critical normal perfusion of the brain is, blood pressure must be closely monitored in any patient with a potential intracranial pressure problem. Frequent assessment becomes even more essential when a decrease in blood pressure is also present. For any patient at risk for intracranial pressure, You need to ensure a systolic blood pressure of at least 110 to 120 millimeters of mercury. Oxygen and carbon dioxide levels are important factors to consider in preventing deterioration of the brain during neurologic emergencies. Optimizing oxygenation through adequate airway management will reduce ongoing ischemia. In the past, it was believed that lowering the carbon dioxide through hyperventilation would also reduce intracranial pressure and improve patient outcomes. However, we now know that hyperventilation may cause more harm than good by causing constriction and decreasing cerebral perfusion. General assessment. The brain is the organ that is most sensitive to fluctuating levels of oxygen, glucose, and temperature. It responds to alterations in these levels with changes in its function. The difficulty is that the brain is relatively resilient to internal environmental changes. It does not simply shut down when oxygen levels fall. The key to identifying a neurologic problem is to look for both the gross, or obvious, changes and the subtle, sometimes hidden changes that can indicate disease. This section reviews the assessment process for the patient presenting with neurologic dysfunction. As with all patients, begin with the scene assessment. Scene assessment. Personal protective equipment and routine precautions are taken for granted in many EMS systems. Their purpose is to protect you from exposure to potentially harmful organisms or environments. Patients having tonic-clonic seizures, for example, may be incontinent. Some unresponsive patients may be experiencing overdoses. With the use of illegal drugs, the presence of weapons, money, and crime increases. This potentially places you close to armed criminals. Patients with altered levels of consciousness may not be able to walk, may be combative, or may be completely unresponsive. You may need additional assistance with lifting and moving these patients. Special circumstances can be overcome easier if additional resources, such as helicopter transportation, rescue equipment, or fire suppression, are requested early in the call. Examine the scene to ascertain the number of patients. Clues can be obtained from the dispatch information. Also consider the mechanism of injury or history of present illness. Motor vehicle collisions typically involve more than one vehicle and, therefore, more than one patient. If many patients exhibit similar signs and symptoms, you should be very cautious. One patient with a headache does not stand out. If an entire family in the same house reports a headache, then you should consider the possibility of carbon monoxide exposure. In such a case, the house may be an unsafe scene, so ensure that you have the correct personal protective equipment. Weapons of mass destruction can follow similar patterns. If you encounter several patients who all exhibit the same signs and symptoms, all within the same general time frame and geographic location, you should consider immediate evacuation, don appropriate personal protective equipment, and contact the dispatcher to begin a more in-depth investigation. Initial assessment. Begin the neurologic assessment as you would with any other patient. Assess and secure the airway, breathing, and circulation. Use the alert, verbal, pain, unresponsive system to determine level of consciousness. If the patient does not respond to verbal stimuli, consider whether he or she may be displaying some abnormal posturing. These unconscious movements may indicate severe brain dysfunction. There are two main abnormal postures that the patient may demonstrate with painful stimulation: decorticate and decerebrate. If you see either posture, you should immediately consider the patient to be critical. In decorticate posturing, also called abnormal flexion, the patient flexes the arms and curls them toward the chest, toward the core of the patient. At the same time, they point the toes. Finally, the wrists are flexed. This posture may indicate damage to the area directly below the cerebral hemispheres. In decerebrate posturing, also called abnormal extension, the patient again points the toes, but now extends the arms outward and rotates the lower arms in a palms-down manner, called pronation. The wrists are again flexed. This posture is a more severe finding than decorticate posturing, as the level of damage is within or near the brainstem, diencephalon or pons or midbrain. Airway. The trigeminal, glossopharyngeal, vagus, and hypoglossal nerves are responsible for airway control. These nerves allow for swallowing, controlling the tongue, and ensuring that the muscles in the hypopharynx are slightly contracted. Alteration in the signals from these nerves can produce too much relaxation or too much constriction of the airway. Trismus, in which the teeth are clenched closed, can make managing the airway very difficult. Trismus can occur in responsive or unresponsive patients. In an unresponsive patient, it can indicate a seizure in progress, severe head injury, or cerebral hypoxia. The patient may need to be sedated or paralyzed to relax the clenched teeth and allow you to better control the airway. Breathing. As part of your assessment of the patient with a neurologic issue, you need to check the rate and rhythm of breathing. Rhythms can have subtle changes or be dramatically different from normal. Generally, the greater the deviation from normal, the more severely the nervous system is affected. Circulation. Evaluate the peripheral and central pulse pressures. Are they the same? The absence of a peripheral pulse with the central pulse present should cause you to suspect shock. What is the characteristic of the skin? Do you see evidence of gross bleeding? Is the pulse pounding? Remember, shock is rarely caused solely by a neurologic problem. If a patient has increased intracranial pressure, the vital signs may provide evidence of this problem. Table 31-2 shows the vital signs associated with increased intracranial pressure. The blood pressure rises, the pulse and respiratory rates fall, and the pulse pressure widens, systolic hypertension, and increased intracranial pressure. This set of conditions, known as Cushing reflex, are the opposite of what is expected in shock. As intracranial pressure rises, blood flow to the brain diminishes. To compensate, the medulla oblongata sends signals to the heart to increase the force of contraction. This causes systolic pressure to rise. If the intracranial pressure continues to increase, downward forces on the brainstem begin to damage the medulla's ability to send signals to the body. The diastolic blood pressure falls as the blood vessels relax or dilate, which in turn results in a widened pulse pressure. Finally, this pressure damages the ability to control respiratory and heart rate, consequently, both decrease. Transport decision. At this point in the examination, you may make a broad decision about whether to load and go, or stay and play. Critical patients, those with alterations in their initial assessment or significant mechanism of injury and history of present illness, should be transported urgently to an emergency department. Defer gathering very detailed information about these patients. Instead, focus on stabilizing and maintaining airway, breathing, and circulation. With stable patients, those with normal initial assessments, and minor mechanism of injury or history of present illness, you have more time to gather detailed information at the scene. You can question family and bystanders to gain valuable insight into your patient's issues. Focused history and physical examination. Rapid trauma assessment. Once the initial assessment is complete, you need to decide how to proceed. Is the patient stable or unstable? Do you suspect a major problem just below the surface? How should you transport this patient? At this point, you have two choices. Complete a rapid assessment using a full head-to-toe approach. Perform a focused history and physical examination, that is, evaluate only the area of patient report. You should perform a rapid assessment for any patient who has an abnormal initial assessment, has a significant mechanism of injury or history of present illness, or who you suspect may have a major problem. Examples would include those who are unconscious, are seizing, or experience a sudden loss of movement of the body. The focused history and physical examination are done on patients who are stable and have limited issues. These people have a completely normal initial assessment and a minor mechanism of injury or history of present illness, and you suspect a very local problem. Examples would include patients with headaches or non-traumatic back pain. Be cautious. If a patient has a headache, stress may not be the cause. Stroke patients can also experience headaches. If you suspect a more complicated problem, perform a rapid assessment to ensure that you give the patient the best possible pre-hospital care. History. History taking in the patient with a potential neurologic issue should follow the same process followed for any other medical or trauma patient. For example, if weakness is a symptom found in a medical patient with no trauma, use the OPQRST mnemonic to elaborate on the report of general body weakness. The physical examination for this should investigate potential cardiac, neurologic, respiratory, metabolic, or infectious causes. Appropriate tests and serial vital signs such as blood glucose levels, 12-lead electrocardiogram, lung sounds, and temperature will also help you rule out potential causes of the weakness. Detailed physical examination. The detailed physical examination examines all of the areas covered within the rapid assessment, but looks at them more closely. Head. The head is the area where you will spend the most time, gathering critical information on the functioning of the nervous system. Of course, you want to assess the head for trauma. Deformities, contusion, abrasions, penetrations, burns, tenderness, lacerations, and swelling are the trauma assessment components you should assess on every body area. There are many shades of level of consciousness, and many ways to evaluate it. A patient may be interacting appropriately with the environment or not at all. Figure 31-15 shows a continuum that ranges from what most would consider to be normal behavior to no response whatsoever. The point on the extreme right side of the continuum is coma, a state in which the patient does not respond to verbal or painful stimuli. The points in between, guide markings, are not intended to imply that every patient will stop at every point as his or her level of consciousness increases or decreases, but rather illustrate the relationships between various levels of consciousness. Although the extremes are easy to understand, the points in the middle, the shades of gray, can be more confusing. One tool to assist with the consistent evaluation of level of consciousness is the Glasgow Coma Scale. This assessment tool provides a basis to determine a patient's degree of illness or injury. It is used to determine the patient's level of consciousness and evaluate responses to eye-opening as well as verbal and motor skills. To determine the Glasgow Coma Scale score, add the three numbers together from each of the subsections of the Glasgow Coma Scale. The Glasgow Coma Scale score can provide information as to what pre-hospital care should be given and where the patient should be transported. Table 31-4 provides general guidelines for interpreting these scores. Patients with mild conditions need standard pre-hospital care. Usually you can honor their request to be transported to a particular hospital. Patients with moderate conditions are very difficult to treat. They are not stable enough for you to relax, but not critical enough to require your full attention. With this group, close assessment and transport to the nearest appropriate facility are prudent. Critical patients need airway management and rapid transport to the closest appropriate hospital. Changes in the patient's mood or tempo of the nervous system should alert you to changes in neurologic status. Oxygen levels or blood pressure could be falling. Body temperature could be climbing. A psychiatric condition could be escalating. Blood glucose levels could be too high or too low. Regardless of the underlying cause, your observation of a change should prompt further evaluation to ensure the appropriate level of pre-hospital care. Mood or affect is another attribute that provides insight into the patient's condition. Ask the patient how he or she feels. Frustration, anger, or aggression can be caused by low glucose or oxygen levels. Ask the patient how easy it is for him or her to think. Patients who have decreased blood glucose levels or who are taking opioids can experience difficulty concentrating. Lower blood glucose levels and opioids tend to produce sedation of the nervous system. In contrast, patients who are taking cocaine may experience difficulty concentrating due to excitement or mania. Cocaine, a sympathomimetic, increases nervous system activity, causing thoughts to come very quickly. If the speed of nervous system activity continues to increase, the patient may hallucinate or become delusional or psychotic. Visual findings. Perform assessment of deformities, contusions, abrasions, penetrations, burns, tenderness, lacerations, and swelling. Look at the symmetry of the face. Is there an obvious facial droop? Look at the eyes. Are the eyelids even bilaterally? Ptosis, drooping eyelids, can indicate Bell palsy or stroke. Figure 31-16 demonstrates what happens when such a patient is asked to smile. Weakness to one side of the face causes facial droop and slight ptosis. Assess the cranial nerves, the peripheral nerves that control various portions of the body. Look for the ability to respond, strength of response, and symmetry. Patients with stroke, trigeminal neuralgia, myasthenia gravis, or other neurologic conditions may demonstrate abnormal cranial nerve functioning. Speech. Listen to the quality of the speech. Is it slurred? Slurring is a classic finding with stroke. Is the speech appropriate? Focus on not only the quality of the words that are spoken, but also the appropriateness of those words. Sometimes speech may be clear but word choice is incorrect. Assess the patient's object recognition abilities. Patients may be able to speak clearly, yet have subtle knowledge deficits. In agnosia 8 equals without gnosis equals knowledge, patients will be unable to name common objects because connections between visual interpretation of objects and the words that name them have become damaged. Apraxia 8 equals without praxia equals movement refers to the inability to know how to use a common object. To test for these signs, simply show the patient your pen, scissors, or a set of keys. Ask the patient to name the object. If the patient responds correctly, hand the object to the patient, and ask him or her to demonstrate the object's use. The patient should know how to write with a pen, cut with the scissors, and turn a lock with the keys. Patients may have one of these signs without the other. One is not a more severe finding than the other, they simply indicate that some degree of misfiring of neurons is occurring between the occipital lobe and the temporal lobe, agnosia, or between the temporal lobe and the frontal lobe, apraxia. Language can be affected by injury or disease. In aphasia, speech is affected. There are three main forms of aphasia. Receptive aphasia. The patient cannot understand, receive, speech, but is able to speak clearly. This form of aphasia indicates damage to the temporal lobe. Ask the patient questions to which you both know the answer. Who is the president? What month is it? Do not ask yes or no questions. If the patient speaks clearly but gives incorrect answers, he or she may have receptive aphasia. Expressive aphasia. The patient cannot speak, express themselves clearly, but is able to understand speech. This form of aphasia indicates damage to the frontal lobe, which controls the motor portion of speech. Ask the patient to raise an arm. If the patient responds correctly, he or she can understand you. Ask the patient for his or her name. If the patient cannot respond or if responses are slurred, the patient has expressive aphasia. Global aphasia. This form of aphasia is a combination of expressive and receptive aphasia. In this setting, the patient will not follow commands and cannot answer your questions. Nevertheless, patients with global aphasia can often think clearly. They have needs, anxieties, and discomforts, but no way to express them. This can be incredibly frightening for patients who cannot understand anything that you are saying and cannot speak to you. Be sensitive to this state. Move slowly and purposely. Use therapeutic touch and good eye contact to reassure the patient. Pupils. Pupillary shape can be changed by trauma, glaucoma, or increased intracranial pressure. Cocaine, methamphetamines, and hallucinogens tend to cause dilation of the pupils. Depressants usually lead to constriction of the pupils. Equality of pupils is an important observation. Anisocoria, unequal pupils with greater than 1 mm difference, can be a sign of increased intracranial pressure. Many people have a slight inequality in pupillary size. Anything greater than a 1 mm difference is worth noting, however. As pressure increases within the skull, the brainstem can be squeezed. This squeezing can interrupt signals to one pupil, resulting in dramatically different size pupils. Finally, determine whether the eyes are twitching. Nystagmus, the involuntary, rhythmic movement of the eyes, can be caused by seizures, vertigo, and multiple sclerosis. Movement of the body. Observe how the patient moves. Does the body move equally on both sides? Patients with strokes may have weakness, hemiparesis, or paralysis, hemiplegia, of one side of the body. Sometimes you may discover patients with weakness on one side of their body but facial droop on the other side. This condition may be caused by decussation, in which nerves cross as they leave the cerebral cortex, move through the brainstem, and arrive at the spinal cord. Nerves that decussate start on one side of the brain, and then cross to control the opposite side of the body. Some nerves do not decussate, facial nerves, for example. The left side of the brain controls the right side of the body, but the left side of the face. A left cerebral stroke would therefore result in right side arm and leg weakness, but left side facial droop. Examining the function of the cerebellum can also allow you to gather information about potential damage to the brain. Have the patient close his or her eyes, and hold out the arms in front of the body at the same level. With the eyes closed, the patient's only way to tell where the arms are located is from the sensations being processed by the cerebellum. This is called the pronator drift test. If the patient has experienced a stroke, one of the arms may drift away from the other. Have the patient walk for several steps, unless some medical reason rules the activity out. Assessing gait, walking patterns, is another way to test the activity of the cerebellum. Walking is really a controlled fall. As your center of gravity moves forward, you must move a leg forward to catch yourself. Once you learn how to walk, your cerebellum controls these mechanics, so you can focus on where you want to walk, not how to walk. Damage to the cerebellum may be manifested as erratic walking, stumbling, or even losing the ability to walk. Several medical conditions cause alterations in the patient's gait. Ataxia is the term used to describe changes in a person's ability to perform coordinated motions like walking. Patients with Parkinson's disease exhibit a classic gait in which they place their feet very close together and shuffle. Their stride is short, and they have great difficulty changing direction. Such a patient will shuffle walk in a straight line and, when asked to turn, will take very small steps until the turn is complete. With this kind of bradykinesia, routine motions may slow dramatically. In contrast, patients with cerebral palsy may walk with a scissors gait. In the spastic form of this disease, the person will point the toes inwardly, have a stiff gait, and nearly touch the knees together while walking. In addition to the patient's gait, you should assess the posture. Have the patient stand straight. Place one hand on the patient's chest, and the other hand behind the back, to catch the patient if he or she cannot do so, and then push on the chest. Normally, as you push backward, the patient will compensate quickly and take a step forward to prevent a fall. In Parkinson's disease, the patient's posture is so rigid that he or she cannot compensate quickly enough and will fall over. Bizarre movements may indicate a disruption within the nervous system. Myoclonus is a type of involuntary contraction of the muscles that is rapid and jerky in nature. Most people have experienced myoclonic jerks at some point. Have you ever seen a seated person who is very tired? As the person gets closer to falling asleep, the head will begin to sag. Often the person will involuntarily jerk the head upward, myoclonic jerk, and wake up. Another form of bizarre movement is dystonia, in which a part of the body contracts and remains contracted. A foot cramp where the great toe extends while the other toes curl under is an example of a common dystonia. Alternatively, the face may become extremely distorted as one side contracts. The head can twist to one side. An arm or leg can become frozen in a contracted position. Dystonia can be caused by brain injuries or medication reactions. When you are watching the patient, does he or she move smoothly? This kind of motion requires proper functioning of the frontal lobe, cerebellum, brainstem, spinal cord, and peripheral nerves. When they are functioning correctly, muscle groups will alternately contract and relax, allowing the body to move smoothly. Patients with Parkinson's disease experience rigidity in which this fine balance is upset, so they move in fits and spurts. Tremors are another potential alteration in smooth motion. These fine oscillating, back and forth, movements are usually found in the hands and head. Rest. Tremors occur with the patient at rest, and not in motion. They are common in Parkinson's disease. Intention. Tremors occur when the patient tries to reach out and grab an object. These tremors may increase as the patient gets closer to the object to be grabbed. Intention tremors are common in multiple sclerosis. Postural. Tremors occur when a body part is required to maintain the same position for a long period of time. Most people have experienced this type of tremor when they were working hard for a long time. As they tire, their worked body parts begin to shake. A postural tremor can also occur when a person is standing, and the head oscillates back and forth. Patients with Parkinson's disease also experience these tremors. Seizures may appear very similar to tremors. Generally, tremors are fine movements, while seizures are larger, less focused types of movement. There are two basic types of movements that patients can perform while seizing. Tonic activity is a very rigid, contracted body posture. The arms, legs, neck, and back can contract so tightly that the body part will shake slightly from the intensity of the contraction. Clonic activity is a rhythmic contraction and relaxation of muscle groups. It may appear as bizarre, non-purposeful movements of any body part. Arms and legs may flail, teeth may clench, the head may bob, and the torso may move wildly. Sensation. Many neurologic conditions can alter the ability to feel pain, temperature, pressure, or light touch. A sensation of numbness or tingling is called paresthesia. If the patient can feel nothing within a body part, the condition is called anesthesia. Blood glucose level. Glucose is the fuel that runs the brain. The brain uses glucose faster than any other part of the body, but it has no means to store glucose. For this reason, all patients with a change in level of consciousness should have their blood glucose level checked. A normal blood glucose reading is 4 to 7 millimoles per liter. As glucose levels fall below 4 millimoles per liter, level of consciousness begins to decrease. Level of consciousness can also be affected by a high blood glucose level, although a significant increase is required before level of consciousness is altered. Glucose levels below 0.6 millimole per liter are incompatible with brain function, and typically lethal. Generally, if levels are below 2 millimoles per liter, confusion or unconsciousness will occur. Blood glucose monitoring is standard pre-hospital care for the patient with an altered level of consciousness. Chest. Evaluate the chest for deformities, contusions, abrasions, penetrations, burns, tenderness, lacerations, and swelling. Look for symmetry in its shape. Does the chest rise and fall equally? If not, this is called paradoxical chest movement. Apply the cardiac monitor and evaluate the electrocardiogram. Many cardiac dysrhythmias can cause neurologic disorders by decreasing the blood supply to the brain. Perform a 12-lead electrocardiogram in all patients with sudden loss of consciousness. How much effort must the patient make to breathe? Do you observe any degree of respiratory distress? Listen to lung sounds. Evaluate for the presence of adventitious sounds, and equality of sounds. Determine the pulse oximeter reading, remembering that normal readings are 95% to 100%, and that this number is affected by the amount of hemoglobin within the body, and the presence of carbon monoxide. Abdomen. Examine the abdomen for deformities, contusions, abrasions, penetrations, burns, tenderness, lacerations, and swelling. Do you note any masses? Are there any pulsations within the abdomen? Does the patient have any issues related to the abdomen? Signs of nausea and vomiting are common with some neurologic conditions, such as headaches or increased intracranial pressure. Pelvis. Examine the pelvis for deformities, contusions, abrasions, penetrations, burns, tenderness, lacerations, and swelling. Is it stable to stress? If the patient is able to walk without assistance, the pelvis should be stable. Does the patient have any incontinence? Urinary or fecal incontinence is a common finding with seizures or syncope. Incontinence also serves as a relatively objective marker for the severity of the unconsciousness. When we sleep, we are not incontinent. Thus, if incontinence is present, the level of consciousness has decreased below that of sleep. Extremities. Examine the limbs for deformities, contusions, abrasions, penetrations, burns, tenderness, lacerations, and swelling. Do you see any signs of edema? Look for venipuncture marks and note whether these marks are at various stages of healing. Such marks may indicate recent illegal drug use. Ongoing assessment. The ongoing assessment is intended to monitor patients for changes. Talk with them. Ask them how they are feeling. Ask about their children. Ask if they caught the game last night. Casual conversation will allow you to closely monitor brain functions. It also communicates a caring environment. If the patient is nonverbal, keep a close eye on respiratory patterns and eye and body movements, and monitor for seizure activity. Routine monitoring should include heart rate, electrocardiogram, blood pressure, respiratory rate and pattern, pulse oximetry, and repeat glucose, if the level was low and sugar was given to the patient. Continue oxygenation and ventilation support. Monitor intravenous lines closely to ensure that accidental fluid overload does not occur. If the patient's condition undergoes a sudden dramatic change, repeat the rapid assessment and detailed physical examination as if this were a new patient. This will give you a chance to modify your pre-hospital care to manage the new development. General management. This management guideline should be followed with all patients who experience a change in level of consciousness. The focus of pre-hospital care for neurologic patients is directed at ensuring that the body has an adequate internal environment to allow for optimal brain function. The three major elements that the brain needs to function are oxygen, glucose, and normal temperature. The general management techniques discussed in this section, the standard pre-hospital care, serve as the foundation on which additional pre-hospital care for specific neurologic problems is built. These general steps will be discussed in further detail later in the chapter. 1. As always, provide for standard precautions and scene safety. 2. Evaluate the patient's airway and effectiveness of breathing. If necessary, secure the airway, and provide ventilatory support to make sure oxygen saturation remains higher than 90%. Routine hyperventilation of neurologic patients can be harmful, so provide hyperventilation only to those patients with documented unresponsiveness and signs of increased intracranial pressure and impending herniation. 3. Establish intravenous access, and then administer normal saline or lactated ringer solution. Consider drawing blood samples for later analysis at the hospital. Do not use solutions containing dextrose. Check the patient's blood pressure and heart rate. Support hypotension to ensure adequate cerebral perfusion pressure. The target is a systolic blood pressure of 110 to 120 millimeters of mercury. 4. Continuously monitor the patient on an electrocardiogram. Perform 12-lead electrocardiogram monitoring if permitted to do so. 5. Check the blood glucose level. If it is low, administer dextrose 50%, 25 grams intravenous push. Be very cautious when you cannot check the patient's blood glucose level. Proceed with additional dextrose cautiously, based on responses to previous doses. Hyperglycemia can increase the morbidity rate among stroke patients. 6. Look for the hallmarks of increased intracranial pressure. In patients who are unresponsive and demonstrate other signs of increased intracranial pressure, ensure a systolic blood pressure of 110 to 120 millimeters of mercury. Administer fluids as needed. Unless you are concerned about possible cervical spine fracture, elevate the head 30 degrees. Provide ventilatory support at 16 to 20 breaths per minute. Avoid unnecessary hyperventilation as this will cause excessive drops in arterial carbon dioxide concentrations, resulting in vasoconstriction and decreased perfusion to the brain. Ensure that the airway is clear, but do not suction vigorously. Stimulating the cough and gag reflexes will increase intracranial pressure. 7. A patient with increased intracranial pressure may be bradycardic. Atropine and pacing are not indicated, however, due to the systolic hypertension that accompanies the bradycardia. The intracranial pressure is causing the bradycardia, not the reverse. Instead, notify the hospital and provide rapid transport. 8. Check for drug use. If the patient may have taken an opioid, consider administering naloxone, 0.4 to 2 milligrams intravenous push. Watch for seizures. If the seizure is prolonged, administer a benzodiazepine, midazolam or lorazepam. 9. Evaluate the patient's temperature. If it is low, cover the patient, turn on the heat, and prevent heat loss. If it is high, remove clothing, cover the naked patient in a sheet, and turn the heat off in the patient compartment. 10. Provide emotional support for the patient and family. Neurologic emergencies can produce confusion, fear, anger, and helplessness. Consider giving a therapeutic, gentle touch on the shoulder. Touch can communicate compassion. Use a calm, reassuring voice to show that you are there to help. Try to reorient the patient, as confusion is often present in these cases. Administration of dextrose or glucose. Follow your local protocol regarding what blood glucose reading is considered low. One guideline to consider is if the blood glucose level is below 4 millimoles per liter, then the patient needs glucose. Two medications are available for the pre-hospital treatment of hypoglycemia, dextrose and glucagon. When administering dextrose 50% in water intravenous solution, you must establish an intravenous line. This access site should be within a large vessel, 18 gauge or larger is preferred, because dextrose 50% in water intravenous solution is quite thick. Ensure that the intravenous line is patent before you attempt to give the dextrose 50% in water intravenous solution. Extravasation of dextrose 50% in water intravenous solution into the interstitial space can cause severe damage to muscles, nerves, and skin or even death. The effects of dextrose typically begin within 30 seconds to 2 minutes. If the dextrose has no effect or if the patient's blood glucose level remains low, then ensure adequate intravenous access, and administer a second dose. Chapter 32. Endocrine Emergencies, discusses administration of dextrose in further detail. Glucagon can be administered if you cannot obtain intravenous access. Glucagon, 0.5 to 1 mg, is given intramuscularly. This naturally occurring body chemical is responsible for converting the body's stores of glycogen into glucose. If the patient has adequate glycogen stores in their liver, you should see an increase in the level of consciousness and blood glucose level within 20 minutes of administration. If the blood glucose level remains low, you may consider repeating to a maximum of 3 doses. Finally, be cautious in patients whose blood glucose level cannot be checked. If the patient is unresponsive or has decreased level of consciousness, and no blood glucose monitor is available, then administer 12.5 grams, 1/2 syringe, of dextrose 50% in water intravenous solution, and then reassess the patient for response. Proceed with additional dextrose cautiously, based on responses to previous doses. Hyperglycemia can increase the morbidity of patients who have had a stroke. You may need to give thiamine, vitamin B1, before administering dextrose 50% in water intravenous solution. Patients who are severely malnourished, such as chronic alcoholics, may have insufficient supplies of vitamin B1 to adequately metabolize dextrose. Thiamine allows the body to convert its store of glycogen into glucose as part of the Krebs cycle. The typical dose in an emergent situation is 50 mg via slow intravenous bolus and 50 mg intramuscularly, with higher doses in the setting of Wernicke's encephalopathy. Thiamine can cause hypotension if administered too quickly. If you cannot obtain vascular access, administer 0.5 to 1 mg of glucagon subcutaneously or intramuscularly. The level of consciousness and blood glucose levels should increase within 20 minutes after administration. If the blood glucose levels remain low, repeat the glucagon to a maximum of 2 doses. If the blood glucose level is high, then be aware that no safe way to decrease blood glucose in the pre-hospital setting currently exists. Administration of insulin can be problematic because it is easy to overcorrect the imbalance, resulting in a hypoglycemic state. Ensure adequate support of blood pressure. Patients with hyperglycemia are often dehydrated and may need volume resuscitation. Note that rehydration alone in a severely dehydrated patient with hyperglycemia can dramatically lower the patient's blood glucose level. Oral glucose administration is another option for the patients with a decreased level of consciousness who can swallow safely. Assess these patients carefully, confirming that they are awake enough to follow commands. First, give them a small amount of water to drink, say, 10 milliliters. If they can swallow that amount, then consider administering 1 tube of oral glucose, depending on the supplier, 15 to 30 grams. Alternatives to oral glucose include cake icing, a plain chocolate bar, without nuts, or orange juice with sugar added. Administration of sugar by mouth will take longer to raise blood glucose levels. Constantly supervise patients as they consume the sugar. Make sure they do not aspirate. Airway management. Sometimes patients may not be able to adequately protect the airway or ventilate themselves. The use of a bag mask device, supraglottic airway, laryngeal mask airway or king larynx and trachea, combi tube, or tracheal intubation should be initiated to provide sufficient oxygen, ventilation, and airway protection in such cases. Tracheal intubation is the most effective means by which you can isolate and protect the trachea from aspiration. Ensure that the pulse oximeter reading is higher than 90%. Provide oxygen via nasal cannula or mask as necessary. Provide ventilatory assistance as needed. If the patient has trismus, determine how effectively the patient can be ventilated with a bag mask device. If ventilation is poor or unsuccessful, you may attempt to place a nasotracheal airway. If this is unsuccessful, consider using a paralytic agent to relax the mouth and allow for airway management. If paralytics are not available or contraindicated and the patient cannot be ventilated, transtracheal airway management is the only option to prevent hypoxia and death. Administration of naloxone. Naloxone, Narcan, is used for the treatment of unresponsive patients with suspected opioid overdose. The initial dose is 0.4 to 2.0 milligrams intravenous push. You may need to administer additional doses, potentially exceeding a total of 10 milligrams, in the setting of a synthetic or high-potency opioid. This opioid antagonist will compete with any circulating opioid, displacing it from its receptors, and allowing the level of consciousness to increase. Naloxone can have quite a dramatic effect. Patients with a Glasgow Coma Scale score of 3 can move to a score of 15 within 30 seconds. This rapid change in level of consciousness may cause patients to become fearful and potentially angry or aggressive. Make sure that you have adequate resources to restrain the patient or that you have the ability to leave the scene quickly before you administer naloxone. It may be advisable to push the drug in small increments until an improvement in level of consciousness or respiration is noted. If the medication does not produce a response, then intubation may be needed. Some EMS systems are modifying or restricting use of naloxone use to decrease the risks of precipitating opioid withdrawal seizures in opioid-dependent patients, and improve paramedic safety due to patients emerging from opioid-induced states in a violent manner. You are advised to consult your local and regional protocols, and exercise caution in naloxone use. Airway management in relation to the opioid overdose can also be tricky. Airway and ventilation are the focus of much of the pre-hospital care provided to unconscious patients. When you encounter a severely bradypneic, cyanotic patient, you reflexively want to establish an airway and intubate the patient quickly. When considering administering naloxone, however, a slightly different approach is recommended. Ensure airway control and adequate ventilation, but do not immediately intubate the patient. As you are oxygenating the patient, establish an intravenous line, and administer the naloxone carefully. Given the drug's quick onset of action, and the potential for a dramatic response, an intubated patient may quickly wake up after the naloxone, grab the tracheal tube, and yank it out. The result of this violent extubation may be vocal cord or tracheal trauma. If the medication does not produce a response, then intubation may be needed. Temperature assessment. The patient's temperature can be difficult to determine in the pre-hospital environment. If you suspect hypothermia or hyperthermia, the standard of pre-hospital care is to use a thermometer to establish the patient's temperature. Oral, otic, transdermal, or rectal temperature can be measured. Avoid using the axillary method of measurement due to its inaccuracy. While most EMS systems have the capability to check a patient's temperature, some may not. In such a situation, you can still gather information about the history of present illness that can lead to a conclusion of temperature alteration. Was the patient in water for a long period of time? Has the patient been out in the snow? Did the patient fall and lie on the floor of a cold home, unable to get up for several days? In these cases, hypothermia should be considered. It would be reasonable to cover the patient in blankets and turn the heat up in the patient compartment. Has the patient been out in the hot sun for several hours? Is the skin hot and dry? Is there a history of fever? In these cases, it would be prudent to remove the patient's clothing, place a sheet over him or her, and at least turn the heat off in the patient compartment. Assessment and management of specific injuries and illnesses. Table 31-6 will help you better classify specific neurologic conditions based first on the part of the nervous system they affect, and then on the type of condition. One way to manage these conditions is to try to create a patient profile that describes the circumstances that typically characterize a particular disease. How old is the typical patient? What sex and race is the patient? What are the common signs and symptoms of the condition? Are any unusual signs present that are uncommon in other conditions? How does the condition develop over time? If the patient profile indicates that men are most commonly affected by the condition, remember that women may also experience it. The patient profile is intended to distill the condition down to its core elements. You can use this valuable system to create flashcards that you can study. This summary of typical age, sex, race, history of present illness, signs and symptoms, and treatment will be provided for each condition discussed in the remainder of this chapter. Stroke. A cerebrovascular accident or stroke represents a serious medical condition in which the blood supply to areas of the brain becomes interrupted, resulting in ischemia. Many patients who experience brain attacks or strokes deny their symptoms, and many will not activate emergency medical services, and subsequently delay seeking pre-hospital care. The goal of treatment is early recognition and rapid, appropriate intervention. The longer the cerebrovascular accident continues without intervention, the less likely the patient will have a promising outcome. Hence the phrase, time is brain. Two basic types of strokes are distinguished, ischemic and hemorrhagic. Figure 31-19 provides some insight into the evolution of strokes. About 4 in 5 strokes are ischemic rather than hemorrhagic. In ischemic stroke, a blood vessel is blocked, so the tissue distal to the blockage becomes ischemic. Eventually, that tissue will die if blood flow is not restored. This pathology is self-limiting, only the tissue beyond the blockage is affected, so the areas of the brain involved are limited. The signs and symptoms eventually stop increasing, and then plateau, indicating that the area of the brain involved is no longer working. The extent and severity of the stroke will be dictated by which artery is involved, and which portion of the brain is denied oxygen. An ischemic cerebrovascular accident to the brainstem is life-threatening. In contrast, hemorrhagic cerebrovascular accidents tend to worsen over time due to bleeding within the cranium. This bleeding may increase intracranial pressure, and lead to herniation of the brainstem. One hallmark of a hemorrhagic cerebrovascular accident is the worst headache of my life report. If the patient reports a very severe headache, later cannot speak, becomes difficult to arouse, and finally shows signs of increased intracranial pressure, you should strongly consider diagnosis of hemorrhagic cerebrovascular accident. Patients with a suspected stroke or transient ischemic attack, discussed in the next section, are usually older than age 65 years. Although men have more strokes, women die from them more often. First Nations and Inuit experience a greater rate of stroke than other groups within the population. Presentation. Patients with stroke can exhibit a variety of signs and symptoms. Language effects may include slurred speech, aphasia, agnosia, and apraxia. Movement effects, hemiparesis, hemiplegia, arm drifting, facial droop, ptosis, and ataxia, may be observed as well. Sensation effects may include headache, in hemorrhagic cerebrovascular accidents, sudden blindness, and sudden unilateral paresthesia. Consciousness problems, such as decreasing level of consciousness, difficulty thinking, seizures, and coma, may be noted. The patient may also develop hypertension. The hospital will take different paths of care for each type of stroke. In any event, speedy treatment is essential. For ischemic strokes, fibrinolytic medications must be administered within 4.5 hours of onset of symptoms. In hemorrhagic stroke, the more the patient bleeds into the cranium, the greater the potential for increased intracranial pressure and brainstem damage. Pre-hospital management. The Heart and Stroke Foundation of Canada, the American Heart Association, and the American Stroke Association have established goals for the management of patients with suspected stroke. Key in this is the need to educate the general public about the signs and symptoms of stroke. The public then needs to call 911 so trained dispatchers can send the appropriate pre-hospital resources. As a paramedic, you need to have adequate training in the delivery of care to patients with strokes, including which patients would benefit from a stroke center. There are a variety of screening tools that paramedics can use to identify a patient with suspected stroke. After the patient arrives in the emergency department, a coordinated and comprehensive approach to care is essential. Some patients will benefit from fibrinolytics, some need intra-arterial clot removal, and others may need neurosurgery. After care has been delivered, and the stroke mitigated, appropriate rehabilitation needs to be considered to ensure the patient returns to the highest quality of life possible. Pre-hospital care of the stroke patient should begin with the standard pre-hospital care outlined previously. Ensure adequate airway, breathing, and circulation, and blood pressure. Standard stroke care includes titrating oxygen therapy to the patient's need. Evaluate the patient's pulse oximetry to maintain a pulse oximetry level of 94% to 99%. Ensure your pulse oximetry reading is accurate. Use other assessment techniques to ensure your patient does not need large amounts of oxygen. From a respiratory point of view, if the patient is in stable condition, then the nasal cannula is probably sufficient. Establish the patient's glucose level, and treat in keeping with your local or regional protocols. Establish intravenous access in case fluids or medications are needed. During the assessment phase, use a stroke assessment tool, such as the Cincinnati Pre-Hospital Stroke Scale, the Los Angeles Pre-Hospital Stroke Screen or Ontario Paramedic Prompt Card for Acute Stroke Protocol, to increase the accuracy of your working diagnosis. Rapid identification is imperative. Several recent clinical trials have established embolectomy as the standard of care for patients with severe stroke who present with emergent large vessel occlusion. Unfortunately, delays in the pre-hospital and emergency department phases of care can delay time to embolectomy, the treatment effect for which is time-dependent. With the advent of designated stroke centers now providing endovascular capabilities to permit embolectomy 24 hours a day, pre-hospital systems have developed methods to identify those stroke patients who may be experiencing emergent large vessel occlusion. Figure 31-21 illustrates the FastVan pre-hospital assessment tool to identify patients paramedics will transport to a center capable of embolectomy. While this is not currently available across Canada, it demonstrates the integral role paramedics and the pre-hospital system play in timely access to stroke care. If your pre-hospital assessment identifies a patient with a suspected stroke, and local or regional protocols permit bypassing the closest hospital, you should take your patient to a designated stroke center to enhance their chance of improved outcome. In some cases, pinning down the exact time the stroke began can be very difficult, such as with patients who live alone. In those cases, ask family or care providers when the patient last seemed normal. If possible, transport a family member or significant other who can speak to staff at the receiving hospital. If your local or regional protocols include a fibrinolytic checklist, perform it en route to the hospital. There are no standardized guidelines for the pre-hospital control of hypertension. Do not administer aspirin. Aspirin is helpful in patients with ischemic stroke but is harmful in patients with hemorrhagic stroke. Therefore, aspirin should be withheld, and only administered after obtaining a computerized tomography or magnetic resonance imaging study. Because neurologic patients may be unable to feel or move their arms or legs, make sure to protect them from injury. Transient ischemic attack. A transient ischemic attack is an episode of cerebral ischemia that does not inflict any permanent damage. Any of the typical presentations associated with a cerebrovascular accident can occur with transient ischemic attacks, but the transient ischemic attack signs and symptoms resolve within hours without any residual damage to brain tissue. This means you may be dispatched for a patient having symptoms of a stroke, but arrive to find a patient who appears perfectly normal. Do not let a normal-looking patient diminish the potential threat. These mini-strokes are often signs of a serious vascular problem that requires medical evaluation. More than one-third of patients with transient ischemic attacks will experience a cerebrovascular accident soon afterward. As with strokes, management of transient ischemic attacks begins with standard pre-hospital care. Follow the same management guidelines as for cerebrovascular accidents. Close neurologic assessment is needed. Patients may experience multiple transient ischemic attacks in a short time frame, coming and going. Strongly encourage the patient to be transported. If he or she refuses transportation, appeal to the patient's family for assistance. Encourage the patient to seek medical care very soon. It is important to reinforce the message that the transient ischemic attack is a warning sign of a very serious and potentially deadly problem with the blood vessels within the brain. In fact, hypertension is the #1 preventable cause of strokes and transient ischemic attacks. Encourage the patient to talk with his or her doctor about blood pressure control, and to take any antihypertensive medications prescribed. Altered level of consciousness or coma. Altered mental status has many possible causes, so these calls are relatively common. One way to remember the most common causes is to use the mnemonic AEIOU tips: alcohol or acidosis, epilepsy, insulin, overdose, uremia, trauma, infection, psychosis, and stroke. As with most medical issues, the history of present illness is vital to identifying the underlying cause of the patient's concerns. An easy approach is to determine when the patient was last seen functioning normally. Presentation. Evaluate the speed of onset for the altered level of consciousness. This may help distinguish its cause. It is very rare that a person would be absolutely healthy 1 minute and be unresponsive from infection the next, for example. By contrast, seizures can cause unresponsiveness almost instantly. The common signs and symptoms for altered level of consciousness or coma include the following. Cognitive effects. Decreasing level of consciousness, confusion, hallucinations, delusions, psychosis, difficulty thinking, and sleepiness. Speech effects. Slurred speech, agnosia, apraxia, and aphasia. Movement effects. Ataxia, aphasia, seizures, and posturing. General central nervous system effects. Total unresponsiveness, coma. Pre-hospital management. In the case of altered level of consciousness, pre-hospital care proceeds in 2 stages. First, you need to support vital functions, including securing and maintaining airway, breathing, and circulation. Second, you need to gather information about the possible cause of the altered level of consciousness. Determine past medical history, evaluate medications, look for signs of trauma, and determine the history of present illness. Does the patient have a medical alert tag? Was drug paraphernalia found near the patient? How was the patient acting before you were called? In-hospital care will focus on supporting airway, breathing, and circulation and attempting to discover the underlying problem. Patients will routinely need blood and urine specimens, radiographs, and computerized tomography, and magnetic resonance imaging studies. Seizure. Seizures involve sudden, erratic firing of neurons. Patients who have epilepsy commonly have seizures, for example. Patients may experience a wide array of signs and symptoms when having seizures, ranging from one hand shaking or having a metallic taste in the mouth to movement of every limb or the complete loss of consciousness. They may be aware of the seizure, or they may wake up afterward not knowing what happened. If a seizure continues for a long period, then profound changes occur within the brain and body. Cerebral glucose and oxygen supplies can be depleted. Systemic, body-wide, hypoxia, hypercapnia, blood pressure changes, and hyperthermia can occur. A single, short-duration seizure is typically not a major life-threatening concern. However, if seizures group together and/or last for long periods, then these complications can cause serious long-term effects to the patient, including death. It is also not uncommon for emergency medical services personnel to be dispatched for a seizure patient, only to arrive and find a patient in cardiac arrest. What happened? The patient experienced a lethal dysrhythmia, blood pressure dropped, blood flow to the brain dropped, and subsequently, the patient seized. If time permits, you should try to determine the cause of the seizure. In particular, ask about medication compliance. phenytoin, dilantin, lorazepam, ativan, carbamazepine, tegretol, and valproic acid, dipakine, are common anticonvulsant medications, but patients may be taking them at insufficient levels to prevent seizures. Patients may feel that they are cured because they have not had a seizure in many months, and stop taking their medications. Children may outgrow their anticonvulsant dosage. Older patients may be unable to afford the medication. In infants, a common cause of seizure is fever, febrile seizure. Patients with diabetes may have low blood glucose levels, and consequently seize. Knowing the cause will help direct management. Table 31-11 lists many of the causes of seizures. Classification of seizures. Seizures can be classified as generalized, affecting large portions of the brain, or partial, affecting a limited area of the brain. The classifications of seizures are outlined in Table 31-12. Within the category of generalized seizures are the tonic-clonic and absence types. Tonic-clonic seizures. Tonic-clonic seizures, also called grand mal seizures, present you with the most challenges. Most tonic-clonic seizures follow a pattern, traveling through each of the following steps in order, although some patients may not experience every step. 1. Aura. A sensation the patient experiences before the seizure occurs, for example muscle twitch, funny taste, seeing lights, hearing a high-pitched noise. 2. Loss of consciousness. 3. Tonic phase. Body-wide rigidity. 4. Hypertonic phase. Arched back and rigidity. 5. Clonic phase. Intermittent contraction of major muscle groups, arms, legs, head movement, lip smacking, biting, clenched teeth. Contractions are chaotic, disorganized, and of small amplitude. 6. Post-seizure. Major muscles relax, and nystagmus may still be occurring. Eyes may be rolled back. 7. Postictal. Reset period of the brain. This can take several minutes to hours before the patient gradually returns to the pre-seizure level of consciousness. During this time, patients are often initially aphasic, unable to speak, confused or unable to follow commands, very emotional, and tired or sleeping. They may present with a headache. Gradually the brain will begin to function normally. During the seizing process, respirations may become very erratic, loud, and obviously abnormal. Alternately, the patient may stop breathing and become cyanotic. These periods of apnea are usually very short-lived and do not require assistance. If the patient is apneic for more than 30 seconds, immediately begin ventilatory assistance. Another disconcerting aspect of seizures, particularly for the patient, is incontinence. Absence seizures. In contrast to tonic-clonic seizures, absence seizures present with little or no movement. The typical patient with absence seizures is a child. Classically, the child will simply stop moving, he or she may be walking, and just stop, may be speaking and stop mid-sentence, or may be playing and freeze with a toy in the hand. The child will rarely fall. These seizures usually last no more than several seconds. There is no postictal period, and no confusion. These may be brought on by flashing lights or hyperventilation. Partial seizures. Partial seizures may be classified as either simple partial or complex partial. Partial seizures involve only a limited portion of the brain. They may be localized to just one spot within the brain, or they may begin in one spot and move in wave-like fashion to other locations. Such a Jacksonian march wave is akin to the ripples that occur from dropping a pebble in a still pond. Simple partial seizures involve either movement of one part of the body, frontal lobe, or altered sensations in one part of the body, parietal lobe. An example of a Jacksonian march in a simple partial seizure would be shaking of the left hand, which moves to the left arm, then to the shoulder, then to the head, then to the right arm, then to the right hand, and finally stops. Complex partial seizures involve subtle changes in level of consciousness. The patient may become confused or less alert, have hallucinations, or become unable to speak. Small movements of the head or eyes may occur. Patients typically do not become unresponsive. Pseudoseizures. Pseudoseizures, or psychogenic non-epileptic seizures, are a generalized neurologic event. Symptomatically, you may not notice any difference from a tonic-clonic seizure. Tonic-clonic motion, loss of consciousness, and a postictal phase are all present during these events. The difference is that in pseudoseizures, the root cause is of psychiatric origin. It is important to understand that in most cases of pseudoseizure, the patient is not intentionally causing this behavior. Patients with pseudoseizures present with loss of consciousness, which is usually triggered by some emotional event, stress, lights, or pain. Pseudoseizures conspicuously occur with witnesses. This fact may lead healthcare providers to believe pseudoseizures are contrived. Motion that occurs during the seizure is relatively organized, side-to-side movement of the head, pedaling movements of the legs, like riding a bicycle, weeping, or stuttering. These patients often have a psychiatric history and/or other medical history, such as fibromyalgia, chronic pain, or chronic fatigue. Pre-hospital management. Most seizures are self-limiting, so you simply need to monitor and protect patients from injuring themselves. Pre-hospital management of patients with seizure begins with standard pre-hospital care. Quickly determine whether trauma is a concern. Where was the patient before the seizure? What was the patient doing before the seizure? How did the patient get to the current position? If the situation is unclear or there is confirmed trauma, perform spinal motion restriction. Other important characteristics of your assessment of a patient with a seizure are listed below. How long did the seizure last? What did it look like to bystanders or family? Describe the seizure as best as possible, unique body motions, regions of the body involved, body positions, etc. Does the patient have a history of seizures? How many seizures does the patient normally have in a day or week? How long do they last? What do they look like? Is the patient taking anti-seizure medication as prescribed? Have any recent changes to medications occurred? Were any medications administered by bystanders? Does the patient have a recent history of head trauma, overdose, pregnancy, diabetes, hypoglycemia, or heat exposure? Does the patient have a fever? Was the patient apneic, cyanotic, and/or vomiting? Did the patient experience bowel or bladder incontinence? If you arrive during the seizure, then do not restrain or try to stop the seizing movement. Remain calm and prevent the patient from striking objects and becoming injured. Do not place anything in the patient's mouth while the patient is seizing. If bystanders have placed objects, for example spoons, butter knives, in the mouth, remove them. If you believe the event is a pseudoseizure, then treat it like any other seizure. Do not dismiss this behavior as a patient acting out. Correct hypoglycemia by giving intravenous glucose as needed, otherwise, most seizures are self-limiting. Provide ventilatory assistance only if the seizure or apnea is prolonged. Ventilation of the actively seizing patient will be very difficult. Oral or nasotracheal intubation will be next to impossible during a seizure. After the seizure, emotional support is very important. Provide privacy. Speak calmly and slowly. Be prepared to repeat yourself. Reorient the patient to place and time. If a child is febrile, encourage parents to administer a drug for fever reduction, acetaminophen or ibuprofen. Unless a clear and easily reversible cause for the seizure is found, all patients should be transported because seizures can be a warning sign of more serious nervous system problems. If the patient has a known history of seizures, he or she may not wish to go to the hospital. Advise the patient to follow up with the family doctor within 24 hours. A patient with diabetes who is awakened after glucose administration may not wish to be transported. Advise this patient to eat a good meal, and follow up with the family doctor. Any patient who you suspect could seize should have the following pre-hospital care. Establish intravenous access. Benzodiazepines, such as diazepam, lorazepam, or midazolam, are the drugs of choice to stop seizures. In patients who are seizing, and in whom intravenous access cannot be established, Midazolam can be administered intramuscularly at a dose of 0.2 mg per kilogram intramuscularly, maximum dose, 10 mg intramuscularly. Place blankets over the rails of the ambulance stretcher. Place blankets over hard surfaces near the patient. Ensure that the patient's stretcher straps are not too tight. It may be difficult to differentiate a seizure from a stroke. Consider your assessment findings and the past medical history. Patients with a history of seizures can have similar seizure patterns over time. Family can therefore anticipate what will happen. When a patient has a seizure caused by a stroke, however, it is unlikely that the pattern will be the same as that of the patient's baseline seizure. That difference can be a clue. Talk to the patient's family members and friends and determine whether the current seizure is the same as his or her typical seizure. Table 31-13 provides additional guidelines for differentiating between a seizure and a stroke. In-hospital management will seek to identify the cause of the seizure. Blood studies, including drug and blood glucose determinations, will be done. Computerized tomography scans or magnetic resonance imaging may be obtained. Status epilepticus. Status epilepticus is a seizure that lasts for longer than 4 to 5 minutes or consecutive seizures that occur without consciousness returning between seizure episodes. This time frame is arbitrary, however, and some research suggests that status epilepticus does not occur until 20 to 30 minutes of uninterrupted seizing. Status epilepticus is a life-threatening neurologic disorder, and it should not be taken lightly, as the mortality rate for patients in refractory status epilepticus can be as high as 70%. Refer to your local protocols for guidelines on how long a seizure can continue before you should intervene. During a seizure, neurons are in a hypermetabolic state, using huge amounts of glucose and producing lactic acid. For a short period, this state does not produce long-term damage. If the seizure continues, however, the body cannot remove the waste product effectively or ensure adequate glucose supplies. Such a hypermetabolic state can result in neurons being damaged or killed. The goal of pre-hospital care is to stop the seizure and ensure adequate airway, breathing, and circulation. Ensure the patient does not have hypoglycemia, and administer a benzodiazepine. These medications may be administered via several routes depending on the drug, although rectal administration is no longer recommended. See Table 31-14 for more information about anti-seizure medications. Generally speaking, if 2 doses of a benzodiazepine have not stopped the seizure, you should contact medical control. This guideline applies to all doses, whether they were administered by family or emergency medical service providers. Be prepared to completely control airway and ventilation, as benzodiazepines can cause respiratory depression and arrest. Continue to use airway positioning and bag mask device ventilations until the seizure stops. If benzodiazepines do not quickly control the seizure, and the patient cannot be ventilated, paralytics may be needed to allow for adequate airway management. Syncope. Syncope, fainting, is the sudden and temporary loss of consciousness with accompanying loss of postural tone. It affects mainly adults and accounts for nearly 3% of all emergency department visits. The brain uses glucose at a high rate, and has no ability to store glucose, so even a 3 to 5 second interruption in blood flow can cause loss of consciousness. The question then becomes, what caused the sudden decrease in cerebral perfusion? Table 31-15 lists the common causes of syncope. Presentation. Classically, the patient with syncope is in a standing position when the event occurs. With young adults, the pattern is usually one of vasovagal syncope. The person will experience fear, emotional stress, or pain. Suddenly the room will seem to spin, and the person will pass out. This is why you should always seat a patient before drawing blood or starting an intravenous line. In older adults, cardiac dysrhythmia is a more typical cause of syncope. The patient experiences a sudden run of ventricular tachycardia, the blood pressure drops, and the person falls to the floor. Once the rhythm terminates, the blood pressure rises, and the person regains consciousness. In either case, the whole process takes less than 60 seconds. Patients with syncope usually experience prodrome, signs or symptoms that precede a disease or condition. For syncope, prodromal issues include feelings of dizziness, weakness, shortness of breath, chest pain, headache, or visual disturbances. Incontinence is possible with syncope, though uncommon. Seizures and syncope can be difficult to differentiate. Table 31-16 provides some guidelines for making this distinction. Pre-hospital management. Begin with standard pre-hospital care. Determine if the patient may have experienced trauma during the fall, and take cervical spine precautions as needed. Focus on blood glucose level, and likely cardiac causes. Obtain orthostatic vital signs, and monitor cardiac rhythm continuously, if possible. If the patient is symptomatic and blood pressure remains low, provide fluids or vasopressors as appropriate, based on the cause of the hypotension. Provide emotional support, as syncope can be very embarrassing. Because you will not know the cause of the syncope, transport the patient to the hospital. Headache. Almost everyone has experienced a headache at one time or another. What exactly is hurting? The brain and skull do not have pain receptors. Instead, headache pain originates from the nerves within the scalp, face, blood vessels, and muscles of the neck and head. Several types of headaches may be identified. Muscle tension headaches, the most common type, are caused by life stress, tension, that results in residual muscle contractions within the face and head. The pain tends to occur on both sides of head and travels from back to front. It is a dull ache or squeezing in nature. The jaw, neck, or shoulders may be stiff or sore. Migraine headaches are thought to be caused by changes in blood vessel size within the base of the brain. The patient may experience an aura, for example seeing bright lights, and unilateral, focused pain that then spreads over time. The pain is throbbing, pounding, or pulsating in nature. Nausea or vomiting may be present. These patients prefer dark, quiet environments. Migraines can last several days. Cluster headaches are rare, vascular headaches that start in the face. They occur in groups or clusters. They last only 30 to 45 minutes, but a patient may have several each day. The headaches may recur for days, and then stop entirely. They may return the next month. The pain, described as sharp and excruciating, or as if someone is pushing the eyeball out, quickly intensifies and spreads to one side of the face. It is unclear what triggers these headaches, but serotonin and histamine may play a role. The headaches are often accompanied by anxiety. Sinus headaches are caused by inflammation or infection within the sinus cavities of the face. The pain, which is located in the superior portions of the face, increases with bending the head forward. It is worse when first waking. The patient may have postnasal drip, a sore throat, and nasal discharge. Other, rare types of headaches include those caused by tumors, inflammation of the temporal artery, strokes, central nervous system infections, or hypertension. Their presentations vary depending on the underlying cause. When you care for a patient with a headache, be cautious because headaches can indicate a more serious condition. If other signs indicate that a stroke may be in progress, then treat the patient for stroke. Remember, a patient who reports the worst headache of his or her life may be having a stroke. Try to determine the patient's level of stress, possible infections, and history of headaches. The patient can have various locations and intensity of pain, and may have nausea, vomiting, or light and sound phobia. Give standard pre-hospital care. Consider stroke, abscess, tumor, hypertension, and central nervous system infections. Ask which medications the patient has taken. Many patients will appreciate a darkened, quiet environment, so do not use lights and sirens if transporting. Medications for pain management could include meperidine, morphine, and ketorolac. Most patients, however, do not require narcotics. Also consider dimenhydrinate, ondansetron, or other antiemetics for nausea or vomiting. In-hospital management will include analgesics and ruling out serious medical problems. Abscesses. Abscesses result when an infectious agent invades the brain or spinal cord. The bacteria or fungi then attack brain cells and destroy tissue. In response, the immune system attempts to kill the infectious agent but fails to do so. To prevent the bacteria or fungi from spreading, the body erects a barrier around the area. The area within the barrier contains the infectious agent, dead or dying brain cells, dead white blood cells, and white blood cells that continue fighting the infection. Over time, with the continued destruction of tissue, and the immune system's ongoing attempts to kill the agent, swelling can occur. The underlying cause of an infection within the brain may be an infection of the sinuses, throat, gums, or ears that has spread. The organism can also be injected during trauma to the head. Such an infection has two major consequences: damage to the brain tissue, and the presence of an abscess within the cranial vault that leads to increased intracranial pressure. These two factors may result in low or high-grade fever, persistent headache, often localized, drowsiness, confusion, general or focal seizures, nausea and vomiting, focal motor or sensory impairments, and hemiparesis. Abscess usually occurs in people younger than 50 years, and has a gradual onset. Pre-hospital management starts with standard pre-hospital care. Although no specific pre-hospital care is available for the abscess patient in the pre-hospital setting, you need to pay close attention for evidence of increased intracranial pressure. Look for changes in level of consciousness, respiratory patterns, and posturing. Notify the hospital of the critical nature of your patient. Take seizure precautions, and be ready to treat accordingly. In-hospital management will likely involve antibiotics, seizure precautions, and potentially surgical removal of the abscess. Multiple sclerosis. Multiple sclerosis is an autoimmune condition in which the body attacks the myelin sheath of the neurons in the brain and spinal cord, leading to areas of scarring. This disease is more prevalent in temperate regions than in tropical regions. Some evidence suggests that a trigger may cause the immune system to attack the myelin. This condition is typically diagnosed among relatively young people, between ages 20 and 50 years, so the initial episode can be especially disconcerting. The presentation of multiple sclerosis usually follows a pattern of attacks and remissions. The attacks can vary in intensity, and the remissions can vary in length. Patients may recover or have long-term issues. In the initial attack, double vision and blurred vision are common reports. Other symptoms include muscle weakness, impairment of pain, temperature, and touch senses, pain, moderate to severe, ataxia, intention tremors, speech disturbances, vision disturbances, vertigo, bladder or bowel dysfunction, sexual dysfunction, depression, euphoria, cognitive abnormalities, and fatigue during attacks. Pre-hospital management is supportive. Give standard pre-hospital care. In-hospital treatment will be directed at controlling the symptoms. There is currently no cure for multiple sclerosis. Neoplasm. For the purposes of this chapter, neoplasm is defined as cancer within the brain or spinal cord. Two basic types of cancer are identified: primary and metastatic. Primary neoplasms begin within the nervous system, while metastatic neoplasms begin in some other part of the body, gain access to the bloodstream or lymphatic system, and then take up residence within the nervous system. Lung and breast cancers are the cancers that most commonly metastasize to the central nervous system. Once mature, neurons no longer divide, so only rarely do they become cancerous. Primary central nervous system cancers are usually caused by mitosis errors in the support structures of the central nervous system. Headache, nausea and vomiting, seizures, changes in mental status, and stroke-like signs and symptoms are common in cases of neoplasm. The rate and intensity of these signs and symptoms depend on the cancer's growth rate and location. Patients may have months of headaches, or suddenly experience a seizure without any prior issues. Pre-hospital management is supportive. Watch for status epilepticus and increased intracranial pressure. All patients with new-onset seizures or chronic headaches that cannot be managed need medical evaluation. In-hospital management is complex and depends on the type of cancer and location. Dystonia. Dystonias are marked by severe, abnormal muscle spasms that cause bizarre contortions, repetitive motions, or postures. These movements are involuntary and often painful. The initial episode usually occurs before the patient is in his or her 40s. Sudden onset may be precipitated by stress or continuous use of a muscle group. Patients tend to have normal intelligence and no psychiatric medical history. Dystonia is both a sign and a condition. Some patients who take antipsychotic medications may experience a sudden onset of bizarre contortions of the face or body. This is considered a secondary dystonia. Primary dystonias occur for unknown reasons, although a defect in the body's ability to process neurotransmitters is thought to lie at the heart of this problem. Spasmodic torticollis is a primary dystonia in which the neck muscles contract, twisting the head to one side and pulling it forward or backward. The head then remains painfully frozen in that position. Pre-hospital management should focus on ruling out other problems such as seizures, strokes, or psychiatric medication reaction. If you suspect a dystonic reaction to antipsychotics, diphenhydramine is the drug of choice to stop the contraction. Unfortunately, this medication is ineffective in primary dystonias. Give standard pre-hospital care. Regardless of the underlying cause, dystonias are socially upsetting as patients suddenly twist and writhe uncontrollably. Providing compassionate pre-hospital care is critical. In-hospital management involves a variety of medication options to control the condition. There currently is no cure for dystonia. Parkinson's disease. In Parkinson's disease, the substantia nigra, the portion of the brain that produces dopamine, becomes damaged. Dopamine is the neurotransmitter that, among other things, ensures smooth muscular contractions. Parkinson's disease symptoms have a gradual onset that spans months to years. The initial signs are often unilateral tremors. Over time, as dopamine levels fall, more areas of the body become involved. Genetics play an important role in this disease. Activity resembling Parkinson's disease can be observed in head injuries, and some overdose patients, in which progression of the symptoms occurs more rapidly. The average age of onset is 60 years, and more men are affected than women. The classic presentation of Parkinson's disease includes 4 characteristics: tremor, postural instability, rigidity, and bradykinesia. Rest tremors and postural tremors are also common. Other symptoms include depression, difficulty swallowing, speech impairments, and fatigue. Prognosis is poor as the condition advances. Patients in later stages are at a much greater risk of death from aspiration, pneumonia, falls, or complications due to immobility. Pre-hospital management involves standard pre-hospital care and emotional support. In-hospital management will include levodopa, which may temporarily restore dopamine levels. Other medications, surgery, and modification of diet and exercise are also options. Trigeminal neuralgia. Trigeminal neuralgia, also called tic douloureux, is an inflammation of the trigeminal nerve, fifth cranial nerve. The trigeminal nerve receives sensory information from the face. The usual cause of trigeminal neuralgia is irradiation by an artery lying too close to the nerve. Over time, as the artery changes diameter to meet blood supply needs, this motion grates the myelin sheath off the nerve. With its insulation gone, the nerve may short out, causing pain without trauma to the area. Patients are usually older than 50 years, and more women are affected than men. Patients experience severe shock-like or stabbing pain, usually on one side of the face. These attacks can last for several minutes to several months. They may be triggered by touching the face, speaking, brushing the teeth, eating, putting on clothing, the wind, essentially any activity that stimulates the face. There is typically no loss of taste, hearing, or facial sensation with this condition. Likewise, there is no loss of motor control over the face, so facial droop, ptosis, and difficulty controlling the airway are very uncommon. Although not life-threatening, this condition can be quite debilitating. Patients experience severe pain. Some will stay indoors, eat softer foods, or stop washing their faces to prevent an attack. These patients need compassion and understanding. Pre-hospital care consists of standard care. Meperidine, morphine, or ketorolac may be indicated to help with pain management. Try to limit conversations to decrease facial movement. Administer oxygen if the patient is in respiratory distress or has a low pulse oximeter reading. Use of a nasal cannula or a non-rebreathing mask can instigate an attack. Even trying to administer blow-by oxygen could be painful to the patient. Long-term treatment for this condition is medication, carbamazepine or phenytoin, to calm the trigeminal nerve, and sometimes surgery to place a barrier between the nerve and the artery. Bell palsy. Bell palsy is a temporary paralysis of the facial nerve, seventh cranial nerve. The facial nerve controls the muscles on each side of the face, including those used in eye blinking and facial expressions such as smiling and frowning. It also controls the tear glands and the saliva glands. Finally, the facial nerve transmits taste sensations from the tongue. Patients typically experience a minor infection before Bell palsy appears. The attack is very sudden and can easily be confused with a stroke. Signs and symptoms include ptosis, facial droop or weakness, drooling, and loss of the ability to taste. This condition strikes all races and both sexes equally. It is more common in middle-aged people, between 15 and 60 years old. Bell palsy will often resolve within 2 weeks. Pre-hospital management involves standard care. Make sure that these patients are not experiencing a stroke. Complete a full assessment. When in doubt, treat the case as if it were a stroke. In-hospital treatment for Bell palsy includes corticosteroids, for example prednisone, and acyclovir, which helps manage viral infections. Amyotrophic lateral sclerosis. Amyotrophic lateral sclerosis, also known as Lou Gehrig's disease, is a disease that involves the death of voluntary motor neurons, for unclear reasons. One theory suggests that the body's immune system selectively attacks and kills these motor neurons. Some evidence indicates that genetics may play a role. Amyotrophic lateral sclerosis is more common in middle-aged men of any race. Initially, this condition is rather subtle and progresses without drawing notice. Fatigue, general weakness of muscle groups, and difficulty performing routine activities such as eating, writing, and dressing are early signs. Patients may also experience difficulty speaking. As amyotrophic lateral sclerosis progresses, the patient loses his or her ability to walk, move the arms, eat, and speak. The speed of progression differs for every patient. Because this condition affects only the motor neurons, patients remain completely aware of their surroundings. The typical person diagnosed with amyotrophic lateral sclerosis will die within 3 to 5 years. As the destruction of motor neurons continues, eventually patients are unable to breathe effectively without ventilatory assistance. Patients die of respiratory infections or other complications related to immobility. Pre-hospital treatment for these patients is standard care. Assess the ability to swallow and monitor the airway closely. Patients may be surrounded by a variety of home medical technology, including feeding pumps, intravenous pumps, long-term intravenous access ports, and ventilators. Transportation becomes complicated by the management of this technology. General guidelines include asking for guidance from the family or home healthcare provider related to the operation of the technology. If necessary, disconnect the patient from the technology after consulting medical direction and transport. In-hospital care for amyotrophic lateral sclerosis is geared towards supporting vital functions. Patients will undergo physical therapy to help strengthen their remaining neurons and muscles. Medications can be given to assist with some of the symptoms, however, there is no cure for amyotrophic lateral sclerosis. Guillain-Barré syndrome. Guillain-Barré syndrome is a rare condition that is rather scary for most patients. It begins as weakness and tingling sensations in the legs, which then moves up the legs and begins to affect the thorax and arms. It can quickly become severe and lead to paralysis. In fact, the transition from being able to walk and speak to needing a ventilator to breathe may take as little as several hours. Most patients will experience maximum muscle weakness and paralysis within 2 weeks. The cause of this condition is unclear, although some degree of immune response appears to be present. Patients usually report having a minor respiratory or gastrointestinal infection prior to the onset of weakness. One theory is that the infectious agent creates a situation in which the body attacks its own neurons. This attack damages the myelin, thereby causing shorting of the signals traveling along the axon. The reversal of this disease can be almost as dramatic as its onset. Some patients will have a complete recovery without residual weakness in as little as several weeks. About one-third retain some degree of weakness after 3 years. Some patients will require ventilatory assistance for the remainder of their lives. Pre-hospital management includes standard care and close assessment of the patient's ability to effectively protect the airway and ventilate. Monitor the patient closely with electrocardiogram and repeat vital signs. Continuous and tidal carbon dioxide readings can provide evidence of impending respiratory failure. Be prepared to administer intravenous fluids to maintain blood pressure and treat hemodynamically significant or symptomatic bradycardia. Because patients can experience a great deal of fear, a comforting voice and use of therapeutic touch are important. In-hospital management includes plasmapheresis, exchanging the plasma within the blood, and immunoglobulin injections. These therapies decrease the time until recovery. Poliomyelitis. Poliomyelitis is a viral infection that is transmitted by the fecal-oral route. Its incidence in Canada peaked in the post-World War II era of the late 1940s and 1950s. With the introduction of the Salk vaccine in 1955, the number of new polio cases in Canada declined dramatically. Polio vaccination has been available free to all Canadians since 1955, and the Americas were certified polio-free by the Pan American Health Organization in 1994. In May 1988, the World Health Organization set a goal to eradicate polio from the planet by 2000. Unfortunately, delivering and administering the vaccine to countries in conflict have hampered this goal, but vaccination rates have improved significantly. Wild poliovirus cases have decreased by over 99% since 1988, from, at that time, an estimated 350,000 cases in more than 125 endemic countries, to 33 reported cases in 2018. By early 2019, the virus has been reported in only 2 countries, Afghanistan and Pakistan. The World Health Organization's goal of eradicating polio is within sight. Most patients who contract the virus do not become ill. Polio can occur at any age, but very young and older patients are at greatest risk. Signs and symptoms may begin as soon as 1 week after infection. In the most severe cases, they include sore throat, nausea, vomiting, diarrhea, stiff neck, and weakness or paralysis of muscles. Pre-hospital management consists of standard care. In severe cases, patients will need ventilatory assistance. In-hospital care for patients with acute polio is directed at hydration, ventilation, and calorie support until the immune system gains control over the infection. The way the virus damages the nervous system places patients at risk for problems decades after the initial infection. In the initial infection, the virus attacks motor neurons within the brain and brainstem, which causes the classic signs of weakness and paralysis. The remaining neurons then begin to send out new axons to try to compensate for this loss, which allows the patient to regain function. Over time, these neurons maintain their unusually high workload. When they begin to break down and die, the patient may develop post-polio syndrome. Consequently, some patients who acquired polio in the early part of the 20th century, most are older than 60 years, are now having difficulty swallowing, weakness, fatigue, or breathing problems. Typically, wherever patients had symptoms when they were originally infected, they experience symptoms again, but in a milder form. Pre-hospital treatment is standard care, with emphasis on possible airway obstruction due to swallowing difficulties. In-hospital treatment includes physical therapy and experimental medications. Cerebral palsy. Cerebral palsy is a developmental condition in which damage is done to the brain, often the frontal lobe. Although it was believed that perinatal, around the time of birth, hypoxia was the primary cause, research has shown that this actually accounts for fewer than 10% of cases. Infections, jaundice, or Rh incompatibility also appear to be possible causes. The condition is self-limiting and does not worsen over time. Babies who are low birth weight, premature, delivered breech, or from multiple births, for example twins or triplets, are at higher risk for cerebral palsy. The presentation of cerebral palsy begins in infancy. Developmental milestones such as walking or crawling may be delayed. The type and extent of damage soon become apparent. In spastic cerebral palsy, 70% to 80% of cases, the muscles are in a near constant state of contraction. If both lower legs are affected, patients will have a classic scissors walk in which the lower legs turn inward, with the legs remaining stiff and the knees almost touching. Other types of cerebral palsy involve slow, uncontrolled writhing movements, tremors, or difficulties with coordination. Pre-hospital management is supportive. Provide standard pre-hospital care. Patients may have ambulatory assistive devices, for example wheelchairs, walkers, crutches, canes, leg braces, that will need to be transported along with them. In-hospital management is based on the patient's symptoms. There is no cure or correction for the damage. Instead, care is directed at maximizing the child's abilities through surgery on affected limbs, and physical and occupational therapy. Spina bifida. Spina bifida is a developmental condition resulting from a neural tube defect. Because the neural tube does not close, for unknown reasons, a portion of the spinal cord remains outside its normal location. The severity of the condition depends on where the defect lies on the cord, and how much it is displaced from normal. In spina bifida occulta, one small section of vertebrae is malformed and slightly displaced. The mildest form of spina bifida, it rarely has any significant clinical features and patients may not even know the malformation is present. In the most severe form, known as myelomeningocele, a portion of the spinal cord remains completely outside the vertebral column, and outside of the skin. There are also two intermediary forms of spina bifida. Consequences of spina bifida can range from no complications to complete loss of motor and sensory functions below the defect. Patients may have muscle problems ranging from mild defects to paralysis, experience seizures, or have severe neurologic impairments. In the most severe forms, the defect interferes with normal movement of cerebrospinal fluid. Cerebrospinal fluid is made within the brain, circulates, and is then reabsorbed. Hydrocephalus, water on the brain, is common in severe spina bifida because the cerebrospinal fluid continues to be produced but cannot circulate effectively. Pressure builds within the brain, causing increased intracranial pressure problems and seizures. EMS may be called for problems with spina bifida patients related to medical technology, seizures, trauma, or infections. Pre-hospital management is standard care. Be aware that many of these patients have latex allergies. In the most severe cases of spina bifida, children need multiple types of medical technology, including feeding tubes, long-term intravenous access, ventilatory support, ambulatory assistive devices, and intraventricular shunts, designed to drain excess cerebrospinal fluid from within the brain's ventricles. To avoid complications, consult with family and other home health care personnel when attempting to transport the patient. In-hospital management will be supportive. It is possible to reimplant the spinal cord, even while the fetus remains within the uterus, but the damage to the nerve tissue is permanent. Myasthenia gravis. Acetylcholine is an important neurotransmitter needed to allow muscular contraction. In myasthenia gravis, the body creates antibodies against the acetylcholine receptors. The thymus gland, where T cells mature, is believed to play a role in the production of these antibodies. As acetylcholine levels fall, muscle weakness begins. This weakness most commonly affects the eyes, eyelids, and facial muscles. Some patients will have difficulty swallowing or speaking, or leg or arm weakness. Patients sustain no sensory impairment. Myasthenia gravis usually affects women younger than 40 years and men older than 60 years. Myasthenia crisis is a sudden increase in the destruction of acetylcholine, resulting in weakness in the respiratory muscles. As a result, patients can become hypoxic. Infections, emotional stress, or reactions to medications can trigger this crisis. Standard pre-hospital care will effectively manage these patients in the pre-hospital environment. Be prepared to assist with ventilations in patients with crisis. In-hospital management includes removal of the thymus gland, medications to boost neurotransmitter levels, and immunosuppressants. Alzheimer's disease. Alzheimer's disease is the most common form of dementia. Dementia is a chronic deterioration of a person's personality, memory, and ability to think. Alzheimer's disease is a progressive organic condition in which neurons die. There is no definitive treatment for the destroyed neurons. Pre-hospital management is standard care. Peripheral neuropathy. Peripheral neuropathy comprises a group of conditions in which the nerves leaving the spinal cord become damaged. Consequently, the signals moving to or from the brain become distorted. Causes of peripheral neuropathy include trauma, toxins, tumors, autoimmune attacks, and metabolic disorders. Trigeminal neuralgia and Guillain-Barré syndrome are examples. The remainder of this discussion focuses on the most common form, diabetic neuropathy. Diabetic neuropathy is frequently seen in patients with diabetes older than 50 years. More men than women are affected. Its onset is gradual, occurring over months and years. As blood glucose levels rise, the peripheral nerves may become damaged, resulting in misfiring and shorting of signals. Affected people may then experience sensory or motor impairment. Loss of sensation, numbness, burning sensations, pain, paresthesia, and muscle weakness are common. Patients may eventually lose the ability to feel their feet or other areas. Management in the pre-hospital setting is supportive. Provide standard pre-hospital care. In-hospital management will include pain medication. The use of antidepressants and anticonvulsants seems to have a positive effect on calming the peripheral nerves. Muscular dystrophy. Muscular dystrophy is a non-neurologic condition of genetic origin marked by the degeneration of muscular tissue. The defective DNA causes an error in muscle tissue, such that the malformed muscle cells rupture more easily. Muscular dystrophy is diagnosed at age 2 to 5 years, and occurs only in men. Its onset is gradual, with progression over months to years. Several forms of muscular dystrophy exist, each distinguished by the involvement of a particular gene and a unique set of characteristics. Generally, muscular dystrophy presents with progressive muscle weakness, delayed development of muscle motor skills, ptosis, drooling, and poor muscle tone. The most common type of muscular dystrophy, Duchenne, manifests itself in childhood, and can include damage to the respiratory and cardiac muscles. These patients have a shortened life expectancy, rarely living beyond their middle 20s. They often die from pneumonia or cardiogenic shock. Standard pre-hospital care is effective in these patients. In severe cases, ventilatory support may be necessary. Blood pressure support may be required, fluids and dopamine may be needed to manage damaged heart muscle. These severely ill patients will have extensive use of home medical technology. In-hospital management is supportive, as there is no cure for muscular dystrophy. Conclusion. Patients with neurologic dysfunction can present a major challenge to the paramedic. To avoid becoming overwhelmed, follow a methodical and systematic approach to the assessment and pre-hospital care of these patients. Use the same format for all physical examinations. Focus your pre-hospital care on providing an environment that will facilitate optimal nervous system functioning. Reassess the patient after your interventions to note any changes. You are part of a healthcare team, so be aware of how your pre-hospital care will affect later activities within the emergency department. Know the material within this text. When you have mastered this information, you should be able to provide your patients with the highest level of pre-hospital care, and your profession with an example of excellence.
Chapter 30, Cardiovascular Emergencies. Introduction. Coronary heart disease, also known as heart disease, was the #1 cause of death in Canada until 2007, when it was surpassed by cancer, although it remains the most common cause of death globally. It was for the purpose of providing early, definitive treatment for patients with acute myocardial infarction, or heart attack, that the job of paramedic first came into being more than 30 years ago. Each year, about 159,000 Canadians are newly diagnosed with heart disease, and about 33,600 Canadians die of heart disease. Of those dying from acute myocardial infarction, approximately one-half die minutes to hours after the onset of symptoms before reaching a hospital or the emergency department. This chapter will prepare you to integrate pathophysiologic principles and assessment findings to formulate a field impression and implement the treatment plan for patients with coronary heart disease. You will first learn about the epidemiology of coronary heart disease in terms of its prevalence, mortality and morbidity, risk factors, and prevention strategies. After reviewing the anatomy and function of the cardiovascular system, the chapter covers some of the clinical manifestations of coronary heart disease. Emphasis is given to the interpretation of cardiac dysrhythmias and their management within the context of the patient's clinical condition. Finally, the chapter examines pharmacologic and other treatment modalities that make up advanced cardiac life support. Epidemiology. According to the Heart and Stroke Foundation of Canada, approximately 30% of adult deaths annually are caused by coronary heart disease, claiming a life every 7 minutes. The leading cause of hospitalization in Canada continues to be circulatory diseases, heart disease and stroke, accounting for 15.4% of all hospitalizations. Heart disease and stroke cost the Canadian economy more than $18 billion every year in physician services, hospital costs, lost wages, and decreased productivity. The many risk factors for coronary heart disease include advanced age, family history of coronary heart disease, gender, race, or ethnicity, diabetes, high blood pressure, elevated cholesterol and triglyceride levels, and carbohydrate intolerance. Family history is considered a risk factor for coronary heart disease if a first-degree male relative had coronary heart disease before age 55 years or a female relative had the same before age 65 years. It was previously thought that coronary heart disease was a man's disease, but in fact more women die of a cardiac event than men. Other factors contributing to coronary heart disease include unhealthy diet, obesity, smoking, oral contraceptive use, physical inactivity, stress, and personality type. People at low risk may ward off heart disease with a healthy lifestyle, but people at high risk should be treated using a combination of drug and non-drug therapies. This aggressive approach can reduce the risk of heart attack by 50%. Patients classified as being at intermediate risk may benefit from further testing for signs of atherosclerosis, which is an indicator of disease. Education and early recognition are also important prevention strategies. Making people aware of the risk factors and signs and symptoms of coronary heart disease may decrease its prevalence. This is an area of interest for paramedics who are involved in community health promotion. Table 30-2 lists factors for decreasing heart disease risks. Cardiovascular anatomy and physiology. Structure and function. The cardiovascular system is composed of the heart and blood vessels. Its primary function is to deliver oxygenated blood and nutrients to cells in the body. It is also responsible for delivering chemical messages, hormones, within the body, and for transporting the waste products of metabolism from the cells to sites of recycling or excretion. The heart. The driving force behind this extensive pickup and delivery service is the heart, a remarkable pump that sits in the chest, above the diaphragm, behind and slightly to the left of the lower sternum, retrosternal. The heart is not much larger than a fist, and weighs only 250 to 300 grams. Despite its relatively small size, it is strong enough to move 7,000 to 9,000 liters of blood around the body every day. On visualization of the chest, one may be able to see the apical thrust or point of maximal impulse. The point of maximal impulse is normally located on the left anterior part of chest, in the mid-clavicular line, at the fifth intercostal space. This thrust occurs when the heart's apex rotates forward with systole, gently beating against the chest wall, and producing a pulsation. Surrounding the heart is a tough, fibrous sac called the pericardium. The pericardium normally contains approximately 30 milliliters of serous fluid, which serves as a lubricant, that is, it enables the heart muscle, as it contracts and relaxes, to slide easily along the pericardium. The pericardium does not stretch readily, so it cannot accommodate sudden accumulations of fluid. Certain infectious processes, cancer, and trauma can lead to an abnormal accumulation of fluid within the pericardial sac. A small accumulation of fluid is referred to as pericardial effusion. A large accumulation of fluid that impairs systole is called pericardial tamponade. The wall of the heart consists of 3 layers, see Figure 30-1. The epicardium, the outermost surface layer, is a thin serous membrane. The endocardium is the innermost smooth layer of connective tissue. The myocardium is the muscular layer of the cardiac wall found between the epicardium and endocardium. Endocarditis is a rare but potentially serious infection of the internal linings and valves of the heart. People who have predisposing cardiac diseases may acquire this disorder. Myocarditis is a less severe infection of the myocardial tissues that may present with or without symptoms. Most people recover completely, but some die from heart failure. Like all cells in the body, myocardial cells require an uninterrupted supply of oxygen and nutrients. Indeed, the cardiac demand for oxygen is particularly unremitting because the heart never stops to rest, not without catastrophic consequences, so it is essential that the heart have an absolutely reliable blood supply. Oxygenated blood reaches the heart through the coronary arteries, which branch off the aorta at the coronary ostia, just above the leaflets of the aortic valve. There are two main coronary arteries, left and right. The left main coronary artery subdivides into the left anterior descending and circumflex coronary arteries, both of which branch widely to supply the more muscular left ventricle of the heart along with the interventricular septum and part of the right ventricle. The right coronary artery supplies the right atrium and ventricle and part of the left ventricle. The numerous connections, anastomoses, between the arterioles of the various coronary arteries allow for the development of alternative routes of blood flow, collateral circulation, in case of blockage. Unfortunately, the coronary arteries are also vulnerable to narrowing in atherosclerotic heart disease. When the lumen, channel, of one of those arteries becomes so narrowed that blood flow through it is impeded, the symptoms of angina occur. The arteries and the main coronary vein cross the heart in a groove, called the coronary sulcus, that separates the atria from the ventricles. Venous blood empties into the coronary sinus, a large vessel in the posterior part of the coronary sulcus, which in turn ends in the right atrium of the heart. Structurally, the heart consists of 4 chambers, see Figure 30-2. The upper chambers of the heart, or atria, are separated from their respective lower chambers, or ventricles, by atrioventricular valves, which prevent backflow during ventricular contraction. The tricuspid valve separates the right atrium from the right ventricle. The mitral valve separates the left atrium from the left ventricle. Anatomic guide wires, called chorditendinia, attached to papillary muscles within the heart, anchor those two valves, and keep them from inverting, prolapsing, during ventricular contraction. Injury or disease, however, may disrupt the chorditendinia and permit a valve leaflet to prolapse, allowing blood to regurgitate from the ventricle into the atrium. 2 other valves in the heart, which are collectively known as semilunar valves because of their half-moon shape, are found at the junction of the ventricles, and the pulmonary and systemic circulation. The pulmonic valve separates the right ventricle from the pulmonary artery, preventing backflow from the artery into the right ventricle. The aortic valve serves the same function for the left ventricle, preventing blood that has already entered the aorta from flowing back into the left ventricle. The cardiac cycle. The cardiac cycle comprises one complete phase of chamber relaxation, diastole, followed by contraction, systole. During the relatively longer relaxation phase, normally 0.52 second, the atria fill passively with blood, under the influence of venous pressure. Approximately 80% of ventricular filling also occurs during this time, as blood flows through the open tricuspid and mitral valves. With atrial contraction, normally both atria contract at the same time. The contents of each atrium are squeezed into the respective ventricle to complete ventricular filling. The contribution to ventricular filling made by contraction of the atrium is referred to as atrial kick. It is the amount of blood kicked in by the atrium during atrial systole. At the beginning of ventricular contraction, pressure in the ventricle becomes higher than in the atria, forcing the atrioventricular valves closed. The 2 ventricles continue contracting, ventricular systole, until ventricular pressure is higher than that in the pulmonary artery and aorta, forcing the semilunar valves open. Blood squeezed out of the right ventricle moves through the pulmonic valve, and into the pulmonary artery, while blood from the left ventricle is pushed through the aortic valve into the aorta. Systole is usually accomplished in a little more than one-half the time it takes to fill the ventricles, approximately 0.28 second. 2 pumps in 1. Although we called the heart a pump, that description is not entirely accurate. Functionally, the heart is actually 2 pumps, a weaker right pump, which circulates blood through the lungs, and a stronger left pump, which circulates blood throughout the rest of the body, separated by a thin wall, the interventricular septum. The 2 pumps just happen, for purposes of efficiency, to be housed in one organ. The right side of the heart, which is composed of the right atrium and right ventricle, is a low-pressure pump. It pumps against the relatively low resistance of the pulmonary circulation. The right atrium collects oxygen-poor venous blood from the venae cavae and the coronary sinus and pumps it into the right ventricle, which pumps the blood into the pulmonary artery for distribution to the alveoli and oxygenation in preparation for delivery to the left side of the heart. The pulmonary veins collect the now oxygen-rich blood and return it to the left side of the heart, specifically, to the left atrium, which pumps it into the powerful left ventricle. The left side of the heart is a high-pressure pump. It drives blood out of the heart against the relatively high resistance of the systemic arteries. Because there are 2 pumps, there must be 2 sets of tubing into which the pumps empty. Thus, the human body, in effect, has 2 circulations. The systemic circulation consists of all blood vessels beyond the left ventricle up to the right atrium, which receive the output of the left side of the heart. The pulmonary circulation comprises the blood vessels between the right ventricle and left atrium, which receive the output of the right side of the heart. At any given time, a major proportion of the body's blood flow may be shunted into one of these 2 circulations. If, for example, the right side of the pump fails and cannot squeeze out its contents efficiently, blood will back up behind the right atrium into the systemic veins, which then become engorged and distended. The most readily visible of the systemic veins are the external jugular veins, which reflect the condition of all the other systemic veins. Distension of the external jugular veins signals that there is considerable back pressure from the right side of the heart throughout the systemic circulation. As pressure increases within the systemic veins, fluid starts to leak into the surrounding tissues, causing the tissues to swell. When enough fluid has leaked into the interstitial spaces, that swelling becomes visible as edema in the subcutaneous tissues. It is less readily visible, but equally present, in the liver, walls of the intestine, and other internal tissues. By contrast, if the left side of the pump fails, blood backs up behind the left atrium into the pulmonary circulation. As pressure builds up in the pulmonary veins, fluid is squeezed into the alveoli, producing the characteristic signs and symptoms of pulmonary edema, dyspnea, bubbling crackles, and frothy sputum. Although the heart has 2 distinct pumping circuits, left and right, the heart functions as a single organ with a single conduction system. In other words, what affects one side of the heart will affect the other side. The blood vessels. The vascular component of the cardiovascular system is the blood vessels. There are 2 principal types of blood vessels in the human body, arteries and veins, both of which share a common structure. A protective outer layer of fibrous tissue, the tunica adventitia, provides blood vessels with the strength needed to withstand high pressure against their walls. A middle layer of elastic fibers and muscle, the tunica media, gives strength and contractility to blood vessels. This medial layer is much thicker and more powerful in arteries than in veins. The innermost layer of the blood vessel, the tunica intima, is a smooth inner lining that is only 1 cell thick. The opening within the blood vessel is referred to as the lumen. Arteries are thick-walled, muscular vessels, befitting pipes operating in a high-pressure system, that carry blood away from the heart. Usually, arteries carry oxygenated blood. The only exceptions are the pulmonary arteries, which carry oxygen-depleted blood from the right ventricle to the lungs, away from the heart. Arteries range in size from the largest artery in the body, the aorta, to the tiniest arterial branch, or arteriole. Figure 30-7 depicts the major arteries in the body. Arterial walls are highly sensitive to stimulation from the autonomic nervous system. Indeed, in response to that stimulation, their diameter may change significantly as the arteries contract and relax. In that manner, the arteries help to regulate blood pressure, that is, the pressure exerted by the blood against the arterial walls. Blood pressure is generated by repeated forceful contractions of the left ventricle, which keep blood flowing through the body. The magnitude of the blood pressure is influenced not only by the output of the heart and the volume of blood present in the system, but also by the relative constriction or dilation of arteries. Veins, which operate on the low-pressure side of the system, have thinner walls than arteries and, consequently, less capacity to decrease their diameter. The thinner walls also make the veins much more likely to distend when exposed to small increases in back pressure. Veins carry blood to the heart, as a rule, oxygen-poor blood. The only exceptions are the pulmonary veins, which carry oxygenated blood to the left side of the heart. The smallest veins, or venules, gradually empty into larger and larger veins, terminating in the two largest veins of the body, the inferior and superior venae cavae. Veins also contain valves, which are unnecessary in arteries. These valves keep the blood flowing in the forward direction only. Between the tiny arterioles and venules at the tissue level is a network of microscopic blood vessels called capillaries. The walls of capillaries are extremely thin, only 1 cell thick, enabling the exchange of gases and nutrients across them. The capillary diameter is so small that red blood cells must pass through them single file. The pump at work. To understand how the heart functions as a pump, it is necessary to learn the following technical terms. Cardiac output. The amount of blood that is pumped out by either ventricle. The left and right ventricles are approximately equal in interior size, so the two ventricles have relatively equivalent outputs. Normal cardiac output for an average adult is 5 to 6 liters per minute. Stroke volume. The amount of blood pumped out by either ventricle in a single contraction, heartbeat. Normally, the stroke volume is 60 to 100 milliliters, but the healthy heart has considerable spare capacity and can easily increase stroke volume by at least 50%. Heart rate. The number of cardiac contractions, heartbeats, per minute, in other words, the pulse rate. The normal heart rate for adults is 60 to 100 beats per minute. The volume of blood that either ventricle pumps out per minute equals the volume of blood it pumps out in a single contraction times the number of contractions per minute. Cardiac output equals stroke volume times heart rate. To meet changing demands, the heart must be able to increase its output several times over in response to the body's increased demand for oxygen, for example, during exercise. The cardiac output equation indicates that the heart can increase its output by increasing its stroke volume, increasing its rate, or both. In a mechanical piston pump, the stroke volume is a fixed quantity related to the distance traveled by the piston and the size of the cylinder. The heart, by contrast, has several ways of increasing stroke volume. One characteristic of cardiac muscle is that, when it is stretched, it contracts with greater force, to a limit, a property called the Frank-Starling mechanism. If an increased volume of blood is returned from the systemic veins to the right side of the heart or from the pulmonary veins to the left side of the heart, the muscles surrounding the cardiac chambers must stretch to accommodate the larger volume. The more the cardiac muscle stretches, the greater the force of its contraction, the more completely it empties, and, therefore, the greater the stroke volume. From the cardiac output equation, it is clear that any increase in stroke volume, with the heart rate held constant, will cause an increase in the overall cardiac output. However, this relationship among volume, stretch, and cardiac output continues only until the heart becomes overfilled and the muscle fibers become overstretched. At this point, further volume does not result in increased cardiac output. The pressure under which a ventricle fills is called preload and is influenced by the volume of blood returned by the veins to the heart. In situations of increased oxygen demand, the body returns more blood to the heart, preload increases, and cardiac output consequently increases through the Frank-Starling mechanism. In a diseased heart, the same mechanism is used to achieve a normal resting cardiac output, which explains why some diseased hearts become enlarged. The load or pressure against which the heart contracts to eject blood is called afterload. For the left ventricle, the afterload is equivalent to the pressure in the aortic arch. A rise in the systemic vascular resistance, constriction of the arteries, leads to a higher afterload, and the cardiac output can drop. That makes intuitive sense, for clearly it is harder to push fluid through narrower pipes. When the afterload is higher, either the cardiac output drops or the heart has to work harder, contract more vigorously, to maintain the same cardiac output. Increased cardiac work results in an increased oxygen demand. In a diseased heart, this may lead to cardiac ischemia or a lower stroke volume. A drop in the stroke volume due to a rise in the afterload, or due to a diseased heart, is represented by a drop in the ejection fraction, the percentage of the blood ejected from the ventricles. A sudden rise in the systemic vascular resistance, for example sudden hypertension, can impair the cardiac output and cause cardiac ischemia. This will result in a backup of blood in the left ventricle, and subsequently in the pulmonary circulation. This is a common cause in presentation of sudden pulmonary edema and heart failure. The heart can also vary the degree of contraction of its muscle without changing the stretch on the muscle, a property called contractility or inotropy. Changes in contractility may be induced by medications that have a positive or negative inotropic effect. The ventricles are never completely emptied of blood with any single beat. However, if the heart squeezes into a tighter ball when it contracts, a larger percentage of the ventricular blood will be ejected, thereby increasing stroke volume and overall cardiac output. Nervous system controls regulate the contractility of the heart from beat to beat. When the body requires increased cardiac output, nervous system signals increase myocardial contractility, thereby augmenting stroke volume. The heart can also increase its cardiac output, given a constant stroke volume, by increasing the number of contractions per minute, that is, by increasing the heart rate, positive chronotropic effect. As an example, consider a heart that has a resting stroke volume of 70 milliliters per beat, and a resting rate of 70 beats per minute. Cardiac output equals 70 milliliters times 70 beats per minute equals 4,900 milliliters. Suppose that the owner of that heart begins to exercise. Oxygen demand increases, and nervous mechanisms stimulate the heart to increase its rate. If, for example, the heart rate increases to 110 beats per minute without any change in the stroke volume, the cardiac output would increase as follows. Cardiac output equals 70 milliliters per beat times 110 beats per minute equals 7,700 milliliters per minute. The Frank-Starling mechanism is an intrinsic property of heart muscle, that is, it is not under nervous system control. By contrast, contractility and changes in heart rate are regulated by the nervous system. The electrical conduction system of the heart. Heart muscle is unique among body tissues because it can generate its own electric impulses without stimulation from nerves, a property known as automaticity. In addition, the heart is endowed with specialized conduction tissue that can rapidly propagate electrical impulses to the muscular tissue of the heart. The area of conduction tissue in which the electrical activity arises at any given time is called the pacemaker, because it sets the pace, that is, rate, for cardiac contraction. This system as a whole is termed the electrical conduction system. The dominant pacemaker. The sinoatrial node. Theoretically, any cell within the heart's electrical conduction system can act as a pacemaker. In the normal heart, however, the dominant pacemaker is the sinoatrial node, which is located in the right atrium, near the inlet of the superior vena cava. The sinoatrial node normally receives blood from the right coronary artery. If the right coronary artery is occluded, as in a myocardial infarction, the sinoatrial node will become ischemic. The subsequent death of the conduction cells will prevent the sinoatrial node from firing. The sinoatrial node is the fastest pacemaker in the heart. Electric impulses generated in this node spread across the two atria through internodal pathways, including the Bachmann bundle, in the atrial wall in approximately 0.08 seconds, causing the atrial tissue to depolarize as they pass. The blood supply to the sinoatrial node comes from a branch of the right coronary artery. From there, the impulse is moved to the atrioventricular node in the region of the atrioventricular junction, which includes the atrioventricular node and its surrounding tissue along with the bundle of His. The atrioventricular node serves as a gatekeeper to the ventricles. In 85% to 90% of humans, its blood supply comes from a branch of the right coronary artery. In 10% to 15%, it comes from a branch of the left circumflex artery. The conduction of the impulse is delayed in the atrioventricular node for approximately 0.12 seconds so that the atria can empty into the ventricles. Approximately 70% of the blood in the atria fills the ventricles by gravity, the remaining 30% comes from atrial contraction, atrial kick. Impulses pass through the atrioventricular node into the bundle of His, then move rapidly into the right and left bundle branches located on either side of the interventricular septum. Next, they spread into the Purkinje fibers, thousands of fibrils distributed through the ventricular muscle. It takes approximately 0.08 seconds for an electric impulse to spread across the ventricles, during which time the ventricles contract simultaneously. The effect on the velocity of conduction is referred to as the dromotropic effect. Some medications affect dromotropy. Depolarization and repolarization. Depolarization, the process by which muscle fibers are stimulated to contract, comes about through changes in the concentration of electrolytes across cell membranes. Myocardial cells, like all cells in the body, are bathed in an electrolyte solution. Chemical pumps inside the cell maintain the concentrations of ions within the cell, in the process creating an electric gradient across the cell wall. As a consequence, a resting, polarized, cell normally has a net charge of -90 mV with respect to the outside of the cell. When the myocardial cell receives a stimulus from the conduction system, the permeability of the cell wall changes through opening of specialized channels in such a way that sodium ions rush into the cell, causing the inside of the cell to become more positive. Calcium ions also enter the cell, albeit more slowly and through a different set of specialized channels, helping maintain the depolarized state of the cell membrane, and supplying calcium ions for use in contraction of the cardiac muscle tissue. This reversal of electric charge, depolarization, starts at one spot in the cell, and spreads in a wave along the cell until the cell is completely depolarized. As the cell depolarizes, and calcium ions enter, mechanical contraction occurs. If the cell remained depolarized, it could never contract again. Fortunately, the cell is able to recover from depolarization through a process called repolarization. Repolarization starts with the closing of the sodium and calcium channels, which stops the rapid inflow of these ions. Next, special potassium channels open, allowing a rapid escape of potassium ions, Ka+, from the cell. This helps restore the inside of the cell to its negative charge. The proper electrolyte distribution is then re-established by pumping sodium ions out of the cell and potassium ions back in. After the potassium channels close, this sodium-potassium pump, driven by adenosine triphosphate, helps move sodium and potassium ions back to their respective locations. For every 3 sodium ions this pump moves out of the cell, it moves 2 potassium ions into the cell, thereby maintaining the polarity of the cell membrane. To accomplish this task, the sodium-potassium pump moves ions against the natural gradient by a process called active transport, which requires the expenditure of energy. Table 30-3 summarizes the roles of the various electrolytes in cardiac function, and depicts the cardiac muscle fibers' electrical potential during the phases of the cardiac cycle. A myocardial cell cannot respond to an electric stimulus from the conduction system normally unless it is fully polarized. The period when the cell is depolarized or in the process of repolarizing, the so-called refractory period, consists of 2 phases. In the absolute refractory period, the cell is still highly depolarized and a new action potential cannot be initiated. In the relative refractory period, the heart is partially depolarized and a new action potential will be inhibited, but not impossible. Secondary pacemakers. The sinoatrial node normally has the most rapid intrinsic rate of firing, 60 to 100 times per minute, so it will outpace any slower conduction tissue. If it becomes damaged or is suppressed, any component of the conduction system may act as a secondary pacemaker. The farther removed the conduction tissue is from the sinoatrial node, the slower its intrinsic rate of firing. Thus, the atrioventricular junction will spontaneously fire 40 to 60 times per minute, whereas the ventricular Purkinje system, which is farther removed from the sinoatrial node, will spontaneously fire only 20 to 40 times per minute. Suppose that the sinoatrial node is damaged by ischemia, tissue injury caused by hypoxemia, and does not fire. When it fails to receive impulses from the sinoatrial node, the atrioventricular junction might then begin firing at its own rate. Thus, an electrocardiogram would show a junctional rhythm at a rate of 40 to 60 beats per minute. If both nodes fail to initiate an impulse, the Purkinje fibers will initiate an impulse, resulting in a ventricular rhythm at a rate of 20 to 40 beats per minute. Measuring the heart's electrical conduction activity. The electrical conduction events in the heart can be recorded on an electrocardiogram as a series of waves, segments, intervals, and complexes. Electrocardiogram ECGs will be discussed in more detail later in this chapter. The depolarization of the atria produces the P wave. It is followed by a brief pause as conduction is momentarily slowed through the atrioventricular junction. Next, the QRS complex occurs, representing depolarization of the ventricles. Repolarization of the atria and ventricles produces T waves. However, the atrial repolarization wave is small and is buried within the QRS complex, so it is not seen. The larger, ventricular T wave follows the QRS complex. What does a lead see when it looks at the heart? The word lead, as it is used in electrocardiography, can be somewhat confusing. Sometimes the word is used to refer to one of the cables and monitoring electrodes that connect the electrocardiogram machine to the patient, such as the right arm lead. A lead provides an electrical picture of the heart obtained from a specified vantage point. Think of a lead as a camera lens, only instead of capturing light, it captures electricity, and turns that electricity into a line on your electrocardiogram. If the electricity is moving from the sinoatrial node towards the lead, the line moves up, and is called positive. If it is moving away from the lead, the line moves down, and is called negative. This is why a QRS complex might be positive in one lead, and negative in another. The intervals between waves and complexes also have names. The PR interval is the distance from the beginning of the P wave to the beginning of the QRS complex. It represents the time required for an impulse to traverse the atria and atrioventricular junction and is normally 0.12 to 0.20 second, 120 to 200 milliseconds, 3 to 5 little squares on standard electrocardiogram paper. The ST segment is the line from the end of the QRS complex to the beginning of the T wave, the beginning of which is referred to as the J point. The ST segment should normally be at the same level as the baseline, isoelectric line. An elevated or depressed ST segment may indicate myocardial ischemia or injury. The RR interval is the time between two successive QRS complexes. It represents the interval between two ventricular depolarizations, and gives an indication of the heart rate. The autonomic nervous system and the heart. The autonomic nervous system is the part of the human nervous system that controls automatic, that is, involuntary, actions. Its importance can be gauged by considering the alternative. Suppose all body functions were solely under voluntary control. 60 times per minute, 24 hours per day, you would have to remind your heart to beat. 12 times per minute, 24 hours per day, you would be required to order your lungs to inflate and relax. You would have to warn your stomach that food was on the way, tell your pancreas and gallbladder to step up their activities, and urge your gut to speed up or slow down as necessary. Whenever you changed your level of activity, for example, during exercise, you would be forced to issue a complex series of orders to your cardiovascular system to ensure that cardiac output increased sufficiently to meet increased metabolic demands. Fortunately, These body functions are automatically accomplished without any conscious effort. As is often the case, the nervous system works better in pairs. Like a musical show comprised of actors and an orchestra, the voluntary nervous system and the involuntary, autonomic, nervous system work together and complement each other perfectly. The voluntary nervous system, the actors, allows a person's mind to consciously control the movement of muscles, while the autonomic nervous system, the orchestra, allows body functions to proceed smoothly in the background, without thought. As skilled as the orchestra is, it does not always function well without a conductor. The autonomic nervous system is unique in that it has two conductors, the sympathetic nervous system and the parasympathetic nervous system. The sympathetic nervous system takes care of such tasks as speeding up the heart, constricting blood vessels, and dilating the bronchi and pupils. The parasympathetic nervous system regulates the body's vegetative functions. It slows the heart rate and encourages digestion. Together, these two systems work together to direct the orchestra to play at the perfect pace. Figure 30-11 shows the organization of the human nervous system. Table 30-6 provides a review of the properties of the autonomic nervous system. Figure 30-12 shows where parasympathetic and sympathetic nerves originate, the craniosacral and the thoracolumbar section of the spine, respectively, and the end organs that they affect. The parasympathetic nervous system. As mentioned previously, the parasympathetic nervous system is concerned primarily with vegetative functions, and sends its messages mainly through the vagus nerve. Think of it as the rest and digest nervous system. The vagus nerve can be stimulated in a number of ways, including pressure on the carotid sinus, straining against a closed glottis, Valsalva maneuver, and distension of a hollow organ, such as the bladder or stomach. At times, the brain may sense that the heart should slow its pace, perhaps because pressure is being applied over the carotid sinus or a person is straining during a bowel movement. A message in the form of an electrical impulse will now travel down the vagus nerve to the place where the nerve abuts on the sinoatrial node of the heart. There, the electrical impulse causes the release of a naturally occurring chemical, acetylcholine. The parasympathetic nervous system derives its other name, the cholinergic nervous system, from this chemical. The acetylcholine then crosses over to the sinoatrial node of the heart and signals the sinoatrial node, indicating that the brain is calling for a slowing of the heart via a transmission through the vagus nerve. To ensure that the message is received and acted on, another acetylcholine molecule travels to the atrioventricular node of the heart. This action is, in effect, a reminder to the sinoatrial node to slow down, making sure no extra impulses get through to the ventricles. Following these actions, acetylcholine is escorted away by acetylcholinesterase. Acetylcholinesterase is an enzyme that breaks down acetylcholine so it can be recycled. A commonly used medicine that blocks the actions of the parasympathetic nervous system is atropine. In emergency medical services, atropine is used to block the vagus nerve, and thereby cause an increase in the heart rate. Suppose the heart is slowing, beating at a rate of 50 beats per minute, and you administer 0.5 mg of atropine intravenous. The atropine will travel through the bloodstream until it reaches the vagus nerve endings at the sinoatrial and atrioventricular nodes, where it blocks the binding of acetylcholine, thus resulting in the sinoatrial node speeding up. In other words, it releases the brakes that the parasympathetic nervous system is placing on the heart, allowing the rate to accelerate. The sympathetic nervous system. The sympathetic nervous system prepares the body to respond to various stresses. It is the fight or flight system mentioned earlier. The parasympathetic nervous system works well for routine activities such as keeping the heart beating during rest or coordinating digestion, but it provides no mechanism for the body to adapt to changing demands. By contrast, the sympathetic nervous system increases the heart rate, strengthens the force of cardiac muscle contractions, and provides other adaptive responses to ensure that the tissue's increased oxygen demands are satisfied with increased cardiac output. Suppose you start running to catch a bus. After a few seconds, your muscles will have used up all the oxygen and nutrients immediately on hand. The muscles, now lacking these nutrients, send a message to the brain, requesting an increase in the delivery of oxygen. In response to this need, the brain sends a message through the sympathetic nerves, passing through the thoracic and lumbar ganglia, ultimately arriving at the heart. Whereas the vagus nerve releases acetylcholine, sympathetic nerves convey their commands through release of norepinephrine. Norepinephrine travels to the sinoatrial node, atrioventricular node, and ventricles, spreading the command from the sympathetic nerves. To prevent a buildup of lactic acid, the heart speeds up, increasing cardiac output and, therefore, delivering more oxygen and nutrients throughout the body. When intense stimulation of the sympathetic nervous system occurs, a special hormone, epinephrine, may be mobilized to spread the alarm and command the heart to speed up. Epinephrine is produced in the adrenal gland, and is also called adrenaline, leading to the other name of the sympathetic system, the adrenergic system. Medications that act on the sympathetic nervous system. Medications that influence the sympathetic nervous system are classified according to the receptors with which they interact. A drug receptor can be visualized as analogous to the ignition switch in a car. When the proper key is inserted into the car's ignition, and turned, a predictable sequence of events follows. The battery sends a current to the starter and the spark plugs, which fire, combustion of gasoline and air occurs, and the engine starts. Although many keys may fit into a specific car's ignition, not every key that fits will turn and start the car, but all that do turn cause the same reaction. Likewise, the organs of a body have a number of ignition switches. In the sympathetic nervous system, those switches, or receptors, are labeled alpha and beta. Whenever one of those switches is activated by a key, a drug or hormone, a predictable sequence of responses will occur. The heart has one primary ignition switch for a beta agent. Any beta agent will have the same effect on the heart, that is, it will increase the heart's rate, force, and automaticity. The arteries, by contrast, have receptors for alpha and beta agents. An alpha medication will turn on the switch that causes vasoconstriction, a beta agent will activate the switch that causes vasodilation. Similarly, the lungs have alpha and beta receptors. Alpha agents do not have much effect on the lungs, at most, they cause minor bronchoconstriction. By contrast, beta agents, such as medications used to treat asthma, trigger significant bronchodilation. Figure 30-13 represents these concepts schematically. Drugs that have alpha or beta sympathetic properties are called sympathomimetic drugs because they mimic, the actions of naturally occurring sympathetic chemicals. If we know whether a sympathomimetic drug is an alpha or beta agent, we can predict the response by the heart, lungs, and arteries. Consider a pure beta agent such as salbutamol. Knowing how it acts can predict its effects. It increases the heart rate, chronotropic, dilates the bronchi, and dilates the arteries. Phenylephrine, neosynephrine, by contrast, has almost purely alpha effects, slight bronchoconstriction with marked vasoconstriction. It does have weak beta effects that are primarily arrhythmogenic. In reality, things are not always so simple. Although salbutamol and phenylephrine have almost pure beta and alpha effects, respectively, most other sympathomimetic drugs, such as dopamine and epinephrine, have mixed alpha and beta activity. Norepinephrine, Levophed, is chiefly an alpha agent, and its alpha effects predominate, because it also has some beta activity. However, it will have effects on the heart. Conversely, epinephrine, adrenaline, is chiefly a beta agent, and its beta effects predominate. Nevertheless, when administered in high doses, epinephrine will produce some alpha effects, especially on the arteries. Table 30-8 lists several sympathomimetic agents that are commonly encountered in the pre-hospital environment. Two of the drugs, norepinephrine and epinephrine, are also naturally occurring chemicals of the sympathetic nervous system. Their actions are the same whether they are produced in the body, and released from the nervous system or manufactured in a factory, and injected. Beta-sympathetic agents can be classified into two groups based on the subtle differences between the beta receptors in the heart and the lungs. Medications that act primarily on cardiac beta receptors are called beta-1, those that act chiefly on pulmonary beta receptors are called beta-2. The bronchodilator salbutamol is primarily beta-2, so it provides effective bronchodilation with fewer cardiac, beta-1, side effects. However, tachycardia is still a common side effect. Another class of drugs that acts on the sympathetic nervous system is the sympatholytic or sympathetic blockers. As their name implies, they block the action of sympathetic agents by beating them to the receptor sites, and preventing these agents from turning on the ignition. The receptor sites cannot distinguish a blocker from a stimulator until it is too late. With the blocker occupying the receptor site, the stimulating agent cannot get in to turn on the switch. Beta blockers occupy beta receptors in the heart, lungs, and arteries, as well as elsewhere in the body. Thus, beta agents, whether released from sympathetic nerve endings or given intravenously, cannot exert their full effects when a beta blocker such as metoprolol has been administered previously. The indications for the major autonomic stimulating and blocking agents can be deduced once you know the properties of the drugs, and the manner in which they interact with the autonomic nervous system. Atropine. Parasympathetic blocker, opposing the vagus nerve. It is used to speed the heart when excessive vagal firing has caused bradycardia. Norepinephrine. Sympathetic agent, primarily alpha, causing vasoconstriction. It is used to increase the blood pressure in hypotension, when hypovolemia is not a concern. Norepinephrine is particularly useful when hypotension is caused by vasodilation, neurogenic and septic shock. With prolonged use or high doses, it can cause critical limb ischemia from the intense vasoconstriction. It causes less tachycardia, and fewer dysrhythmias than dopamine, and so is generally preferred to dopamine. Epinephrine. Sympathetic agent with both beta and alpha effects, thus, it has chronotropic, dromotropic, and inotropic effects with direct cardiac stimulation and vasoconstrictor effects. Used for cardiac arrest to increase the automaticity of the heart and vasoconstriction. It is also the preferred agent for anaphylactic shock for all of its effects, bronchodilation, vasoconstriction, and increased cardiac output. May also be used for severe hypotension unresponsive to first-line agents, norepinephrine and dopamine. Dopamine. Sympathetic agent used at low, beta, doses to increase the force of myocardial contractions in cardiogenic shock. It also has alpha vasoconstriction effects at higher doses. Its dilation, beta, effects on renal and mesenteric arteries mean that dopamine may help to maintain urine flow and good perfusion to abdominal organs. Salbutamol. Sympathetic beta-2 agent that acts on the lungs. Used to induce bronchodilation in asthma, chronic obstructive pulmonary disease, and other bronchospastic conditions. Metoprolol. Sympathetic beta blocker, opposing the actions of beta-stimulating agents. It is used clinically to slow the heart rate in certain tachydysrhythmias, to decrease the pain of chronic angina, by decreasing the work of the heart, and to depress irritability in the heart, by decreasing the tendency of the heart to fire automatically. Its use is contraindicated in asthma. The sympathetic nervous system and blood pressure regulation. The body attempts to maintain a fairly constant blood pressure to ensure perfusion of vital organs. At any given moment, the blood pressure is influenced by the cardiac output, and the resistance, degree of constriction, of the arterioles. Blood pressure equals cardiac output times systemic vascular resistance. Thus, the blood pressure can be increased by increasing cardiac output, the systemic vascular resistance, or both. Under normal circumstances, the body balances flow and resistance to maintain a stable blood pressure, that is, alterations in one variable bring about compensatory changes in the other variable to restore blood pressure toward normal. Consider, for example, a situation in which cardiac output decreases suddenly, as in hemorrhage. The fall in cardiac output will inevitably lead to a fall in blood pressure unless the systemic vascular resistance is altered. The falling cardiac output activates the sympathetic nervous system, which in turn causes the arterioles to constrict. Vasoconstriction increases the systemic vascular resistance, thereby tending to restore the blood pressure back toward normal. In conditions of chronically high afterload, such as arteriosclerosis-induced high blood pressure, the left ventricle may become hypertrophied, increased muscle mass, to overcome the additional work. Myocardial hypertrophy from chronic hypertension results in a reduced chamber size, and thus a reduced stroke volume. Additionally, the heart may not be able to relax as well, leading to a reduced filling volume. Lastly, the hypertrophied muscle also has greater oxygen demand, and may be more at risk of cardiac ischemia. This additional work, along with changes in the heart, often lead to heart failure. Patient assessment. Patients experience a variety of symptoms when they have a cardiovascular problem. The most common reports are chest pain, dyspnea, fainting, palpitations, nausea, and fatigue. If the patient is pulseless or breathless, basic life support measures may be used. In some cases, advanced life support procedures may be necessary. This section reviews the organized approach to assessing patients by focusing on their cardiac and pulmonary systems. Note that the order of steps for performing a primary assessment differs depending on the type of cardiac patient. Whereas the order of steps in the primary assessment is normally ABC, assess airway, breathing, and circulation. If the patient is found unresponsive and is suspected of being in cardiac arrest, the order changes to CAB, first assess circulation, then airway and breathing. In this section, assume the patient is conscious, breathing, and has a pulse. Scene assessment. The primary assessment begins with sizing up the scene and ensuring scene safety. In addition, you should try to anticipate the need for other resources, such as extra personnel. As you enter the scene, you should also be looking for any clues that may help identify what might have brought on the potential problem, such as medications, alcohol, cigarettes, drug paraphernalia, and/or living conditions. One of the most important and widely used tools in the pre-hospital setting is the electrocardiogram monitor defibrillator. The electrocardiogram machine enables you to monitor and record 3 lead electrocardiogram tracings, record 12 lead electrocardiograms in the field, quickly identify suspected ST segment elevation myocardial infarction, and make sound transport decisions based on the electrocardiogram findings. The electrocardiogram monitor defibrillator also provides you with the ability to defibrillate, perform cardioversion, and perform transcutaneous pacing in the pre-hospital setting. Primary assessment. General appearance. Observe the patient's general appearance as you approach him or her, and assess for apparent life threats. The initial assessment is fairly consistent for all patients, but this discussion has a cardiac focus. Sometimes assessing the airway, breathing, and circulation can be accomplished easily by merely greeting the patient and introducing yourself, assuming that the patient can answer you. Determine the patient's level of consciousness based on his or her response to your greeting, and use the AVPU scale. Airway, breathing, and circulation. Determine the patency of the patient's airway. If the patient is talking to you, the airway is patent. The patient may be able to maintain an open airway or, depending on the level of consciousness, may need help with clearing obstructions, debris, blood, or teeth, by properly positioning the head under placing an airway adjunct. Note the rate, quality, and effort of a breathing, and consider initiating oxygen therapy at this time. Assessment of circulation is done primarily by checking the patient's pulse. For a responsive patient, you will typically check the radial pulse. If the patient is unresponsive, check the carotid pulse. While checking the pulse, note the rate, regularity, and overall quality. Is it weak, bounding, or irregular? While holding the patient's hand in yours, assess the skin color and condition. The skin is the largest organ of the body, so a good indication that the rest of the body is getting adequate circulation is that the skin and mucous membranes are pink and the skin is warm and dry. Is there edema, poor turgor, or skin tenting? The quality of skin on the legs can give clues to peripheral vascular disease. Is the skin shiny, waxy, and lacking hair? This indicates likely vascular disease, a risk factor for acute myocardial infarction. Transport decision. The primary assessment ends with making a load and go transport decision for your patient. Based on your findings to this point, you should be able to determine whether the patient requires immediate transport. If you are unsure, continue with the history and secondary assessment, and the correct decision may become apparent. History. During the focused history and physical examination, you will perform a focused assessment. This inquiry into the patient's medical history and a physical examination are based on the patient's chief complaint. The inquiry is also referred to as the history of present illness. The sample history is included in this assessment. In patients with acute coronary syndromes, the most common chief complaints are chest pain, dyspnea, fainting, palpitations, nausea, and fatigue. History of presenting illness. To understand the events and symptoms of this current illness or episode, start by asking open-ended questions regarding the history of the current event. Be sure to find out what was happening when the problem started, and what was done before your arrival. Explore the specific symptoms in more detail. Chest pain is often the presenting symptom of an acute myocardial infarction. The patient's description of the pain is important for assessing its significance. The OPQRST format can be used to elaborate on the patient's chief complaint. What is the onset or origin of the pain? That is, how did it begin, suddenly or gradually? Has anything like this ever happened before? P. What provoked the pain? That is, what, if anything, brought it on? Is it exertional or non-exertional? What was the patient doing at the time? Sitting in a chair. Changing a tire? Having an argument with the boss? Does anything make it worse? P also stands for palliation. What palliates the pain? Is there anything that makes the pain go away or get better? Patients with chronic coronary heart disease may take nitroglycerin for episodes of chest pain. Ask whether the patient did so and, if so, whether it helped. Q. What is the quality of the pain? That is, what does it feel like? Get the patient's narrative description. Dull, sharp, crushing, heavy, squeezing. Note the exact words the patient uses to describe the pain, and observe the patient's body language as he or she does so. Try not to lead the patient's description unless he or she is unable to describe the pain. In such cases, try to give alternatives, such as is it sharp or dull? R. Does the pain radiate? From where to where? To the jaw. Down the left arm. Into the back? S. What is the severity of the pain? That is, how bad is it? Use the pain scale of 1 to 10, with 10 being the worst. If the patient has chronic angina, ask him or her to compare the pain with the usual angina pain. T. What was the timing of the attack? That is, when did it start? How long did it last? What time did it get worse or better? Was it continuous or intermittent? Another chief complaint among patients with an acute coronary syndrome is dyspnea. In the context of acute coronary syndrome, dyspnea may be the first clue to failure of the left side of the heart. To explore this possibility, ask the following questions. When did the dyspnea start? Did it awaken the patient from sleep? Paroxysmal nocturnal dyspnea is an acute episode of shortness of breath in which the patient suddenly awakens from sleep with a feeling of suffocation. Often the patient will report going to a window to get more air or will move from the bed to a recliner. Paroxysmal nocturnal dyspnea is one of the classic signs of left-side heart failure, although it may also occur in chronic lung diseases. Did the dyspnea come on gradually or suddenly? Is it continuous or intermittent? Does it happen during activity or while at rest? Does any position make the dyspnea better or worse? The dyspnea of pulmonary edema usually worsens when the patient is lying down, orthopnea, because blood pools in the lungs when the body is horizontal. Patients with significant orthopnea will often sleep with several pillows, or even sitting in a recliner, to maintain a semi-upright position. Has the patient ever had dyspnea like this before? If so, under what circumstances? Does the patient have a cough? Is it dry or productive? Any fever or travel history to suggest an infectious, non-cardiac cause of symptoms? Were there any associated symptoms? Fainting, syncope, occurs when cardiac output suddenly declines, leading to a reduction in cerebral perfusion. Cardiac causes of syncope include dysrhythmias, increased vagal tone, and heart lesions. There are also numerous non-cardiac causes of syncope, discussed in Chapter 31, Neurologic Emergencies. As part of taking a history from someone who has fainted, try to sort out whether the patient fainted from cardiac or non-cardiac causes. Under what circumstances did the syncopal episode occur? What was the patient doing at the time? A 20-year-old who faints at the sight of blood is unlikely to have significant underlying cardiac disease. A 60-year-old who faints after feeling some fluttering in the chest may have a dangerous cardiac dysrhythmia. Were there any warning feelings before the episode, or did the fainting spell occur suddenly and unexpectedly? What position was the patient in when he or she fainted? Standing? Sitting? Lying down? A loss of consciousness while sitting or lying down has more ominous implications than fainting while standing up. Has the patient fainted before? If so, under what circumstances? Were there any associated symptoms, such as nausea, vomiting, urinary incontinence, or seizures? Finally, patients with cardiac problems may present with a chief complaint of palpitations. Palpitations refer to the sensation of an abnormally fast or irregular heartbeat. Except after extreme exertion, a person normally remains blissfully unaware of his or her heartbeat. The cause of palpitations is often a cardiac dysrhythmia, such as PVCs or paroxysmal supraventricular tachycardia. The patient may not use the word palpitations, but may report feeling the heart skip a beat or use words to that effect. In such a case, inquire about the onset, frequency, and duration of this symptom, and previous episodes of palpitations. Also ask about the presence of associated symptoms, such as chest pain, dizziness, and dyspnea. Patients may report a variety of other related symptoms as you explore their history of present illness. They may have a feeling of impending doom or a sense that they will soon experience a life-changing event. Some patients relate feeling nauseated or having vomited. Listen carefully for indications that trauma may be involved or that their activity has been limited as a result of their condition. Observe their faces as you listen to them tell their stories. Do you see a look of fear or anguish? Are they holding their chest? Most of the other associated issues your patients may have are related to hypoxia or poor perfusion resulting from inadequate cardiac output. For example, decreased level of consciousness, diaphoresis, restlessness, and anxiety, fatigue, headache, behavioral changes, and syncope. Past medical history, medications, and allergies. After exploring the patient's presenting illness and symptoms, inquire about pertinent aspects of the patient's past medical history and cardiac risk factors. Is the patient under treatment for any serious illnesses or conditions? Ask specifically whether he or she has ever been diagnosed with any of the following: coronary artery disease, atherosclerotic heart disease, angina, previous myocardial infarction, hypertension, high blood pressure, heart failure, valvular disease, aneurysm, pulmonary disease, diabetes, renal disease, vascular disease, inflammatory cardiac disease, previous cardiac surgery, such as coronary artery bypass graft or valve replacement, congenital anomalies. Is the patient taking any medications regularly? The focused history is a great opportunity to ask about which medications have been prescribed, and whether the patient is taking them as instructed. Be sure to ask when the patient took the medications last. Is he or she taking medications that were prescribed for someone else, borrowed? Also ask about any over-the-counter medications or any herbal supplements the patient uses. It may be appropriate to ask about recreational drug use. If you are unfamiliar with any medication, ask the patient what it was prescribed for. It is also a good idea to ask if the patient takes any medication for each medical condition he or she reports as part of the history, and to verify these medical conditions match the medications the patient is actually taking. Does the patient have known allergies to foods or medications? If so, ask what kind of reaction the patient has with each one. Ask the patient when he or she last had anything to eat or drink, and note the time that occurred. This information will prove helpful later in many situations. Vital signs. Pulse. When you take the vital signs, make a careful assessment of the patient's pulse. It is best to assess both radial pulses, right and left arm. Is it regular or irregular? Abnormally fast or slow? Strong or weak? An irregular pulse signals a disturbance in cardiac rhythm. A very rapid pulse, tachycardia, may simply indicate anxiety, but it can also occur secondary to severe pain, heart failure, or a cardiac dysrhythmia. A weak, thready pulse suggests a reduction in cardiac output. You should be familiar with the potentially abnormal pulse findings. For example, the patient may have a pulse deficit. A deficit occurs when the palpated radial pulse rate is less than the apical pulse rate or the left radial pulse is absent when the right is present. It is reported numerically as the difference between the two. To assess for a deficit, check the peripheral radial pulses, each in turn, while listening to an apical pulse. Another abnormal pulse finding is pulsus paradoxus. Pulsus paradoxus is an excessive drop, greater than 10 millimeters of mercury, in the systolic blood pressure with each inspired breath. Pulsus paradoxus can sometimes be palpated as a decrease in the amplitude of the pulse waveform, which makes the affected pulse beats feel weaker than the others. This observation can best be made when the rhythm is regular. If the variation is slight, it can be detected only by use of a blood pressure cuff and stethoscope. Finally, you might recognize pulsus alternans. This pulse alternates in strength from one beat to the next. Blood pressure. Hypertension is defined as an systolic blood pressure of 130 millimeters of mercury or greater or a diastolic blood pressure of 80 millimeters of mercury or greater and is an important risk factor for coronary heart disease. Patients with an systolic blood pressure of 120 to 129 millimeters of mercury are considered prehypertensive and need to adopt a healthier lifestyle to prevent coronary heart disease. In emergency situations, an elevated blood pressure may reflect the patient's anxiety or pain rather than chronic hypertension. The pulse pressure, the difference between the systolic and diastolic pressures, gives a rough indication of the elasticity of the arterial walls and the stroke volume. In patients with arteriosclerosis, the arterial walls are stiffened, and the pulse pressure is increased. In cardiogenic shock or cardiac tamponade, the stroke volume is reduced because the heart cannot pump effectively, so the pulse pressure is narrowed accordingly. A very low diastolic blood pressure may indicate a drop in systemic vascular resistance due to causes such as septic shock, anaphylaxis, or sedative drugs. Bilateral upper limb blood pressures should be obtained in all patients with chest pain. An aortic dissection or other vascular emergencies can cause the blood pressures between the right and left arms to be substantially different. A difference of greater than 20 millimeters of mercury should be considered abnormal and brought to the attention of the receiving facility personnel. Respirations. Note the rate and quality of the patient's respirations. Is the respiratory rate abnormally rapid, tachypnea? Is the patient laboring to breathe? Respiratory distress in a cardiac patient suggests the possibility of heart failure, with fluid in the lungs. Remember the saying, look, listen, and feel? In this physical examination, it is called inspection, auscultation, and palpation. Cardiac monitoring and pulse oximetry. As part of taking the vital signs, attach the cardiac monitor and pulse oximeter if you have not done so already. Use the electrocardiogram interpretation and oxygen saturation measurement just as you do other vital signs, that is, as tools to help you in your assessment, and not as the only guide to treatment. Treat the patient, not the monitor. Note that very low cardiac output may lead to a failure to obtain a pulse oximeter reading. This is a good clue to check for low cardiac output. When caring for a patient in relatively stable condition who does not require rapid assessment, the physical examination may be done at this point. Secondary assessment. The physical exam during the secondary assessment is similar for many medical patients. Nevertheless, certain aspects warrant greater emphasis in the patient whose chief complaint suggests a cardiac problem. When observing the patient's general appearance, pay particular attention to the level of consciousness, which is an excellent indicator of the adequacy of cerebral perfusion. If a patient is alert and oriented, the brain is getting enough oxygen, which in turn means the heart is doing its job as a pump. Conversely, stupor or confusion may indicate poor cardiac output, which may be the result of myocardial damage or dysfunction. Skin color and temperature are also valuable indicators of the state of the patient's circulation. The cold, sweaty skin of many patients with myocardial infarction reflects massive peripheral vasoconstriction. Physical examination. Begin the physical exam with inspection, auscultation, and palpation of the patient's respirations. Make note of the patient's respiratory difficulty, and classify it as none, mild, moderate, or severe respiratory distress. Inspect the neck and tracheal position. Is the trachea midline and mobile to gentle manipulation? Gently press down with your finger in the patient's suprasternal notch to verify that the trachea is midline. Also inspect adjacent structures such as the neck veins. The external jugular veins reflect the pressure within the patient's systemic circulation. Normally, they are collapsed when a person is sitting or standing. If the function of the right side of the heart is compromised, however, blood will back up into the systemic veins behind the right side of the heart, and distend those veins. To estimate the patient's jugular venous pressure, place the patient in a semi-fowler position, 45-degree angle, with the head slightly rotated away from the jugular vein you are examining. Observe the height of the distended fluid column within the vein, and note how far up the distension extends above the sternal angle. The normal jugular venous pressure is typically 2 to 4 centimeters above the sternal angle. Continue the assessment by inspecting and palpating the chest. Look for surgical scars that might indicate previous cardiac surgery. Is there a nitroglycerin patch on the patient's skin? Is there a bulge under the patient's skin indicating a pacemaker or an automated implanted cardioverter defibrillator? These devices are implanted just below the right or left clavicle, and are approximately the size of an $1 coin. Is the anterior-posterior diameter of the chest enlarged, as in a barrel-chested patient with chronic obstructive pulmonary disease? Listen carefully to the chest with your stethoscope. Crackles may be suggestive of left-side heart failure with pulmonary edema. Remember that wheezes may be a cardiac wheeze from pulmonary edema rather than bronchoconstriction from asthma or chronic obstructive pulmonary disease. Salbutamol is rarely beneficial in treating cardiac asthma, and may increase myocardial demands due to its mild beta-1 chronotropic effects, increase heart rate. Other aspects of the exam, peripheral edema, jugular venous pressure, vital signs, often severe hypertension, and history may help differentiate this. Examine the extremities and back for edema, a sign right side heart failure. Remember that right side heart failure can be caused by a backup of blood secondary to left side heart failure. Reassessments. Once the history and vital signs have been obtained, and the physical examination has been completed, continue treatment of the patient, and initiate transport. Reassessments are accomplished en route to the hospital. These begin with a repeated initial assessment, level of consciousness and airway, breathing, and circulation. The vital signs should be obtained every 5 to 15 minutes during this time as well. A repeated physical examination, including lung auscultation, should be accomplished to see if any changes have occurred or if any conditions were missed in the initial physical examination. Assess the effectiveness of all interventions implemented. For example, is the intravenous fluid still flowing or has the pain diminished after nitroglycerin administration? Prepare proper documentation of the call. Notify the receiving facility of any pertinent history findings, physical exam findings, and cardiac monitoring or electrocardiogram findings. Finally, part of the care of the patient with ST segment elevation myocardial infarction should involve transmitting the 12-lead electrocardiogram to the catheterization lab to shorten the interval from the arrival time to treatment time. Transmit your findings. Pathophysiology and management of cardiovascular problems. Atherosclerosis. Atherosclerosis is a thickening of the artery wall from the accumulation of fatty material and the secondary inflammatory response. Atherosclerosis is a chronic disease that remains asymptomatic for decades. It affects all arteries, but predominantly the coronary, renal, aortic, femoral, carotid, and cerebral arteries. It causes symptomatic disease from one of two main mechanisms. 1. Chronic gradual narrowing of the arteries can eventually cause ischemia from reduced blood flow, stable angina, leg claudication. 2. Acute infarction can be caused by acute plaque rupture and subsequent thrombus formation and occlusion of the artery, myocardial infarction. Atherosclerosis is of particular concern because it affects the inner lining of the aorta and cerebral and coronary blood vessels, leading to the narrowing of those vessels and reduction of blood flow through them. The atherosclerotic process probably begins in childhood, when small amounts of fatty material are deposited along the artery's inner wall, intima, usually at points of turbulent blood flow, such as where the arteries bifurcate or where the arterial wall has been damaged. As the streak of fat enlarges, it becomes a mass of fatty tissue, an atheroma, which gradually calcifies and hardens into a plaque. The atheromatous plaque infiltrates the arterial wall and decreases its elasticity. At the same time, the expanding atheroma narrows the arterial lumen and interferes with blood flow through the lumen, the hollow interior space within the artery. The narrowed, roughened area of the arterial intima provides a locus for the formation of a fixed blood clot, or thrombus, which may then obstruct the artery altogether. When such a clot forms in a coronary artery, it is known as a coronary thrombosis. In addition, calcium may precipitate from the bloodstream into the arterial walls, causing arteriosclerosis, a condition in which thickening and stiffening of the arterial walls greatly reduces the elasticity of the arteries. Atherosclerosis is the main underlying cause of the following conditions: angina, myocardial infarction, heart failure, aortic aneurysm and dissection, peripheral vascular disorders, and stroke. Coronary heart disease and angina. Coronary heart disease is the most common form of heart disease, and a leading cause of death in adults in Canada. The coronary arteries supply oxygen and nutrients to the myocardium. If one of these blood vessels becomes blocked, the muscle it supplies will be deprived of oxygen, ischemia. If this oxygen supply is not quickly restored, the ischemic area of heart muscle will eventually die, undergo infarction. Risk factors for atherosclerosis, coronary heart disease, and angina. Although atherosclerosis is widespread in industrialized countries, certain factors increase the risk of developing atherosclerosis and coronary heart disease: hypertension, high blood pressure, cigarette smoking, diabetes, high serum cholesterol levels, lack of exercise, obesity, family history of heart disease or stroke, and male gender. Clearly, these risk factors include factors beyond a person's control. We cannot, for example, select our parents and grandparents or choose to be born female. Nevertheless, we can address our modifiable risk factors. Diabetes increases your risk of coronary heart disease, cerebrovascular disease, peripheral vascular disease, and heart failure. Excessive alcohol consumption can raise blood pressure and triglyceride levels. According to Health Canada, women should limit alcohol intake to no more than 1 drink per day and men to no more than 2 drinks per day. High blood pressure is a risk factor for heart disease, stroke, and end-stage renal disease. Hypertension cannot always be prevented or cured, but it can be controlled with diet and medication. A diet high in saturated fat, trans fat, and cholesterol increases the risk of atherosclerosis and heart disease. The level of serum cholesterol is, at least in part, a consequence of dietary intake of saturated fat. In populations with low fat intake, the incidence of coronary heart disease is also low. Furthermore, lowering the serum cholesterol level has been shown to reduce the risk of heart attack. Cholesterol may also be controlled with medication, if necessary. Obesity is associated with an increased risk of heart disease. Patients with obesity have an increased likelihood of developing other coronary heart disease risk factors, including high blood pressure, diabetes, and high cholesterol. Weight reduction, by means of a sensible diet, and increased physical activity, can bestow several lifelong and life-extending benefits. Having a healthy body weight can lower the risk of coronary heart disease. People who are not physically active have a greater risk of coronary heart disease than do people who participate in regular physical activity. Such activity improves overall fitness, cardiac reserve, and collateral coronary circulation. It can also help reduce stress. Cigarette smoking is the most significant cause of preventable death in Canada, and a smoker's chances of sudden death are several times greater than those of a non-smoker. Tobacco use increases the risk of damage to the heart and blood vessels, thereby increasing the risk of atherosclerosis and acute myocardial infarction. The chemicals in cigarettes increase levels of fibrinogen, promoting clotting. Nicotine increases heart rate and blood pressure. The good news is that smokers who quit return rapidly to the same risk level as that of non-smokers. Because every person manages stress differently, researchers are not sure how stress increases the risk of heart disease. It is clear, though, that hormones such as epinephrine are released during times of stress. The release of epinephrine accelerates the heart rate, raises blood pressure, and increases the body's need for oxygen. Chronic stress exposes the body to persistent levels of epinephrine and increased blood pressure. The body's response to stress can also worsen other risk factors. For example, a person who is stressed may be less active, overeat, start smoking, or smoke more than usual. According to the Heart and Stroke Foundation of Canada, 9 in 10 adult Canadians, 90%, have at least one modifiable risk factor for heart disease or stroke, and 4 in 10, 40%, have at least 3 risk factors. The number of Canadians with hypertension, diabetes, obesity, and poor diet has increased in the last decade. The Heart and Stroke Foundation of Canada has numerous strategies aimed to inform Canadians that lifestyle modifications can reduce the risk of heart disease and stroke by up to 80%. Although the rate of modifiable risk factors has increased, improved primary and secondary prevention has lowered the rate of coronary heart disease and the mortality from coronary heart disease so that it is no longer the #1 killer in Canada. It has been surpassed by deaths due to cancer. However, the Heart and Stroke Foundation of Canada has reported that there are still an estimated 70,000 acute myocardial infarctions in Canada annually, although the mortality from acute myocardial infarctions, approximately 20%, or 16,000 annually, has declined by 5% in the last decade. Peripheral vascular disorders. Peripheral arterial disease. Atherosclerosis of the femoral and peripheral arteries can lead to reduced blood flow to the lower limbs. This can cause a variety of problems that are collectively referred to as peripheral arterial disease. This affects approximately 4% of people older than age 40 years in Canada. Symptoms and signs of peripheral arterial disease range from asymptomatic, skin changes and hair loss in the distal legs, foot and/or leg ulcers, claudication, pain or cramping in muscles due to reduced blood flow, to necrosis and/or gangrene of the limb. An acute pale, pulseless leg is a surgical emergency. Risk factors for peripheral arterial disease are the same as those for atherosclerosis: smoking, diabetes, dyslipidemia, hypertension, advanced age, male gender, obesity, associated history of coronary heart disease and stroke, and family history of vascular disease. Smoking is by far the biggest risk factor, and smokers have a higher risk of peripheral arterial disease than coronary heart disease. Management for chronic peripheral arterial disease focuses on risk modification, especially smoking cessation, regular exercise, and antiplatelet agents such as aspirin. Advanced peripheral arterial disease may need surgical treatment. Acute problems that may be encountered may relate to infected ulcers, necrotic toes, or acute or chronic limb ischemia. Pre-hospital management for these problems is usually limited to supportive care en route. Thromboembolism. Thromboembolism refers to blockage of a blood vessel by a blood clot that has become dislodged from another site in the circulation. Commonly, the clot develops in the peripheral venous system or the atria of a patient with atrial fibrillation. When it becomes dislodged, it can travel to an artery, causing obstruction that leads to ischemia and infarction. This can occur in the limbs and cause limb ischemia, occur in the brain and cause an ischemic stroke, or occur in the pulmonary arteries and cause pulmonary embolism. In Canada, approximately 50,000 patients are diagnosed with serious pulmonary embolisms annually, leading to approximately 5,000 deaths. In-hospital treatment of pulmonary embolism involves ensuring airway, breathing, and circulation support, treatment with anticoagulants, and possibly thrombolysis. Surgical retrieval of the clot is occasionally done. Pre-hospital treatment of thromboembolism primarily involves supportive care. Stable angina. The principal symptom of coronary heart disease is angina pectoris, literally choking in the chest. Angina is the sudden pain that occurs when the supply of oxygen to the myocardium is insufficient to meet the demand. As a result, the cardiac muscle becomes ischemic, switching to anaerobic metabolism. This altered metabolism leads to the accumulation of lactic acid and carbon dioxide. Understanding the concept of supply and demand is crucial here. At rest, a person with heart disease who remains sedentary may have an adequate supply of oxygen to the myocardium despite some narrowing of the coronary arteries. However, when the same person exercises or experiences some other physiologic stress, blood flow to the myocardium may not be able to satisfy the heart's increased oxygen demand. In that case, angina will result. Clearly, then, the patient who experiences angina at rest, when oxygen needs are minimal, has more severe coronary heart disease than a person who experiences angina only during vigorous exercise. Prinzmetal angina is caused by coronary artery vasospasm. It is more common in women, and commonly occurs at rest, especially at night. Most patients with Prinzmetal angina have only mild coronary heart disease, and thus do not have exertional symptoms. The vasospasm can cause both ischemia and infarction, and thus these patients are at risk of myocardial infarction, ventricular dysrhythmias, atrioventricular block, and sudden death. Patients typically respond to nitrates and calcium channel blocking agents. When taking the history from a patient with chest pain, it is important to distinguish between stable angina and unstable angina. Stable angina follows a recurrent pattern. A person with stable angina experiences pain after a certain, predictable amount of exertion, such as climbing one flight of stairs or walking for 3 blocks. The pain also has a predictable location, intensity, and duration. The patient may report, for example, every time I walk up the hill to the bus stop, I get a squeezing pain under my breastbone, and I have to sit down for 2 or 3 minutes until it goes away. Patients with chronic, stable angina often take nitroglycerin or some other nitrate agent to relieve anginal pain. Nitroglycerin is supplied as a sublingual tablet or formulated as a liquid that is sprayed under the tongue. It may also be given in a sustained-release capsule 2 or 3 times per day, as a cream rubbed into the skin, topical agent, or as a patch worn on the skin. Regardless of its form, it will have a predictable effect in patients with stable angina, relieving symptoms within a few minutes. ST segment depression or inverted T waves may be observed on the electrocardiogram. These electrocardiogram changes usually resolve when the heart's oxygen demand is reduced to a level that can be supplied by the coronary artery, such as with rest, or when blood flow is increased by dilating the coronary arteries with nitroglycerin. As discussed in the next section, it is usually not possible in the field to differentiate the patients who are having angina from those having an acute myocardial infarction. It is safer to treat a patient who has symptoms suggestive of cardiac ischemia as if they have an acute myocardial infarction rather than undertreat an acute myocardial infarction by assuming it is angina. Therefore, refer to the section on management of acute coronary syndrome to determine how to treat these patients. Acute coronary syndrome. Acute coronary syndrome refers to a continuum of cardiac disorders causing myocardial ischemia or infarction, unstable angina, non-ST segment elevation myocardial infarction, and ST segment elevation myocardial infarction. Acute coronary syndrome is most commonly caused by a ruptured atherosclerotic plaque and subsequent thrombosis of the involved coronary artery. It excludes stable angina, which can also lead to cardiac ischemia but is a self-limiting condition that is not due to a plaque rupture or thrombosis, but rather due to chronic atherosclerosis and narrowing of a coronary artery. Acute coronary syndrome is one of the most common reasons for hospital admission and results in significant cost to the healthcare system. For the patient, acute coronary syndrome can lead to significant morbidity due to reduced heart function, and has an appreciable mortality. Diagnosis is dependent on history, 12-lead electrocardiogram findings, and laboratory and/or other diagnostic testing. Unstable angina is much more serious than stable angina, and indicates a greater degree of obstruction of the coronary arteries. It is characterized by noticeable changes in the frequency, severity, and duration, greater than 15 minutes, of pain and often occurs without predictable exertion. The patient may report that the angina attacks have become more frequent or more severe, last longer, or now occur at rest. Such patterns of acute worsening should be suspected to be acute coronary syndrome from acute plaque rupture and thrombosis and may become an acute myocardial infarction. Patients with unstable angina are at high risk of imminent acute myocardial infarction and benefit from early and aggressive treatment to prevent infarction. An acute myocardial infarction is at the far end of acute coronary syndrome continuum, where a portion of the cardiac muscle is deprived of coronary blood flow long enough that portions of the muscle die, undergoes necrosis, or infarcts. The most common cause of reduction of blood flow resulting in an acute myocardial infarction is from plaque rupture and thrombus formation. However, especially if the vessels are already narrowed by atherosclerotic disease, an acute myocardial infarction can occur from spasm of a coronary artery, such as from acute cocaine toxicity or Prinz metal angina, or reduction of overall flow from any cause, such as shock or dysrhythmias. Acute myocardial infarctions are classified as either non-ST segment elevation myocardial infarction or ST segment elevation myocardial infarction. The history and clinical presentation of these two conditions are the same, only an electrocardiogram differentiates them. Non-ST segment elevation myocardial infarction does not have the recognizable electrocardiogram changes of a ST segment elevation myocardial infarction, and thus is initially indistinguishable from unstable angina. Typically, laboratory biomarkers of infarction are used to distinguish non-ST segment elevation myocardial infarction, elevated biomarkers, from unstable angina, normal biomarkers. ST segment elevation myocardial infarction is commonly recognized by an appropriate presentation or with classic 12-lead electrocardiogram findings. It does not require biomarkers. Pre-hospital 12-lead electrocardiograms are crucial in recognizing these patients so that you can start appropriate therapy and rapidly triage and transport for reperfusion therapy. The location and size of a myocardial infarction depend on which coronary artery is blocked and where along its course the blockage occurred. The majority of infarcts involve the left ventricle. When the anterior, lateral, or septal walls of the left ventricle are infarcted, the source is usually occlusion of the left coronary artery or one of its branches. Inferior wall infarcts are usually the result of right coronary artery occlusion. The infarcted tissue is invariably surrounded by a ring of ischemic tissue, an area that is relatively deprived of oxygen but still viable. The ischemic tissue tends to be electrically unstable and is often the source of cardiac dysrhythmias. Of all deaths from acute myocardial infarction, 90% are due to dysrhythmias, usually ventricular fibrillation, which typically occur during the early hours of the infarct. Dysrhythmias can be prevented or treated so that most deaths from acute myocardial infarction are preventable. Signs and symptoms of acute coronary syndrome. Not all chest pain is caused by cardiac ischemia or infarction. Many other conditions, such as pulmonary embolism, pneumothorax, pneumonia, pericarditis, aortic dissection, gastroesophageal reflux disease, gastritis, and peptic ulcer disease, may cause chest pain that can be mistaken for angina or an acute myocardial infarction. These other causes should be considered, and further history and examination may help to determine if the symptoms are likely to be cardiac in origin. The most common symptom of acute coronary syndrome is chest pain. This pain is similar to that of angina, but can be much more severe and last more than 15 minutes. A patient with chronic angina will be aware that the episode is different from previous anginal attacks. The pain of myocardial infarction is typically felt just beneath the sternum or on the left side of the chest, and is variously described as heavy, squeezing, crushing, or tight. Patients may describe the sensation in their chest not as pain, but rather as pressure or discomfort. Often, the patient unconsciously clenches a fist when describing the pain, Levine's sign, to convey in body language the squeezing nature of the pain. In 25% of cases, the pain radiates to the arms, most often the left arm, but pain to the right arm is highly suggestive of cardiac pain, and into the fingers. It may also radiate to the neck, jaw, upper back, or epigastrium. Occasionally, a patient will mistake the pain of acute coronary syndrome for indigestion, and may take antacids in an attempt to relieve the discomfort. The pain of acute coronary syndrome is not usually influenced by coughing, deep breathing, or other body movements. Not every patient with acute coronary syndrome has chest pain, however. In fact, 10% to 20% of patients with acute myocardial infarction do not experience any chest pain. People with diabetes, older people, and heart transplantation patients, for example, generally do not present with chest pain, a condition referred to as silent myocardial infarction. Instead, these patients may present with symptoms related to a drop in cardiac output. It is not unusual for them to develop sudden dyspnea, progressing rapidly to pulmonary edema, as an angina equivalent, hypotension, confusion, profound fatigue, or feeling weak and dizzy. Women with acute coronary syndrome may present differently from men with the same condition. Women may experience nausea, lightheadedness, epigastric burning, sudden onset of weakness, or unexplained tiredness more prominently than men. Many women may not recognize these symptoms as being potentially cardiac. Unfortunately, heart disease accounts for 1/3 of all female deaths in Canada. It is the #1 cause of death for women in Canada, and women are more likely to die of acute myocardial infarction than men. Typical symptoms are, in fact, not that typical in women. When obtaining the history from a patient whose chief complaint is chest pain, ask the usual sample: signs and symptoms, allergies, medications, pertinent past medical history, last oral intake, events leading up to the illness or injury, and OPQRST questions to elaborate on the chief complaint. In addition, ask whether the patient has taken anything for the pain and, if so, whether it helped. If the patient reports having taken nitroglycerin without relief, it is important to establish why the patient did not obtain relief. One of two reasons might explain this failure. One possibility is that the patient is, indeed, having acute coronary syndrome, for which nitroglycerin would not provide complete pain relief. The other possibility is that the nitroglycerin is out of date. To distinguish between the two explanations, ask the patient whether he or she noticed the usual effects of the nitroglycerin. Nitroglycerin tablets that are therapeutically active cause a slight burning under the tongue, may make the patient feel flushed, or may give the patient a transient, throbbing headache. If the patient confirms that he or she felt one of those effects but the chest pain still would not go away, then you know there was nothing wrong with the nitroglycerin, but there may be something very wrong with the patient. As soon as you have elicited a chief complaint of a cardiac nature, you will need to start treatment of the patient in parallel with obtaining a focused history and physical examination. For purposes of discussion, though, the history and physical examination will continue to be described. Besides pain, or sometimes instead of pain, a number of other symptoms are associated with acute coronary syndrome. Diaphoresis, sweating, often profuse, is principally the result of massive discharge by the autonomic nervous system. The patient may soak through his or her clothing and report a cold sweat. Dyspnea may be a warning of impending left side heart failure. Anorexia, loss of appetite, nausea, vomiting, or belching frequently accompanies myocardial infarction. Hiccups may occasionally occur as well, due to irritation of the diaphragm by an inferior wall myocardial infarction. Weakness may be profound, and the patient may describe this feeling with phrases such as a limp prag. If cardiac output is significantly diminished, then the reduced circulation to the brain may cause dizziness. Patients with cardiac dysrhythmia sometimes perceive palpitations as a sensation that the heart has skipped a beat. Feeling of impending doom is common among patients having a myocardial infarction. The patient is frightened, appears frightened, and expresses his or her fear to other people, all of which adds to a general atmosphere of panic and dread. Patients with an acute myocardial infarction often have relatively normal physical examination findings, and the diagnosis in the field depends chiefly on the history and the 12-lead electrocardiogram findings. Nevertheless, a few specific physical exam findings can help you to detect the development of complications to acute myocardial infarction, such as heart failure or cardiogenic shock. Pay attention to the patient's general appearance. Does the patient appear anxious, frightened, in obvious pain? Of course, not all chest pain is caused by ischemia, injury, or infarction. Many other conditions may cause chest pain that can mimic angina or an acute myocardial infarction. What is the patient's level of responsiveness? Is he or she fully alert? Confused? Remember, poor perfusion creates confusion. If the patient does not seem mentally sound, it may be because the heart is giving out and not enough oxygenated blood is reaching the brain. Is the skin pale, cold, and clammy? A typical patient with an acute myocardial infarction is apprehensive, with ashen gray pallor, and cold, wet skin. Assess the patient's vital signs. Is the pulse strong or weak? Regular or irregular? Is the respiratory rate abnormally rapid? Is the blood pressure abnormally high or low? In a patient with acute myocardial infarction, the pulse rate may be normal, rapid, or slow. The blood pressure may be decreased, reflecting decreased cardiac output from the damaged heart, or it may be elevated from pain and anxiety. Are there signs of left side heart failure, wheezes or crackles? Signs of right side heart failure, distended neck veins, pedal or presacral edema. Pre-hospital management of acute coronary syndrome. The stress response causes the adrenal glands to secrete a surge of catecholamines, epinephrine and norepinephrine, which in turn can send the damaged heart racing. At the same time, the massive discharge throughout the fight or flight system puts the peripheral circulation in a state of severe vasoconstriction. Thus, not only is the heart being pushed to go faster and faster, but it also has to work harder and harder against the increased afterload. The heart's need for oxygen, therefore, soars precisely when it is already in a state of marked oxygen deprivation. This cycle can lead quickly to dysrhythmias and death. Pre-hospital deaths are related to dysrhythmias, often ventricular fibrillation, and most occur during the first 4 hours after onset of symptoms. Nevertheless, this deadly cycle can be interrupted by community education programs designed to assist citizens in early recognition of symptoms, early activation of EMS, and, if needed, cardiopulmonary resuscitation and early access to an automated external defibrillator. Acute coronary syndrome treatment is time-sensitive. Despite great efforts at educating the public about the symptoms of acute coronary syndrome, the longest delay in treatment often seems to be the phase from onset of symptoms to patient recognition. Patients often delay seeking medical attention. As such, your care must begin immediately. The goals of treatment are to limit the size of the infarct, to decrease the patient's fear and pain, and to prevent and manage the development of serious cardiac dysrhythmias. On your arrival at the scene, assessment and management for possible acute coronary syndrome should occur simultaneously. Although you will be working quickly, you need to calm the patient and place him or her at rest. Prioritize your questions to determine the presence of possible acute coronary syndrome. Initial treatment. To begin your treatment, put the patient physically and emotionally at ease. Recall that one goal of treatment is to try to limit the size of the infarct. One way to do so is to decrease the amount of work that the heart must do, which will immediately begin to decrease the patient's myocardial oxygen requirements. The position in which cardiac work is minimal is the semi-Fowler position, that is, reclining on the stretcher with the back of the stretcher raised approximately 30 degrees, although if there is pulmonary edema, the patient may be comfortable sitting up more. From the time you arrive, the patient must not expend any effort, not even to walk to the stretcher. Once the focused history and primary assessment have confirmed possible acute coronary syndrome, perform a 12-lead electrocardiogram, and assess for aspirin administration. Rapid acquisition of the 12-lead electrocardiogram before the secondary assessment, and before anti-ischemic therapy is preferred. Efficient on-scene assessment, and an early 12-lead electrocardiogram allow early recognition of ST segment elevation myocardial infarction so prompt transport can occur. Data suggests that rapid acquisition of a 12-lead electrocardiogram in the pre-hospital environment decreases the time to treatment in hospital, decreases door-to-balloon and door-to-needle times by 15 to 30 minutes. This can translate into improved outcomes and reduced mortality for your patients. Given the risk of sudden ventricular dysrhythmias, patients should be transported with defibrillation pads on their chest to allow rapid defibrillation if this occurs. Consider rapid transport if your patient has evidence of a ST segment elevation myocardial infarction. An early electrocardiogram prior to treatment can also document ischemic electrocardiogram changes that may normalize after treatment is started. For example, suppose a patient is experiencing chest pain, and ST depression from ischemia is apparent on the 12-lead electrocardiogram. The ST depression may normalize after the chest pain resolves with nitroglycerin administration. If nitroglycerin was administered to that same patient prior to the 12-lead electrocardiogram, the ST depression may not be captured, and that valuable information will be lost. Aspirin is life-saving medication in acute coronary syndrome. For such a simple therapy, it has a dramatic effect on decreasing mortality from myocardial infarction. In most EMS systems, as long as the patient has no aspirin allergy, gastrointestinal bleeding, or recent head injury or hemorrhagic stroke, dispatchers may advise patients to chew baby aspirin, 160 to 325 milligrams. If this has not been done before your arrival or the patient has not already taken aspirin on his or her own, then assess the patient for contraindications. In the absence of contraindications, give the patient 160 to 325 milligrams of non-enteric-coated aspirin to chew. In the past, oxygen was administered to all patients with possible acute coronary syndrome. However, supplemental oxygen has not been shown to improve morbidity and mortality unless the patient is hypoxic, pulse oximetry less than 90%. Conversely, oxygen toxicity from oxygen supplementation may cause damage to injured cells. Therefore, the most recent Canadian recommendations are that oxygen should not be routinely administered. Only administer oxygen if needed to maintain the pulse oximetry level between 90% and 94%. Be sure to avoid hyperoxia. A nasal cannula is often sufficient. If it has not already been done in parallel with the initial assessment and management, initiate cardiac monitoring, complete a full set of vital signs, and complete the secondary assessment. Following this, you can determine what further therapies may be indicated. Electrocardiogram monitoring will be discussed later in this chapter. Obtain vital signs, including pulse, respirations, blood pressure, and oxygen saturation. Measure the blood pressure, and repeat that measurement at least every 5 minutes. Measure the pulse. The electrocardiogram monitor provides information only about the electrical activity of the heart. It gives no information about the strength of the heartbeat, muscular activity, or even about whether the heart is beating at all. It is, therefore, necessary to monitor the patient's pulse to assess peripheral blood flow, especially during transport, when blood pressure measurements may be less reliable. Next, you should obtain a more detailed history and perform a secondary assessment. Find out if the patient has a history of cardiac disease, takes any heart medications, such as beta blockers, angiotensin-converting enzyme inhibitors, diuretics, or nitroglycerin, nitrates, or has had a previous heart attack or any heart surgery, such as coronary artery bypass graft. Also obtain a more complete description of the present symptoms, especially regarding their onset. Gathering that information should not, however, delay transport to the hospital. Your secondary assessment will include an examination looking for other potential causes of the patient's symptoms, and for complications of acute coronary syndrome. Pay particular attention to the cardiac, vascular, and respiratory assessments. While you are assessing the patient for further therapies, start an intravenous line. If the patient is hypotensive or becomes so, you can use this line to provide a bolus of intravenous crystalloid. If the patient develops a dysrhythmia or complication, you will have intravenous access for medication administration. Most cardiac procedures utilize the right radial artery, so avoid the right arm if possible. Assess the patient for possible nitroglycerin administration. Nitroglycerin is a vasodilator that dilates the coronary vasculature such that it may relieve any vasospasm and may improve flow through the collateral circulation. It similarly relaxes the peripheral vasculature and may reduce preload and afterload, easing work of the heart. It quickly reverses the ischemia and the pain associated with angina. However, it may have little effect on a patient with an acute myocardial infarction, and it typically does not relieve the pain of an infarction, as it cannot open up the artery that is occluded with thrombus. It does not reduce the mortality of an acute myocardial infarction, and thus is not life-saving. It can have some side effects from the peripheral vasodilation. It may cause hypotension, especially if the right ventricle is weak. Therefore, it should be used with caution, and further treatment halted if hypotension occurs. Indeed, its use in a ST segment elevation myocardial infarction patient should not interfere with rapid transportation. Before administering nitroglycerin, assess for any contraindications. Nitroglycerin should not be administered to a patient who is hypotensive or who is bradycardic or tachycardic. Heart rates less than 50 beats per minute or greater than 160 beats per minute are associated with impending hypotension and cardiogenic shock. Nitroglycerin should be withheld in these patients. Another contraindication to nitroglycerin use is known right ventricular infarction, which can be recognized on the 12-lead electrocardiogram. Right ventricular infarction is associated with sensitivity to preload reductions, vasodilation, which decrease cardiac filling, and thus the Frank-Starling mechanism. This can lead to profound cardiac output reduction. Use of phosphodiesterase 5 inhibitor medications is also a contraindication to nitroglycerin use, as they both cause vasodilation, and concomitant use can lead to profound hypotension. It is imperative that you ascertain whether the patient has taken phosphodiesterase 5 inhibitors, taken for erectile dysfunction or pulmonary hypertension, in the 24 to 72 hours prior to nitroglycerin administration. Lastly, lack of an intravenous line to administer a bolus of crystalloid fluid is a relative contraindication for administration of nitroglycerin unless the patient has received it previously without complications. If there are no contraindications, administer nitroglycerin under the patient's tongue, sublingually, 0.3 or 0.4 mg. Nitroglycerin may be repeated every 5 minutes for 3 to 6 doses as long as the patient's condition remains stable. Reassess the vital signs after each dose, and discontinue if the patient drops out of the blood pressure or heart rate parameters, or if the systolic blood pressure drops by more than 1/3 of the initial value. If subsequent doses do not provide pain relief, further administration can be stopped. If nitroglycerin does not provide adequate pain relief, some directives suggest consideration of opioids to provide analgesia. Opioids do not appear to have any mortality benefit in acute coronary syndrome, but are associated with side effects such as vasodilation, respiratory depression, nausea and vomiting, and potential harm in acute coronary syndrome. Both morphine and fentanyl have been shown to reduce and slow the absorption of non-acetylsalicylic acid antiplatelet medications, such as clopidogrel and ticagrelor. Because these antiplatelet medications have been shown to reduce mortality in ST segment elevation myocardial infarction and high-risk acute coronary syndrome, and opioids have not been shown to reduce mortality, the latest Canadian ST segment elevation myocardial infarction guidelines recommend avoiding routine use of opioids. However, the guidelines indicate opioids can be considered if the patient is experiencing severe uncontrolled pain, greater than or equal to 7 out of 10. Therefore, try to avoid opioid use except in the patient with severe pain who is showing signs of distress. Contraindications are similar to nitrates. Do not administer to a patient with hypotension or right ventricular infarction. Administer 2 mg intravenously as needed every 5 minutes and reassess the vital signs and respiratory status after each dose. Discontinue if the patient's pain is improved, less than 7 out of 10, or if the patient becomes hypotensive or experiences significant side effects. Once you have started initial treatment for acute coronary syndrome, there is no reason to remain at the scene unless a cardiac arrest or dysrhythmia requires immediate treatment. If the 12-lead electrocardiogram that was done early in your assessment demonstrates ST segment elevation myocardial infarction, then place the defibrillation pads on the patient and initiate rapid transport. If it did not demonstrate ST segment elevation myocardial infarction, repeat this again in the vehicle prior to leaving the scene. The electrocardiogram changes associated with the ST segment elevation myocardial infarction evolve over time, and you will increase the chance of recognizing a ST segment elevation myocardial infarction by 10% to 15% if you repeat the 12-lead electrocardiogram. Continue your frequent reassessments every 5 minutes, and be ready for acute coronary syndrome complications such as hypotension, acute pulmonary edema, cardiogenic shock, dysrhythmias, and cardiac arrest. Remember to place defibrillation pads on ST segment elevation myocardial infarction patients. Continue further nitroglycerin or morphine, if appropriate, en route. If pulmonary edema develops from left ventricular failure, consider continuous positive airway pressure therapy, which is discussed later. If a serious dysrhythmia occurs during transport, institute treatment immediately. Treatment of life-threatening situations will often require your partner to pull over to the side of the road and help you in the back of the vehicle. Reperfusion techniques for ST segment elevation myocardial infarction. The majority of acute myocardial infarctions occur as a result of thrombus, fixed blood clot, formation at the site of a ruptured atherosclerotic plaque. The thrombus occludes the coronary artery, preventing further blood flow through it. Time is myocardium. The longer a segment of myocardium remains unperfused, the smaller the chances of salvaging that tissue and restoring its normal function. There is evidence that, for ST segment elevation myocardial infarction, immediate angioplasty, or percutaneous coronary intervention, is preferred to fibrinolysis when it can be accomplished within 90 to 120 minutes from first medical contact. That starts with paramedic first contact. If you can reach a hospital with facilities within 60 to 90 minutes of first contact and, if local policies allow, it may be appropriate to transport hemodynamically stable patients directly to a cardiac interventional facility. Quick reperfusion by either percutaneous coronary intervention or fibrinolysis saves cardiac tissue and reduces mortality in ST segment elevation myocardial infarction. Thus, it seems reasonable to try to restore circulation through the occluded coronary artery, thereby restoring perfusion to the ischemic myocardium. Simply put, that is reperfusion. You should know how to recognize ST segment elevation myocardial infarction on an electrocardiogram, Know which hospitals in your area carry out emergency percutaneous coronary intervention, or fibrinolysis, and provide early notification, along with 12-lead electrocardiogram results, to the facility that a candidate for such therapy is en route. Fibrinolysis. One way to reperfuse the blocked coronary artery is to try to break up the occluding blood clot with medications, thereby restoring circulation to the ischemic heart. That idea is the essence of fibrinolytic therapy. Fibrinolytic therapy seeks to administer, during the early hours of myocardial infarction, an agent that will activate the body's own internal system for dissolving clots, the fibrinolytic system. Once activated, that system can begin to dissolve the clot that has formed within the coronary artery, thereby reopening the artery, recanalization, and allowing the resumption of blood flow through it, reperfusion. Unfortunately, if an agent capable of promoting clot dissolution is given intravenously, its effects cannot be limited to the clot in the coronary artery. An agent can also act anywhere else in the body where clots are being formed and, therefore, may lead to uncontrolled bleeding. Thus, the benefit of fibrinolytic therapy, the possible salvage of myocardium, must always be weighed against its risks, principally, the risk of bleeding. Although percutaneous coronary intervention is preferred to fibrinolytic therapy when it is timely, similar mortality reduction, but less bleeding risk, and greater blood flow restoration, there are a limited number of centers that can perform percutaneous coronary intervention, and thus fibrinolytic therapy may be more readily available. Fibrinolytic therapy can be performed in virtually every emergency department in Canada. In addition, paramedics can safely administer fibrinolytic therapy in circumstances, such as rural and remote settings with long transport times to the closest emergency department. Several prospective studies, carried out more than 10 years ago, have documented reduced time to administration of fibrinolytics and decreased mortality rates when pre-hospital fibrinolytics were given to patients with ST segment elevation myocardial infarction. Some EMS systems may opt to start fibrinolytic treatment in the pre-hospital environment, especially in rural areas with very long transport times. Even in EMS systems in which paramedics do not give fibrinolytic therapy, their ability to identify candidates for such therapy has a decisive role in helping emergency department personnel administer fibrinolytic therapy early enough to make a difference. For these reasons, you should thoroughly understand the principles of fibrinolytic therapy for ST segment elevation myocardial infarction. To determine the appropriate candidates for fibrinolytic agents, you need to be as certain as possible that you are really dealing with a patient who is having a ST segment elevation myocardial infarction. A patient having chest pain from another cause would receive no potential benefit from fibrinolytic therapy, so he or she would be subjected to this therapy's risks for no reason. ST segment elevation myocardial infarction recognition on a 12-lead electrocardiogram is a skill that takes time to learn and ongoing experience to maintain that skill, and recognize ST segment elevation myocardial infarction mimics. At the same time, exclusion criteria are used to identify patients for whom the risk of fibrinolytic therapy is unacceptably high. For example, patients most likely to experience hemorrhagic complications. The key to realizing the benefits of fibrinolysis is to start early. A pre-hospital fibrinolytic program is recommended only in systems with well-established protocols, checklists, experience in advanced cardiac life support, ability to communicate with the receiving institution, and a medical director with training and experience in the management of ST segment elevation myocardial infarction. Percutaneous intervention. Many cardiac centers perform emergency primary percutaneous coronary intervention as an alternative to fibrinolysis on a 24 hours on all-day basis. Primary percutaneous coronary intervention involves emergently opening the blocked coronary artery by mechanical means with a balloon-tipped catheter, instead of delivering a fibrinolytic agent. Studies have shown that patients undergoing rapid primary percutaneous coronary intervention have better outcomes than those receiving fibrinolytic therapy. The key to better outcomes is rapid response. The target is to have the artery opened by the balloon within 90 to 120 minutes from first medical contact. This is possible in well-organized emergency medical services and hospital systems with experienced and available interventional cardiac facilities. In most systems, paramedics must alert interventional teams early. Often, the team will be called in from home, require time to prepare the interventional suite, or delay the start of an elective procedure to make room for an emergency. Thus, early notification is important. Canadian studies have demonstrated that paramedics can reliably identify patients with ST segment elevation myocardial infarction with 12-lead electrocardiogram, utilize a hospital bypass protocol, and transport patients with ST segment elevation myocardial infarction directly to a hospital with interventional cardiac care facilities. Programs that integrate EMS, emergency departments, and cardiology services are improving patient outcomes. You should be aware of your local or regional protocols for acute coronary syndrome and ST segment elevation myocardial infarction patients. Heart failure. Heart failure, also known as chronic heart failure, occurs when the heart is unable, for any reason, to pump powerfully enough or fast enough to empty its chambers. As a result, blood backs up into the systemic circuit, the pulmonary circuit, or both. Although heart failure may develop in situations other than acute myocardial infarction, for example, in a patient with chronic high blood pressure, the basic principles of diagnosis and treatment are similar, whatever the precipitating factors. It is estimated that 600,000 Canadians are living with heart failure. Depending on the symptom severity, heart dysfunction, age, and other factors, heart failure can be associated with an annual mortality of between 5% and 50%. Left ventricular failure is commonly a result of myocardial infarction and chronic hypertension, whereas right ventricular failure is most common in long-standing pulmonary disease because of the increased workload placed on the right ventricle by pulmonary hypertension. It is important to think of these two conditions as separate diseases, as their pathophysiology, manifestations, and treatment are quite different. Left side heart failure. The left ventricle is most commonly damaged during an acute myocardial infarction. Likewise, in chronic hypertension, the left ventricle tends to sustain the long-term effects of having to pump against an increased afterload, constricted peripheral arteries. In both cases, the right side of the heart continues to pump relatively normally and deliver normal volumes of blood to the pulmonary circulation. By comparison, the left side of the heart may no longer be able to pump the blood being delivered from the pulmonary vessels. As a result, blood backs up behind the left ventricle, and the pressure in the left atrium and pulmonary veins increases. As the pulmonary veins become engorged with blood, serum is forced out of the pulmonary capillaries and into the alveoli. This is called cardiogenic pulmonary edema. When fluid occupies the alveoli, oxygenation is impaired. The patient experiences that impairment as shortness of breath, dyspnea, particularly in the recumbent position, orthopnea. If left ventricular failure is the result of chronic overload, as opposed to myocardial infarction, the patient is likely to give a history of a week or two of paroxysmal nocturnal dyspnea. To compensate for the impairment in oxygenation, the patient's respiratory rate increases, tachypnea. Even so, if the patient's condition is advanced enough, cyanosis may become evident. In some patients with pulmonary edema, especially older patients, Cheyne-Stokes respirations may be present. Fluid from the pulmonary vessels also leaks into the interstitial spaces in the lungs, and increasing interstitial pressure causes narrowing of the bronchioles. Air passing through the narrowed bronchioles creates wheezing noises, whereas air bubbling through the fluid-filled alveoli produces crackles. Furthermore, the patient may cough up the edema fluid in the form of foamy, blood-tinged sputum. As the airways narrow and the lungs grow heavier from the accumulation of fluid, the work of breathing increases, which puts an even greater strain on the already floundering heart. Dyspnea and hypoxemia produce a state of panic, which induces the release of epinephrine from the adrenals. The heart is pushed even harder, and its oxygen demand is increased precisely when fluid in the alveoli is reducing the amount of oxygen available. To make matters worse, the sympathetic nervous system response produces peripheral vasoconstriction. Peripheral resistance, afterload, increases, and the weaken, hypoxic heart finds itself trying to push blood out into smaller and smaller pipes. Clinically, peripheral vasoconstriction is apparent as pallor and elevated blood pressure. The massive sympathetic discharge also produces sweating of the pale, cold skin. It is not unusual for a patient with left-side heart failure to become frantic from air hunger. He or she may pace or thrash about or may even be combative and struggle with the rescue team. Furthermore, hypoxemia results in inadequate oxygen supply to the brain, often manifested as confusion or disorientation. If hypoxemia is severe, cardiac arrest may follow quickly. Signs and symptoms of left-side heart failure. The signs and symptoms of left-side heart failure include extreme restlessness and agitation, confusion, severe dyspnea and tachypnea, tachycardia, abnormally high or low blood pressure, crackles and possibly wheezes, and frothy, pink sputum. Sometimes, it may be difficult to distinguish the wheezing of chronic obstructive pulmonary disease from that of cardiogenic pulmonary edema. Table 30-11 presents some of the features that can help you differentiate the two conditions. Management of left-side heart failure. Pre-hospital management of left-side heart failure is aimed at improving oxygenation, decreasing the workload of the heart, and reducing the volume of venous blood return to the heart, the preload, so that the left ventricle is less overburdened. In conjunction with the primary assessment, obtain vital signs, and initiate cardiac monitoring and pulse oximetry. Unless the patient is hypotensive or the patient's level of awareness precludes it, position the patient sitting up with the feet dangling. This position encourages venous pooling in the legs, thereby reducing venous return to the heart. The sitting position also makes breathing easier for a patient in respiratory distress. Administer oxygen as required to keep the oxygen saturation between 90% and 94%. Start an intravenous line with normal saline at a to keep open rate. Perform a 12-lead electrocardiogram when feasible, may be difficult due to positioning and respiratory distress. Pre-hospital pharmacologic therapy of left-side heart failure may vary slightly between regions, but the traditional medication therapy includes the medications mentioned below. Some of these therapies will be guided by vital signs, specifically blood pressure, and thus this should be monitored closely. Refer to your local protocols for specific therapies and dosing in your area. Nitroglycerin is the mainstay of treatment for acute heart failure exacerbation, and the single medication that may reduce mortality, intubation rate, intensive care unit admission rate, and myocardial infarction rate. This medication is usually given sublingually, supplied as 0.4 mg spray or 0.3, 0.4, or 0.6 mg tablets, as a single or double dose depending on the patient's blood pressure. It can also be delivered via an intravenous infusion, primarily in the hospital. Nitroglycerin's direct effects are to first cause venodilation. At higher doses, it causes arterial dilation. Indirectly, this may lead to a reduction in cardiac work, and an improvement in cardiac output, which may reduce the amount of pulmonary edema being produced. The arterial dilation reduces the afterload, or the force the heart pumps against. This will reduce the strain on the heart, and secondarily improve cardiac output. The initial dose of 0.4 or 0.8 mg may be repeated at 3 to 5 minute intervals with frequent blood pressure checks. Furosemide, Lasix, is a diuretic that is used for symptomatic benefit in chronic heart failure, but it should be used cautiously in acute heart failure. As a diuretic, it removes excess fluid from the body by promoting its excretion by the kidneys. This may be useful if the patient is fluid overloaded, but this is not always the case in an acute episode of left-side heart failure, and it may take 30 minutes to have a diuretic effect. Diuresis may worsen hypokalemia and cause hypovolemia. Earlier effects may include reduced preload. Large doses in acute heart failure may lead to a reflexive increase in afterload, vasoconstriction as a reflex response to diuresis, reducing cardiac output, and making the patient worse. Pre-hospital studies have shown that large doses can be deleterious, therefore, this medication should be used with caution in the pre-hospital setting. If ordered, furosemide is given in a dose of only 20 to 40 milligrams, small dose, by intravenous bolus. Morphine sulfate was part of the standard treatment of cardiogenic pulmonary edema in the past, but it appears to have little benefit, and may cause some harm. Morphine works as a vasodilator, increasing the pooling of blood in the periphery, and it also has a calming effect on a frantic patient. Pre-hospital studies have shown that the sedation may be detrimental and lead to a greater likelihood of intubation. Because vasodilation can be easily accomplished by nitroglycerin, morphine is rarely indicated. The presence of wheezing is common and may indicate that bronchoconstriction has developed from the excessive fluid. However, if the patient does not show substantial evidence of bronchoconstriction, bronchodilators should be avoided because they all cause tachycardia, which can worsen the patient in heart failure. Many EMS programs are now introducing portable continuous positive airway pressure devices with tightly fitting masks to improve oxygenation in patients with pulmonary edema or chronic obstructive pulmonary disease and hypoxemia. Recall from Chapter 14, Mechanical Ventilation, that continuous positive airway pressure provides positive end expiratory pressure. In pulmonary edema, fluid in the alveoli reduces the surfactant's ability to keep the alveoli open. The result is atelectasis, alveolar collapse, increased respiratory effort, and reduced gas exchange. Continuous positive airway pressure can help reverse this by holding alveoli open throughout the respiratory cycle so that oxygen and carbon dioxide can diffuse between the alveoli and capillaries. The mask can be removed for medication administration, such as nitroglycerin sprays, but it may be better to give initial medications prior to continuous positive airway pressure administration, and then only remove the mask for further medications if the patient's condition is not improving. Oxygenation and blood pressure should be monitored closely. Continuous positive airway pressure increases intrathoracic pressure, and may cause a slight decrease in blood pressure. If the patient's respiratory status is very poor, oxygen saturations are dropping, and tidal carbon dioxide is increasing, or the patient's level of awareness is decreasing, you need to stop continuous positive airway pressure, and manually ventilate the patient with a bag mask device. Use a positive end expiratory pressure valve, and two-handed seal if possible. While intubation in the field is discouraged for most spontaneously breathing patients, and can often be avoided in patients with acute heart failure managed with the above therapies, there are patients who require advanced airway management in order to improve their oxygenation and ventilation. Under special circumstances, when transport will be prolonged and the patient's blood pressure is low, direct medical control may order an inotrode, drug that increases cardiac contractility, such as dopamine or norepinephrine, which will increase blood pressure and/or cardiac output. If bradycardia is contributing to low cardiac output, raising heart rate with atropine, dopamine, or transcutaneous pacing should be attempted. Electrical pacing is preferred when the patient is unstable. Right side heart failure. Right side heart failure most commonly occurs as a result of left side heart failure. As blood backs up from the left side of the heart into the lungs, the right side has to work increasingly harder to pump blood into the engorged pulmonary vessels. Eventually, the right side of the heart is unable to keep up with the increased workload, and it, too, fails. Right side heart failure may also occur as a result of pulmonary embolism or pulmonary hypertension. In pulmonary embolism, forward blood flow through the pulmonary circuitry to the left atrium is blocked by a blood clot, resulting in increased workload on the right ventricle. In pulmonary hypertension, long-standing lung diseases such as chronic obstructive pulmonary disease and pulmonary fibrosis cause increased resistance to blood flow through the lungs, again backing up blood into the right ventricle, and increasing its workload. When the right ventricle has to work harder to pump blood through the pulmonary circuit due to chronic lung disease, the term cor pulmonale is applied. Signs and symptoms of right side heart failure. The presence or absence of pulmonary edema on physical examination can often provide a helpful clue as to whether right side heart failure is secondary to left side heart failure, pulmonary edema present, or due to primary lung or right side heart problems, no pulmonary edema. When right side heart failure occurs, blood backs up behind the right ventricle and increases the pressure in the systemic veins, causing them to become engorged. Distension can be seen in the veins visible on the surface of the body, such as the external jugular veins. Over time, as the pressure within the systemic veins increases, serum is forced out of the veins and into the surrounding tissues, producing edema. Edema is most likely to be visible in dependent parts of the body, such as the feet in a person who is sitting or standing or the lower back in a bedridden patient. Edema is also present in parts of the body that are not visible, a painful liver easily palpable in the right upper quadrant, for example, signals engorgement and swelling within that organ, hepatomegaly. Management of right side heart failure. Right side heart failure, by itself, is seldom a life-threatening emergency. Usually it develops gradually over days to weeks. Similarly, it requires days to weeks to reverse the process by slowly ridding the body of excess salt and water. Treatment in the pre-hospital environment of a patient with right side heart failure, therefore, is simply to make the patient comfortable, preferably in the semi-Fowler position. Monitoring is always indicated in any patient with significant cardiac disease. If signs of associated left side heart failure are present, treat them as outlined in the previous section. Cardiac tamponade. The pericardium is a tough, fibrous membrane with the ability to stretch only up to a point. Normally, a small amount of pericardial fluid separates the pericardium and the outer surface of the heart. Cardiac tamponade occurs when excessive fluid accumulates within the pericardium, limiting the heart's ability to expand fully after each contraction, and resulting in reduced cardiac output. If unrecognized and untreated, this condition will reduce cardiac filling to the point that the heart is unable to circulate the blood. Cardiac tamponade occurs when an effusion, fluid buildup, either occurs quickly or to such an extent that it causes hemodynamic compromise. It can occur as a result of tumors, inflammatory conditions, chemotherapeutic agents, or trauma to the chest. Fluid can gradually accumulate, resulting in excessive amounts of fluid in the pericardial space. Blunt or penetrating trauma can result in bleeding into the pericardial space, causing abrupt accumulation of blood. Signs and symptoms of cardiac tamponade. Signs and symptoms of cardiac tamponade vary depending on its cause. If the onset is gradual, as with pericarditis, the initial reports might be dyspnea and weakness. If the cause is traumatic, the chief complaint might be chest pain. As the volume of fluid increases in the pericardium, the stroke volume decreases, causing an initial drop in the systolic blood pressure. Eventually, the diastolic blood pressure will slowly rise, resulting in the classic symptom of narrowing pulse pressure. The initial drop in blood pressure is usually followed by an increase in heart rate, which leads to tachycardia. The heart sounds may be muffled or quieter than usual owing to the buildup of fluid, although this sign may be difficult to identify in the pre-hospital environment. The patient may experience jugular venous distension as well, owing to the backup of blood from the right side of the heart. The combination of hypotension, weak pulse or narrowing pulse pressure, jugular venous distension, and muffled heart sounds is commonly known as the Beck triad. When cardiac tamponade is suspected, the most helpful clue on examination is pulsus paradoxus. Pulsus paradoxus can be noted by a drop in systolic blood pressure of more than 10 mm of mercury or a weakening pulse with the patient's inspiration. Pulsus paradoxus can occur in conditions other than cardiac tamponade, but you should consider cardiac tamponade if it is present. The electrocardiogram is of limited value in identifying cardiac tamponade. Aside from tachycardia, you might rarely see electrical alternans, alternating small and large amplitude QRS complexes. In addition, you might identify pulsus alternans, alternating strong and weak pulses. Muffled heart sounds, pulsus alternans, electrical alternans, and pulsus paradoxus are not common signs, and so may be easily overlooked. In trauma patients, you may have difficulty distinguishing between cardiac tamponade and tension pneumothorax as the cause of hypotension. One way to differentiate between the two is to remember that in cardiac tamponade, the breath sounds will be equal and the trachea will be midline because the lungs are not affected. Management of cardiac tamponade. The ultimate treatment for cardiac tamponade is pericardiocentesis, which involves inserting a needle or drain into the pericardium, and then withdrawing fluid. Often, withdrawal of as little as 50 milliliters of fluid will result in significant improvement in the patient's condition. This technique is risky and usually performed under ultrasound guidance in the emergency department or operating room. In the pre-hospital setting, treatment that will significantly enhance the patient's survival is rapid transport to a facility that can perform this procedure. Supporting the patient's airway, breathing, and oxygenation during transport is essential. An intravenous fluid bolus of 500 to 1,000 milliliters of saline might be considered. When updating the receiving hospital, make sure that you identify all signs and symptoms that led you to believe the patient has cardiac tamponade so that they will be prepared to treat the patient. Cardiogenic shock. Cardiogenic shock occurs when the heart is so severely damaged that it can no longer pump a volume of blood sufficient to maintain tissue perfusion. An acute myocardial infarction nearly always produces some impairment of left ventricular function. When 25% of the left ventricular myocardium is involved in the myocardial infarction, left side heart failure usually develops. When 40% or more of the left ventricle has been infarcted, cardiogenic shock may occur. Thus, cardiogenic shock indicates extensive injury to the myocardium. Accordingly, there is a high mortality rate. Transient cardiogenic shock can occur after resuscitation, for example, following return of spontaneous circulation after defibrillation for ventricular fibrillation. Other causes of cardiogenic shock are toxicity or overdose from cardiac medications, for example beta blocker or calcium channel blocker, viral myocarditis, and peripartum cardiomyopathy of pregnancy. Signs and symptoms of cardiogenic shock. The signs and symptoms of cardiogenic shock are similar to those of most other kinds of shock. Because of the reduced cerebral perfusion, the patient is often confused or even comatose. If awake, he or she is likely to be restless and anxious. Massive peripheral vasoconstriction results in pale, cold skin, and poor renal perfusion is reflected in minimal or absent urine output. Pulse oximeter readings are frequently difficult to obtain in patients with cardiogenic shock because the fingers and toes are barely perfused due to the intense vasoconstriction. Respirations are rapid and shallow, so auscultation usually reveals crackles throughout the chest, and the pulse is racing and thready. As these compensatory mechanisms begin to fail, the blood pressure will fall, sometimes to less than 90 millimeters of mercury of systolic blood pressure. However, this vital sign may be deceptive. In patients with pre-existing hypertension, systolic blood pressure higher than 90 millimeters of mercury may still be associated with cardiogenic shock. The goal in treatment of cardiogenic shock is to identify and support the patient before the blood pressure drops to the point where the shock becomes irreversible. Management of cardiogenic shock. Management of cardiogenic shock focuses on improving perfusion without adding to the work of the heart. Administer supplemental oxygen by mask or bag mask device if the patient is hypoxic. An advanced airway may be necessary if the patient is comatose. The addition of continuous positive airway pressure using a positive end expiratory pressure valve attached to a bag mask device or a continuous positive airway pressure or mask delivery system may be helpful to improve oxygenation in cases of cardiogenic shock associated with pulmonary edema, although the blood pressure may be reduced when applied. Place the patient in a supine position unless pulmonary edema is present. In that case, the patient should be placed in the semi-fowler position. Start an intravenous line with normal saline at a to keep open rate. Direct medical control may order a trial of fluids even if the patient has pulmonary edema, as this may sometimes improve the cardiac output. If so, rapidly infuse 250 milliliters of saline and reassess. Closely monitor the patient's pulse, blood pressure, and level of consciousness. Report those observations to the physician. Apply monitoring electrodes, and obtain a 12-lead electrocardiogram if available. Dysrhythmias may bring about hypotension by causing severe disturbances in cardiac output. Thus, rhythm treatment may be required to stabilize the patient. Depending on the distance to the hospital and local protocols, you may be asked to administer a vasopressor drug, such as one of those listed in Table 30-12. Dopamine is the most commonly used vasopressor by paramedics, although norepinephrine may have similar outcomes with fewer dysrhythmias. In addition to increasing the blood pressure, most vasopressors will also act as an inotrode, which increases cardiac contractility. The administration of any vasopressor drug requires careful titration and frequent monitoring of the blood pressure. Measure the blood pressure at least every 5 minutes. Slow the infusion if the systolic blood pressure rises to more than 90 or 100 millimeters of mercury. Speed up the infusion if the systolic blood pressure below 80 millimeters of mercury. If bradycardia is present and the patient is unstable, consider transcutaneous pacing. Transport the patient expeditiously to the hospital. Except for the correction of life-threatening dysrhythmias, there are no measures that can stabilize the condition of a patient in cardiogenic shock in the pre-hospital environment. Thus, a short scene time is essential. Aortic emergencies. The two most concerning aortic emergencies are aneurysm and dissection. The word aneurysm comes from a Greek word for widening. It refers to the dilation or outpouching of a blood vessel. The most common concern for paramedics is an expanding or ruptured aneurysm of the abdominal aorta. This is not all that uncommon, especially in patients older than 50 years. Dissection is a tear in the innermost wall of the artery, which leads to blood flow between the layers of the artery. It can block or restrict flow to branches of the artery, and may eventually rupture. It is commonly found in the thoracic aorta, usually not associated with an aneurysm. It is a relatively uncommon event compared to acute coronary syndrome, with overall incidence is about 4.6 per 100,000 population in Ontario each year. Acute dissection of the aorta. The proximal aorta is subject to enormous hemodynamic forces. Anywhere from 60 to 100 times per minute, 60 minutes per hour, 24 hours per day, that is, around 40 million times per year, pulsatile waves of blood come pounding out of the left ventricle against the aortic walls. Over the years, that pounding takes its toll, producing degenerative changes in the media, the middle layer, of the aorta, especially the ascending aorta, the part of the aorta that rises from the heart toward the aortic arch. The degenerative changes are more pronounced with advancing age, in people with chronic high blood pressure, and in younger patients with connective tissue disorders, such as patients aged 20 to 40 years with Marfan syndrome. The resulting effect is to unglue the layers of the aortic wall from one another. Eventually, the degenerative changes in the aortic media may lead to a disruption of the underlying intima, innermost layer of the artery. Tearing of the intima is most likely to occur in the portions of the thoracic aorta that are under the greatest stress, specifically, the ascending aorta just distal to the aortic valve, approximately 65% of cases, and the descending aorta just beyond the takeoff point of the left subclavian artery. Once the intima is torn, the process of dissection often begins. With each ventricular systole, a jet of blood is forced into the torn arterial wall, creating a false channel between the intimal and medial layers of the wall. This channel is propagated distally and sometimes proximally along the length of the wall. If the dissection progresses back into the aortic valve, it may prevent the valve from closing, so that blood regurgitates back from the aorta into the left ventricle during systole. Recall that the coronary arteries branch off from the aorta just above the leaflets of the aortic valve. Thus, if the valve is affected, coronary blood flow will likely be affected as well and may result in an acute myocardial infarction. If the dissection involves the takeoff point of the innominate, left common carotid, or left subclavian artery, blood flow through the affected artery or arteries will be compromised and may cause a stroke or arm ischemia. Signs and symptoms of acute dissection of the aorta. The typical patient with a dissection is a middle-aged or older man with chronic hypertension, although dissection may occur during pregnancy, and in younger patients with Marfan syndrome. By far, the most common chief complaint is chest pain, which is classically described as the worst pain I have ever experienced, or as ripping, tearing, sharp, or like a knife. This pain comes on very suddenly and may be located in the anterior part of the chest or in the back between the shoulder blades, and/or radiate into the posterior chest, back, or abdomen. On the basis of the patient's description, it may be difficult to differentiate the chest pain of a dissection from that of an acute myocardial infarction, but a number of distinctive features may help. The pain of an acute myocardial infarction is often accompanied or preceded by other symptoms, nausea, indigestion, weakness, and sweating, and tends to come on gradually, getting more severe with time, and often being described as pressure rather than stabbing. By contrast, the pain of aortic dissection usually becomes maximal within 1 minute, without prodromal symptoms, and often includes radiation into the back. Table 30-13 summarizes the differences in the clinical presentations of myocardial infarction and aortic dissection. Other signs and symptoms of dissection will depend on the site of the intimal tear and the extent of the dissection. In dissections of the ascending aorta, which tend to occur in younger patients previously in good health, one or more of the vessels of the aortic arch are usually compromised. Disruption of flow through the brachiocephalic or left subclavian artery, for example, is likely to produce a difference in blood pressure between the two arms. If you do not routinely check the blood pressure in both arms, you will never detect that sign. You may also find that one femoral or carotid pulse is missing or weak. Always check both radial pulses when suspecting dissection. Disruption of blood flow into the left common carotid artery may produce signs and symptoms of a stroke. When the dissection extends proximally to the ostia of the coronary arteries, coronary blood flow is apt to be compromised, and electrocardiogram changes of myocardial ischemia are likely. Death from dissection of the ascending aorta is nearly always a result of aortic rupture. It may rupture into the mediastinum and chest cavity, or into the pericardium with resultant cardiac tamponade. In the former, the patient will rapidly develop shock and cardiac arrest. In the latter, you will briefly see the characteristic signs of cardiac tamponade, distended neck veins, hypotension, narrow pulse pressure, and muffled heart sounds prior to cardiac arrest. Dissection of the descending aorta occurs more commonly in older patients, especially those with a history of hypertension. The pain is apt to be somewhat less severe when the descending aorta is involved. Indeed, the patient may wait a few days before seeking help. The dissection usually proceeds distally, so the aortic arch is spared, which means that blood pressure discrepancies between the two arms are not part of the picture. The pulses in the lower extremities, however, may be affected. Management of acute dissection of the aorta. The goal of pre-hospital management in a suspected aortic dissection is recognition and rapid transport. In the hospital setting, medications will be given to lower the patient's blood pressure and reduce myocardial contractility to take some of the hemodynamic load off the aorta prior to surgery. Only in very unusual circumstances would such therapy be started in the pre-hospital environment, however, because it requires continuous monitoring of intra-arterial pressure. The steps of pre-hospital management in suspected aortic dissection are as follows. Calm and reassure the patient. Administer supplemental oxygen if the patient is hypoxic. Insert an intravenous line with a crystalloid solution. Apply monitoring electrodes, and obtain an electrocardiogram rhythm strip. Transport without delay. Nothing can be done to stabilize the patient's condition in the pre-hospital setting. He or she will need aggressive therapy in the intensive care unit, and possibly surgery, so do not dawdle. If the patient is not hypotensive, consider morphine sulfate, 2 mg intravenously per dose. If the patient is having severe pain, avoid acetylsalicylic acid and nitroglycerin. Expanding and ruptured abdominal aortic aneurysms. An abdominal aortic aneurysm can be found in approximately 2% of the population older than 65 years, and rupture of the aneurysm is associated with an 80% mortality. Most commonly, the aneurysm is located just distal to the renal arteries. An expanding aneurysm is, as the name implies, an aneurysm that is getting larger and producing symptoms by compressing on adjacent structures, although the aortic wall remains intact. When an aneurysm starts expanding and producing symptoms, you can assume that rupture is imminent. Signs and symptoms of expanding and ruptured abdominal aortic aneurysms. The typical patient with an abdominal aortic aneurysm is a man in his late 70s. So long as the aneurysm is stable, the patient will usually be asymptomatic. When the aneurysm starts to expand or rupture, however, the patient becomes symptomatic, with a sudden onset of abdominal or back pain. When the pain is principally in the abdomen, it tends to center on the umbilicus. Often, the pain may be located solely in the lower back, leading the patient to think he or she has pulled a muscle, or mimic the pain from renal colic. The pain is constant and moderate to severe. It cannot be relieved by changes in position. It tends to radiate into the thigh and groin. If the aneurysm is leaking blood, the patient may experience an episode of syncope followed by pain. The most characteristic physical finding in an abdominal aortic aneurysm is a pulsatile mass palpable in the abdomen. The patient is likely to be normotensive when first seen, but signs of shock, with or without hypotension, may develop rapidly if the aneurysm has ruptured. Management of expanding and ruptured abdominal aortic aneurysms. Pre-hospital management of an expanding or ruptured aortic aneurysm is aimed at getting the patient to the hospital as expeditiously as possible because the definitive treatment requires urgent surgery. The key is to maintain a high index of suspicion whenever a middle-aged or older person presents with sudden back pain or a pulsatile abdominal mass. The more likely problem in the pre-hospital environment in a conscious patient is a leaking aneurysm that has yet to rupture. The steps of pre-hospital management in expanding or ruptured aortic aneurysm are as follows. Administer supplemental oxygen if hypoxic. Transport without delay. Insert an intravenous line en route, but avoid large volume infusions. Use a large gauge cannula, but maintain the flow to keep the vein open unless signs of shock appear. If there are signs of shock, allow permissive hypotension with intravenous fluids only to bring the blood pressure up to 70 to 90 millimeters of mercury. Higher may cause more blood loss. Hypertensive emergencies. Hypertension, high blood pressure, affects nearly 1 in 4 Canadians, yet almost 1/2 of those with hypertension do not know it because they have no symptoms. In addition, it is a major contributing cause in many cases of myocardial infarction, heart failure, and stroke. Most hypertension causes advanced atherosclerosis or arteriosclerosis, which decreases the lumen of the arteries and reduces their elasticity. The high afterload leads to increased work on the heart and resultant myocardial hypertrophy and eventually heart failure and or ischemia. Hypertension is present when the blood pressure at rest is consistently greater than 130/80 millimeters of mercury. Normal blood pressure is below 120/80 millimeters of mercury. Many conditions, such as anxiety or pain, can transiently elevate a person's blood pressure, especially the systolic blood pressure, so a single blood pressure measurement obtained during an emergency scarcely constitutes adequate grounds for telling a patient that he or she is hypertensive. Instead, you may say something like this: "Sir, your blood pressure is a little high right now." That may be because of the situation today. To be safe, you should have your blood pressure rechecked a couple of times in the next few weeks under less stressful circumstances. Persistent elevation of the blood pressure can cause peripheral vascular disease and coronary heart disease and significantly shortens lifespan. The most common complications of hypertension include renal damage, stroke, and heart failure. The latter is a result of the left ventricle having to pump for years against a markedly increased afterload. Signs and symptoms of hypertensive disease. In the majority of cases, hypertension is entirely asymptomatic and is detected during routine examination. By the time symptoms start to occur, hypertension is already in a more advanced stage, and has probably produced at least some damage to organs such as the heart, kidneys, and brain. Management of hypertensive emergencies. Hypertensive emergencies occur in approximately 1% of all hypertensive patients. A hypertensive emergency is defined as an acute elevation of blood pressure with evidence of end organ damage. That last phrase is important, because it is the evidence of end organ dysfunction that determines the urgency of the situation, not the height of the blood pressure reading. Two end organ emergencies that may result from uncontrolled hypertension were discussed earlier in this chapter: left side heart failure and aortic dissection. A rare but just as devastating complication of hypertension is hypertensive encephalopathy. Hypertensive encephalopathy is severe hypertension associated with loss of the blood-brain barrier and cerebral edema. The determining factor for hypertensive encephalopathy is usually the mean arterial pressure. The mean arterial pressure is calculated by adding 1/3 of the difference between the systolic blood pressure and diastolic blood pressure to the diastolic blood pressure. Mean arterial pressure equals diastolic blood pressure plus 1/3 of systolic blood pressure minus diastolic blood pressure. When the mean arterial pressure exceeds 150 millimeters of mercury, the pressure may breach the blood-brain barrier with resultant fluid leaking out, increasing intracranial pressure. Usually, the first symptoms noticed are severe headache, nausea, and vomiting. They are followed by seizures and alterations in mental status, that is, confusion to unresponsiveness. Sometimes patients may show focal neurologic signs, such as sudden blindness, aphasia, disturbances in speech production or comprehension, or hemiparesis. It is often difficult in the pre-hospital environment to differentiate hypertensive encephalopathy from intracerebral hemorrhage or other causes of coma. The goal of treatment in hypertensive encephalopathy is to lower the blood pressure by no more than 1/3, in a controlled manner, during a 30 to 60-minute period so that cerebral blood flow is restored to normal. Excessive lowering of the blood pressure can cause complications, and must be avoided. That is best accomplished under controlled conditions in a hospital. Thus, if you are within 20 to 30 minutes of the nearest hospital, provide supportive treatment only. Administer supplemental oxygen if hypoxic. Establish an intravenous line with normal saline at a to keep open rate. Apply monitoring electrodes, and run an electrocardiogram rhythm strip. Obtain a 12-lead electrocardiogram en route to the emergency department. Transport without delay. Be prepared to deal with seizures en route. In some settings where the diagnosis is known, such as an interfacility transfer, you may continue the antihypertensive therapy initiated by the sending hospital. A commonly used medication for this purpose is labetalol, Trandate, which has alpha and beta blocking properties. It can only be given if it is within your paramedic scope of practice and part of a medical directive or with direct medical control. As an alpha blocker, labetalol prevents vasoconstriction, thereby decreasing the overall peripheral vascular resistance. Meanwhile, its beta-blocking actions prevent the reflex tachycardia that would otherwise occur in response to a drop in blood pressure. As a beta blocker, however, labetalol is relatively contraindicated in patients with asthma and chronic obstructive pulmonary disease. Labetalol can be given initially by slow intravenous push at 10 to 20 milligrams, repeated in 10 minutes as necessary, or an intravenous drip can be started. If delivered by infusion, watch the infusion like a hawk. A runaway intravenous line could prove disastrous. Monitor the patient's blood pressure every 2 to 3 minutes. When the blood pressure has fallen to the target level specified by medical control physician, modify subsequent doses or the infusion rate. The other medication that may be ordered to lower a dangerously high blood pressure is nitroglycerin, 0.4 mg sublingual. This medication is not the first choice for this indication, but its use is acceptable if labetalol is not available. Once again, use of nitroglycerin for this purpose depends on your medical directives and direct medical control. Whenever you give a medication to lower a patient's blood pressure, keep the patient supine and measure his or her blood pressure at least every 3 to 5 minutes. Remember that the only reason to acutely lower a patient's blood pressure in the field is for a hypertensive emergency when end organ damage is present. Even then, treatment is usually started in the hospital, but occasionally paramedics may be involved in treating these patients on interfacility transfers. Cardiac monitoring. Cardiac dysrhythmias may arise from a variety of causes. They are not solely caused by myocardial infarction. A cardiac dysrhythmia is simply a disturbance in the normal cardiac rhythm, which may or may not be clinically significant. Sometimes dysrhythmias are caused by ischemia, electrolyte imbalances, or disturbances or damage in the electrical conduction system, resulting in escape beats, circus re-entry, or enhanced automaticity. Thus, it is necessary to evaluate the dysrhythmia in the context of the patient's overall clinical condition. The patient's condition along with the rhythm recognition will ultimately determine whether treatment is necessary and the urgency of that treatment. Treat the patient and the monitor. One of the most important tasks in the pre-hospital care of a patient with an acute myocardial infarction is to anticipate, recognize, and treat life-threatening dysrhythmias. Dysrhythmias develop after an acute myocardial infarction for two principal reasons. First, irritability of the ischemic heart muscle surrounding the infarct may cause the damaged muscle to generate abnormal currents of electricity that cause abnormal cardiac contractions. When the dysrhythmia arises from irritable spots in the myocardium, ectopic foci, it is usually a rapid dysrhythmia, tachydysrhythmia, such as ventricular tachycardia or PVCs. Second, dysrhythmias may occur after an acute myocardial infarction because the infarct damages the conduction tissues. In such a case, the abnormal rhythm is usually a block or a branded dysrhythmia. Very slow heart rates, usually less than 50 beats per minute, lead to inadequate cardiac output, and often precede electrical instability of the heart. Furthermore, when the sinus rate becomes very slow, ectopic pacemakers in the atrioventricular junction or ventricles may fire, producing escape beats to assist in maintaining cardiac output. Conversely, very rapid heart rates, greater than 120 to 140 beats per minute, increase the work of the heart, causing further myocardial ischemia and damage. Tachycardias may also be associated with decreased cardiac output secondary to decreased stroke volume because the ventricles have less time to fill between beats. Hypoxia, metabolic alkalosis, hypokalemia, and hypocalcemia can lead to electrical instability. Cells that usually do not have automaticity may then begin to fire impulses. The result is the potential for tachycardias, flutters, and fibrillations in the atria or ventricles, heralding grave rhythms such as ventricular tachycardia and ventricular fibrillation. Circus re-entry can also be a serious problem. The atrioventricular node may be bombarded by more than one impulse, potentially blocking the pathway for one impulse and allowing the other to stimulate cardiac cells that have already depolarized. The danger here comes when these impulses get stuck in a pattern of repetition, causing multiple ectopic beats or ventricular fibrillation. ECG analysis is indicated in any patient who might have a cardiac-related condition or rapid or slow heart rate. Any patient with chest pain should certainly undergo ECG analysis, but this monitoring should also be instituted for any patient with a history of heart problems. Given that age is a contributing factor to heart disease, ECG analysis is appropriate for older patients in many situations. Indeed, the ECG should be thought of as another vital sign, similar to the blood pressure or pulse oximetry. ECG monitoring and the electrodes. The ECG monitor serves several functions in the pre-hospital setting. The device can be used to continuously monitor the patient's cardiac rhythm during transport, print out a rhythm strip to perform dysrhythmia interpretation, and perform a 12-lead ECG for specific concerns. Typically, continuous monitoring is performed using the three standard limb leads, leads 1, 2, and 3. Continuous ECG monitoring may be used during transport to identify any changes in the patient's heart rhythm. When analyzing cardiac monitoring ECGs, the tracing from lead 2 is usually the most useful. The cardiac monitor also enables you to acquire and document a 12-lead ECG. The 12-lead ECG provides detailed information about the heart's conduction system and records the activity from 12 separate angles. In virtually all cases, when you record a 3-lead ECG, it is because you suspect the patient is experiencing a cardiac event. Therefore, a 12-lead ECG should also be captured. A detailed discussion of 12-lead ECGs can be found later this chapter. Cardiac monitors are equipped with leads, wires, that are connected to electrodes that are placed on the patient. Each lead offers an electrical snapshot of a certain part of the heart. The cardiac monitor records an ECG tracing for each lead used. Professionals trained in interpreting the findings can then review them. Transport the patient. An important component of acute coronary syndrome care is performing a pre-hospital 12-lead ECG with either transmission or interpretation by paramedic personnel. As discussed earlier, a pre-hospital 12-lead ECG demonstrating ST segment elevation myocardial infarction has been shown to reduce the time to reperfusion and can help triage patients to a hospital with interventional cardiac care facilities. When paramedics activate the cardiac care team, this can result in reductions to reperfusion times and improved survival. Electrode placement for cardiac monitoring. In virtually all cases, if you suspect the patient is experiencing a cardiac event, you should capture a 12-lead ECG. Although a 3-lead ECG provides a great deal of information, it is very limited compared with the information obtained from a 12-lead ECG. To maintain consistency in monitoring and obtaining a useful ECG, there are predetermined locations to place electrodes and leads. Electrodes used in the pre-hospital setting are generally adhesive and have a gel center to aid in skin contact. Some manufacturers offer diaphoretic electrodes that adhere aggressively to diaphoretic patients. Whichever type is used, certain basic principles should be followed to achieve the best skin contact and minimize artifact. Artifact refers to a poor ECG tracing that is the result of poor contact or interference, rather than the heart's electrical activity. These principles are as follows. To maintain the correct lead placement, it may be necessary to shave the patient's body hair from the electrode site. Do not be fooled by a hairy chest. It may appear that you have good skin contact initially, but the electrode will peel away from the skin and stick to the hair. To remove oils and dead tissue from the surface of the skin, rub the electrode site briskly with a dry gauze pad. Attach the electrodes to the ECG cables before placement. Confirm that the electrode now attached to the cable is placed at the correct location on the patient's chest or limbs. Each cable is marked and color-coded to indicate the correction location for placement. Once all the electrodes are in place, switch on the monitor and print a rhythm strip. If the strip shows any interference, artifact, then verify that the electrodes are firmly attached to the skin, and that the monitor cable is plugged in correctly. Artifact on the monitor can be tricky. A straight-line ECG in an alert, communicative patient indicates a loose or disconnected lead, not asystole. Similarly, a wavy baseline resembling ventricular fibrillation may be caused by patient movement or muscle tremor. Before you lunge for the defibrillator paddles, look at the patient. If he or she is alert and in no obvious distress, recheck the leads and equipment. Skill Drill 30-1 shows the steps for performing cardiac monitoring. Skill Drill 30-1. Cardiac monitoring. Step 1. Take routine precautions. Check your equipment. Ensure there are no loose pins in the end of the ECG cable, and the cable or lead wires are intact. Ensure the monitor has an adequate paper supply. Connect the ECG cable to the machine. Connect the lead wires to the ECG cable, if not already connected. Turn on the power to the monitor. Adjust the screen contrast if necessary. Step 2. Explain the procedure to the patient. To minimize distortion of the ECG tracing, prepare the skin for electrode placement by briskly rubbing it with a dry gauze pad to remove skin oils and improve impulse transmission. If you are applying electrodes to the patient's chest, rather than to his or her limbs, ensure good contact by shaving small amounts of chest hair if needed. Step 3. Attach the electrodes to the leads before placing them on the patient. Step 4. Position the electrodes on the torso of the patient. Step 5. Turn on the monitor and set it to lead 2. Adjust the ECG size, if necessary, to ensure the machine detects the patient's QRS complexes. Feel the patient's pulse, and compare it with the heart rate indicator on the monitor. If not already preset, set the heart rate alarms on the monitor according to your agency's policy. Step 6. Record the tracings. Step 7. Label each strip. This is the end of skill drill 30-1. The ECG leads. If you are performing continuous cardiac monitoring, there are 3 or 4 electrodes that should be placed on the patient's torso in the following manner. 1. White, right upper chest near the shoulder, or right arm for a 12 lead. 2. Black, left upper chest near the shoulder, or left arm for a 12 lead. 3. Red, left lower abdomen, or left leg for a 12 lead. 4. Green, sometimes available, right lower abdomen, or right leg for a 12 lead. Placing these 3 electrodes on the patient enables the ECG device to record the standard limb leads, 1, 2, 3, using the Einthoven triangle. Einthoven was a physicist who discovered that every time the heart contracts, it emits a tiny amount of electrical energy, which travels across the surface of the skin. Using electrodes and an ECG monitor, these waves of energy can be recorded and plotted on a piece of grid paper. Einthoven recorded 3 leads initially, leads 1, 2, and 3, where lead 1 was formed between the right and left arms, lead 2 between the right arm and left leg, and lead 3 between the left arm and left leg. When correctly positioned on the chest, these leads form a triangle around the heart, called the Einthoven triangle. Leads 1, 2, and 3 are bipolar leads. Bipolar leads are leads that contain a positive and negative pole. Lead 1 is formed between the right and left arm electrodes. The left arm electrode is the positive terminal. Lead 2 is formed between the right arm and left leg. The left leg electrode is the positive terminal. Lead 3 is formed between the left arm and left leg. The left leg electrode is the positive terminal. Any impulse in the body moving toward a positive electrode will cause a positive, upright, deflection on the ECG. Conversely, if an impulse is moving toward a negative electrode, or away from a positive electrode, it will result in a negative deflection on the ECG tracing. If the electrical impulse changes direction, you may see a biphasic waveform, which is above and below the isoelectric baseline. An impulse that is perpendicular to the lead will produce an isoelectric tracing or very little inflection in any direction. In a normal tracing, the flat horizontal PR, between the P wave and the QRS complex, ST, and TP segments form the baseline of the ECG. However, PR depression can occur with pericarditis and ST depression, and elevation can occur with cardiac ischemia, infarction, and other causes. Thus, the TP segment is typically used as the isoelectric line, 0 mV, to which all other segments can be compared to determine elevation or depression. Additional leads for a 12-lead ECG. Leads AVR, AVL, and AVF are augmented unipolar leads. Augmented unipolar leads contain one true pole, while the other end of the lead is referenced against a combination of other leads. They are created using the 4 limb electrodes. For example, lead AVR is the electrode at the right arm, referenced against the combination of the left arm and left leg electrodes. The precordial leads V1 to V6 are unipolar leads. The precordial leads are referenced against a calculated point known as the central terminal of Wilson. It is created by bisecting limb leads in the Einthoven triangle. The electrodes for the unipolar leads are the positive terminals for that lead. Recall that there is only one true pole in unipolar lead systems. The other end of the lead does not have polarity. For example, lead V1 is positive at the V1 electrode placement. The other end of the lead is the central terminal of Wilson, a calculated point. Reading an ECG rhythm strip. Part of your role as a paramedic will be to interpret ECG strips and be alert for dysrhythmias. Use a systematic approach and examine every strip the same way, which will assist with rhythm identification and ensure you will not overlook any important findings. By using such an approach, you will find, in most cases, that even the most complex appearing dysrhythmias can be reduced to simple terms and can be identified correctly. ECGs are recorded at a standardized speed of 25 mm per second, thus, a given distance on the graph paper represents a given time. Specifically, one small square, 1 mm, is equivalent to 0.04 second or 40 milliseconds. One large square, which consists of 5 small squares, is equivalent to 0.20 second or 200 milliseconds. 0.04 times 5 equals 0.20 second. There are 5 large blocks per second. The format of the 12-lead ECG. The gold standard for multi-lead ECGs is the 12-lead ECG. In special situations, a 15-lead ECG may also be performed. 12-lead ECGs have a common layout. A typical 12-lead ECG runs at a paper speed of 25 mm per second, although this can be changed in some in-hospital ECG machines for infrequent reasons. The speed will always be printed on the 12-lead ECG as confirmation. Each small block is 1 mm, and horizontally, time, this corresponds to 0.04 second, or 40 milliseconds. 5 small blocks make up one larger block, which corresponds to 0.2 second, or 200 milliseconds. 5 large blocks make up 1 second. The vertical axis on the graph paper represents the amplitude or gain of deflection in millivolts. The standard calibration for amplitude is 10 mm per millivolt, or 1 mm per 0.1 millivolt. A calibration box is printed at the beginning of all ECGs. The calibration box informs you about the paper speed and amplitude and measures 5 mm wide by 10 mm tall, representing the standard 25 mm per second paper speed and 10 mm per millivolt gain. 12-lead ECGs are usually printed using the same format as rhythm strips, namely, 25 mm per second paper and 10 mm per millivolt gain, with 4 columns by 3 rows with the leads in predictable positions. However, the leads are also labeled to ensure clarity. Each column captures approximately 2.5 seconds simultaneously for the 3 leads represented, and then the printing switches to the next 3 leads for 2.5 seconds, for a total of approximately 10 seconds. Although the printout only shows 2.5 seconds for each lead, it actually captures the information for all leads simultaneously for the entire 10 seconds. The computer interpretation, therefore, has an advantage as it can analyze the information for all 12 leads for the entire time. Some 12-lead ECGs also include 1 or more rhythm strips simultaneously to assist with rhythm analysis. Contiguous inferior leads. Lead 2 is contiguous with lead 3. Lead 3 is contiguous with leads 2 and AVF. Lead AVF is contiguous with lead 3. Contiguous septal anterior lateral leads. V1 is contiguous with V2. V2 is contiguous with V1 and V3. V3 is contiguous with V2 and V4. V4 is contiguous with V3 and V5. V5 is contiguous with V4 and V6. V6 is contiguous with V5 and lead 1. Lead 1 is contiguous with V6 and AVL. AVL is contiguous with lead 1. Components of an ECG complex. The components of an ECG rhythm correspond to electrical events occurring in the heart, as shown in Figure 30-32. The typical ECG complex includes a P wave, QRS complex, and a T wave. The next section will discuss each of these, as well as the segments and intervals outlined in Figure 30-33. P wave. The P wave is formed as the impulse is generated in the atria, usually the sinoatrial node in the right atrium, and represents atrial depolarization. It is characterized by a smooth, round, upright shape in leads 1 and 2 when it is coming from the sinoatrial node. It normally immediately precedes the QRS. The normal P wave duration is less than 110 milliseconds and the amplitude less than 2.5 millimeters tall. If there are no P waves, the pacemaker for the heart is not in the sinoatrial node, and one must consider the possibility of atrial fibrillation or a junctional or ventricular rhythm, discussed later in this chapter. If a P wave is present but not followed by a QRS complex, a block is present somewhere in the atrioventricular junction or below and is preventing conduction from the atria to the ventricles. P waves can give clues to the pacemaker site. P waves that vary in size and configuration mean that there are several pacemaker sites at different locations throughout the atria. The morphology and or whether they are upright or inverse can also give information that there is atrial enlargement or that the pacemaker is in an ectopic location not at the sinoatrial node. PR interval. The PR interval represents the time required for an impulse to traverse the atria and atrioventricular junction. It includes the slight delay that normally occurs when the impulse is slowed through the atrioventricular node, allowing time for ventricular filling. The PR interval is measured from the start of the P wave to the point at which the QRS complex begins. Although it normally lasts 0.12 to 0.20 second, or 120 to 200 milliseconds, 3 to 5 small squares on the ECG strip, the PR interval may be prolonged and give clues that there is a first-degree nodal block. A PR interval that exceeds 0.20 second, 5 small squares, for example, is called first-degree atrioventricular block, and may indicate injury to the atrioventricular junction, and a PR interval of less than 0.12 seconds suggests ventricular pre-excitation. QRS starts early, via an accessory pathway such as in Wolff-Parkinson-White syndrome. Wolff-Parkinson-White will be discussed in greater detail later in this chapter. A variable PR interval may indicate either a wandering atrial pacemaker, variable P wave morphology, or a second-degree atrioventricular nodal block. The PR segment usually follows the baseline or isoelectric line, but PR depression may occur with pericarditis. Therefore, the TP segment should be used as the isoelectric line, 0 mV, to which the other segments can be compared to look for elevation or depression. QRS complex. In healthy people, the QRS complex is narrow, with sharply pointed waves, and has a duration of less than 0.12 second, or 120 milliseconds, 3 small squares on the ECG strip. Such a complex indicates that conduction of the impulse has proceeded normally from the atrioventricular junction through the bundle of his left and right bundles, and the Purkinje system. If abnormal, the complex has a bizarre appearance, and a duration longer than 0.12 second, or 120 milliseconds. It signifies some abnormality in conduction through the ventricle, as in a bundle branch block. The first negative deflection in the QRS is called a Q wave. This wave represents conduction through the ventricular septum. The Q wave should last no more than 0.04 second, or 40 milliseconds, and should be less than 1/3 the overall height of the QRS complex. The electricity spreads from right to left through the septum. The first positive deflection of the QRS is referred to as the R wave. Most of both ventricles are depolarized during the R wave. The R wave may be wide if the ventricle is enlarged and may be abnormally high if ventricular hypertrophy is present. The S wave is any negative deflection after the R wave. If the S wave is abnormally large, it may indicate hypertrophy of the ventricles. If there is a second positive deflection, it is called an R' wave. R' waves are never normal, and they indicate trouble in the conduction system of the ventricle. Q waves are abnormal or pathologic if they're one small square, 0.04 second, 400 milliseconds, wide on the ECG strip. Similarly, if they're deeper than 1/3 of the total height, amplitude, of the QRS complex, in lead 2, they are abnormal. This finding is significant when looking at 12-lead ECGs because it may indicate a current or previous acute myocardial infarction. J point. The J point is the junction or point in the ECG where the QRS complex ends, and the ST segment begins. Thus, it represents the end of ventricular depolarization, and the apparent beginning of ventricular repolarization. Locating the J point is important because it makes it easier to identify the ST segment, and is often depressed or elevated when the myocardium is ischemic. J-point changes will be discussed with 12-lead ECG interpretation. ST segment. The ST segment, which is the line between the QRS complex and the beginning of the T wave, is normally isoelectric. An ST segment that is significantly greater than 1 mm or 1 small square above or below the isoelectric line is highly suggestive of myocardial ischemia or injury, although a full 12-lead ECG is required to determine the precise significance of ST segment elevation or depression. T wave. A T wave represents ventricular repolarization. The T wave should be asymmetric, less than 1/2 the overall height of the QRS complex, and oriented in the same direction as the overall QRS complex. For example, if the QRS complex is predominantly upright, the T wave should be predominantly upright. The T wave consists of two halves. The first half, closest to the QRS complex, represents a period of time called the absolute refractory period. During the absolute refractory period, the ventricles have not sufficiently repolarized to enable another depolarization. A helpful analogy is flushing a toilet. If you flush a toilet, and then immediately try to flush it again, does the toilet flush? No. Why? Because the tank has not yet filled back up with water. The second half of the T wave represents the relative refractory period. The relative refractory period indicates that some cells have repolarized sufficiently to depolarize again. Now think about flushing the toilet, and waiting 15 seconds before flushing again. What happens this time? You get a partial flush because perhaps 1/2 the tank was able to fill with water before you flushed it again. So, during the absolute refractory period, nothing can stimulate the ventricles to contract again at that moment in time. During the relative refractory period, however, a large stimulus can initiate depolarization of those cells that are repolarized and may result in a dangerous heart rhythm. The latter is the reason that synchronized buttons, sync, are used during cardioversion of a rhythm so that the shock will not be delivered during the precarious part of the T wave, known as R on T, causing ventricular fibrillation. TP segment. The TP segment is generally regarded to be the isoelectric line or baseline. Although the baseline is neither positive or negative, there is still electrical activity, movement of ions, in the myocardium. Perhaps a better phrase to describe the baseline would be a period of equal negative and positive electrical activity. The baseline is generally a flat, straight, horizontal line that begins at the end of the T wave and ends at the start of the P wave. The baseline is the reference point to which you compare the J point and ST segment. QT interval. The QT interval represents all the electrical activity of one complete ventricular cycle, that is, ventricular depolarization and repolarization. It begins with the onset of the Q wave and ends with the T wave as it comes back to the isoelectric line. If there is no Q wave, measurements begin with the R wave. The QT interval normally lasts 0.36 to 0.44 seconds, or 360 to 440 milliseconds. The QT interval varies with gender and age and is dependent on the heart rate, with the QT being shorter with a rapid heart rate. Thus, a formula is used to correct the QT measurement to a heart rate of 60 for comparison. 12-lead ECG computer interpretation accurately calculates this and lists it as QTC. A prolonged QT interval, long QT syndrome, indicates that the heart is experiencing an extended refractory period, making the ventricle more vulnerable to dysrhythmias. Such prolongation may occur with administration of some medications, hypocalcemia, an acute myocardial infarction, pericarditis or congenital conditions. Conversely, the QT interval may occur with administration of some medications, some antidysrhythmics, antibiotics, antifungals, antipsychotics, antidepressants, antihistamines, some electrolyte disturbances, hypokalemia, hypocalcemia, or congenital conditions. Prolonged QT is associated with dysrhythmias, especially torsades de pointe, which may be fatal if not treated immediately. Long QT syndrome is a genetic condition characterized by a QT interval exceeding approximately 0.45 second 450 milliseconds. Long QT syndrome predisposes the patient to ventricular dysrhythmias, which can result in syncope and sudden cardiac arrest. Patients with long QT syndrome are at increased risk for ventricular dysrhythmias, including torsades de pointe and ventricular fibrillation. EMS is often called to treat patients who experience syncope, palpitations, or sudden death. It is critical to record an ECG on all patients experiencing syncope, including younger patients. Approach to reading an ECG rhythm. You will usually exclusively use lead 2 to perform rhythm interpretation. Here, a 5-step method is presented. 1. Identify the waves, P, QRS, T. 2. Measure the PR interval. 3. Measure the QRS duration. 4. Determine rhythm regularity. 5. Measure the heart rate. Using 120 milliseconds, 0.12 second, as the cutoff between narrow and wide QRS complexes will help to differentiate between whether the rhythm is supraventricular or ventricular, or supraventricular with aberrant conduction. When identifying the P waves, note whether they are upright and within normal parameters or absent, such as in sinus arrest, atrial fibrillation, or junctional or ventricular rhythms. The PR interval may show evidence of atrioventricular nodal delay, atrioventricular blocks, or suggest the potential presence of Wolff-Parkinson-White syndrome. Is there only one P wave for every QRS complex? This will determine if there is atrioventricular association, sinus, and intermittent association, second-degree atrioventricular blocks, or atrioventricular dissociation, third-degree block. Rhythm regularity. A rhythm can be regular, regularly irregular, or irregularly irregular. Determining rhythm regularity is simple. Measuring the distance between R waves is one method used to evaluate rhythm regularity. If the RR interval is exactly the same between the QRS complexes, the rhythm is regular. When the RR intervals are not all the same, the rhythm is irregular. You can separate the irregular rhythm further. If no two RR intervals are equidistant, the rhythm is irregularly irregular, for example atrial fibrillation. If the R waves are irregular, but appear to follow a pattern, the rhythm is regularly irregular. For example, you obtain the following data when measuring the distance between R waves. 25 mm, 35 mm, 25 mm, 25 mm, 35 mm, 25 mm. This represents a regularly irregular rhythm. ECG calipers or the edge of a piece of paper may be used as the ruler. Determining heart rate. This section describes some of the more common methods of using a cardiac rhythm strip to determine heart rate. The 6-second method. The 6-second method is the fastest method to measure heart rate from the ECG. Use this method for regular or irregular rhythms. In fact, it is the best method for calculating heart rate when the rhythm is irregular. Count the number of QRS complexes in a 6-second strip, and multiply that number by 10 to obtain the rate per minute. The sequence method. The sequence method should be used to determine the heart rate only when the rhythm is regular. First, memorize the following sequence: 300, 150, 100, 75, 60, 50. Find an R wave on a heavy line, large square, and count off 300, 150, 100, 75, 60, 50 for each large square you land on until you reach the next R wave. Estimate the rate if the second R wave does not fall exactly on a heavy black line. As an example, if the R waves of two successive QRS complexes are 3 boxes apart, the heart rate is approximately 100 beats per minute. If the RR interval spans fewer than 3 large squares, the rate is greater than 100, tachycardia. If it covers more than 5 large squares, the rate is less than 60, bradycardia. The 1500 method. The 1500 method is the most accurate way to calculate the heart rate from the ECG. It is typically used when the heart rate exceeds 150 beats per minute, and only when the rhythm is regular. Calculate the rate by counting the number of small boxes between any two QRS complexes, the RR interval, and then divide 1500 by that number. In Figure 30-44, for example, there are approximately 23 small boxes between two successive QRS complexes. 1500 divided by 23 equals 65. This calculation yields a rate of approximately 65 beats per minute. Specific cardiac dysrhythmias. As discussed earlier, cardiac dysrhythmias can be induced by a variety of causes. Ischemia, infarction, or scarring can lead to conduction problems such as atrioventricular node blocks or bundle branch blocks. Alternatively, ischemia and infarction can also lead to ectopic foci causing premature beats. A number of factors can contribute to premature beats and other dysrhythmias. Some dysrhythmias such as ventricular fibrillation lead to cardiac arrest. Bradycardias and tachycardias may cause reduced cardiac output and subsequent ischemia and shock. Other dysrhythmias, such as atrial fibrillation, rarely cause death directly but can lead to secondary morbidity via thrombotic complications such as stroke. Rhythms of the sinoatrial node. Normal sinus rhythm. The sinoatrial node is the primary pacemaker for the heart. A normal sinus rhythm arises in the sinoatrial node, has an intrinsic rate of 60 to 100 beats per minute. The rhythm is regular, with minimal variation between RR intervals. An upright P wave precedes each QRS complex. The PR interval measures 0.1 to 0.20 second, 120 to 200 milliseconds. The QRS complex measures 0.11 second, 110 milliseconds, or less. Sinus bradycardia. In sinus bradycardia, the pacemaker is still the sinoatrial node, but with a rate of less than 60 beats per minute. The rhythm is regular, and an upright P wave precedes each QRS complex. The PR interval is 0.12 to 0.20 second, 120 to 200 milliseconds. The QRS complex is 0.11 second, 110 milliseconds, or less. A very slow heart rate, usually less than 50 beats per minute, leads to inadequate cardiac output, and often precipitates electrical instability of the heart. Furthermore, when the sinus rate becomes very slow, ectopic pacemakers in the atrioventricular junction or ventricles may fire, and produce escape beats to assist in maintaining cardiac output. Sinus bradycardia can be an asymptomatic phenomenon in healthy adults and conditioned athletes and may occur during sleep. More serious causes include hypothermia, sinoatrial node disease, acute myocardial infarction, which may stimulate vagal tone, parasympathetic stimulation, increased intracranial pressure, and use of beta blockers, calcium channel blockers, morphine, quinidine, including interactions between quinidine and some calcium channel blockers, or digoxin. In general, treatment focuses on the patient's tolerance to the bradycardia and looking for causative factors. Atropine may be necessary. Patients who are symptomatic and do not respond to atropine may require a transcutaneous pacemaker to assist the heart in increasing its ventricular rate. Transcutaneous cardiac pacing will be discussed later in the chapter. Sinus tachycardia. By definition, a tachycardia has a ventricular rate faster than 100 beats per minute. With sinus tachycardia, the sinoatrial node is still the pacemaker, but the heart rate is typically 101 to 180 beats per minute in a resting adult. Experts note that the upper rate of sinus tachycardia is age-related and can be calculated as approximately 220 beats per minute minus the patient's age in years. The rhythm is regular, and an upright P wave precedes each QRS complex, although it is occasionally difficult to see if it is partially buried in the T wave of the beat before it. The PR interval is 0.12 to 0.20 second, 120 to 200 milliseconds. The QRS complex is 0.11 second, 110 milliseconds, or less. Sinus tachycardia may result from a variety of causes, including pain, fever, hypoxia, hypovolemia, exercise, sympathetic nervous system stimulation, caused by stress, fright, or anxiety, acute myocardial infarction, pump failure, or anemia. In addition, caffeine, nicotine, alcohol, and certain medications, such as atropine, epinephrine, amphetamine, and cocaine, can cause tachycardia. Hypoxia, metabolic alkalosis, hypokalemia, and hypocalcemia can lead to electrical instability, prompting the firing of cells that normally do not generate impulses. Prolonged tachycardia increases the work of the heart, leading to further ischemia during an acute myocardial infarction. In addition, cardiac output may be significantly reduced when the heart rate exceeds 150 beats per minute because the ventricles do not have enough time between contractions to fill completely with blood. The treatment of sinus tachycardia is related to the underlying cause. Sinus dysrhythmia. Sinus dysrhythmia is a slight variation in cycling of a sinus rhythm, usually one that exceeds 0.12 second, 120 milliseconds, between the longest and shortest cycles, that is often associated with respiratory cycle fluctuations. The rate increases during inspiration, and decreases during expiration. The sinoatrial node is still the pacemaker, and an upright P wave precedes each QRS complex. A PR interval of 0.12 to 0.20 second, 120 to 200 milliseconds, and a QRS complex of 0.11 second, 110 milliseconds, or less are the same as in a normal sinus rhythm. Sinus dysrhythmia is often a normal finding in children and young adults and tends to diminish with age. Sinus dysrhythmia is usually due to changes in the heart rate with the respiratory cycle, and is more prominent and normal in children and young adults. It tends to diminish or disappear with age. Sinus dysrhythmia is often somewhat more prominent with fluctuation in the respiratory cycle because the heart rate accelerates with inspiration, and slows with expiration. Increased filling pressures of the heart during inspiration stimulate the Bainbridge reflex, which increases the heart rate, and is partially responsible for respiratory sinus dysrhythmia. The increased filling pressure on the heart increases stroke volume, remember the Frank-Starling mechanism, and blood pressure. The increase in blood pressure stimulates the baroreceptor reflex, baroreflex, which attempts to block the rate increase caused by the Bainbridge reflex. In this way, the baroreflex inhibits the respiratory sinus dysrhythmia. Sinus arrest. Sinus arrest occurs when the sinoatrial node fails to initiate an impulse, eliminating the P wave, QRS complex, or an T wave for one cardiac cycle. After this missed set of waveforms, the sinoatrial node resumes normal functioning as if nothing ever happened. In sinus arrest, the atrial and ventricular rates are usually within normal limits, and the rhythm is regular except for the absent complexes. P waves are present and upright, preceding every QRS complex, and the PR interval, when present, is 0.12 to 0.20 second, 120 to 200 milliseconds. The QRS complex, when present, is 0.11 second, 110 milliseconds, or less. Possible causes of sinus arrest include ischemia of the sinoatrial node, increased vagal tone, carotid sinus massage, and the use of medications such as digitalis and quinidine. Occasional episodes of sinus arrest are not significant, however, if the heart rate drops below 60 beats per minute, cardiac output may fall, and an ectopic focus from either the atrioventricular junction or the ventricles may take over. In such a case, treatment is based on the patient's overall heart rate and tolerance. He or she may benefit from a temporary pacemaker, a transcutaneous pacer in the pre-hospital setting, or a permanent pacemaker after admission to the medical facility. 6. Sinus syndrome. 6. Sinus syndrome encompasses a variety of rhythms that involve a poorly functioning sinoatrial node, and is common in older patients. On an ECG, 6. Sinus syndrome announces itself in many ways, including sinus bradycardia, sinus arrest, sinoatrial block, and alternating patterns of extreme bradycardia and tachycardia, bradycardia-tachycardia syndrome. Patients may remain asymptomatic or they may experience a syncopal or near syncopal episode, dizziness, and palpitations. Rhythms of the atria. Although the sinoatrial node is normally the pacemaker for the heart, any area of the atria may originate an impulse, thereby superseding the pacemaking authority of the sinoatrial node. Some rhythms originating from the atria produce upright P waves that precede each QRS complex, but they are not as well-rounded as those generated by the sinoatrial node. Wandering atrial pacemaker. In wandering atrial pacemaker, as the name suggests, the pacemaker of the heart moves from the sinoatrial node to various areas within the atria or atrioventricular junction. Wandering atrial pacemaker usually has a rate of 60 to 100 beats per minute. The rhythm is slightly irregular, with variations between RR intervals based on the site of the pacemaker for that particular complex. An upright P wave precedes each QRS complex, however, its shape varies, indicating multiple sites of origin. The definition of wandering atrial pacemaker requires the presence of at least 3 different shapes of P waves within one ECG strip. The PR interval measures 0.12 to 0.20 second, 120 to 200 milliseconds, but will also vary slightly based on the origin of the particular complex. The QRS complex will measure 0.11 second, 110 milliseconds, or less. Wandering atrial pacemaker is most often seen in children, older adults, and athletes. Treatment is usually not indicated in the pre-hospital setting unless the dysrhythmia is associated with a slow rate, and the patient is symptomatic. Under those circumstances, treatment is the same as for symptomatic sinus bradycardia. Premature atrial complex. A premature atrial complex is not, strictly speaking, a dysrhythmia, but rather an ectopic complex that appears within another rhythm. A premature atrial complex occurs earlier than the next expected sinus complex, producing an abnormally short RR interval between it and the previous complex. The presence of a premature atrial complex will make the rhythm irregular. An upright P wave precedes each QRS complex, however, its shape differs from the shapes of the P waves originating from the sinoatrial node, indicating its different site of origin. The PR interval measures 0.12 to 0.20 second, 120 to 200 milliseconds, but may vary slightly based on the origin of the premature complex. The QRS complex measures 0.11 second, 110 milliseconds. Premature atrial complexes are very common and can be caused by stress, stimulants such as caffeine, or conditions such as heart failure or electrolyte imbalance. When premature atrial complexes are frequent, treatment is focused on correcting the underlying cause. Supraventricular tachycardia. Supraventricular tachycardia is a rhythm originating from a site above the ventricles with a ventricular rate faster than 100 beats per minute at rest. In patients with normal ventricular function, tachycardia with a rate of less than 150 beats per minute rarely causes serious signs and symptoms. However, when the ventricular rate exceeds 150 beats per minute, ventricular filling time is reduced, which can in turn reduce cardiac output. When the ventricular rate reaches 150 to 180 beats per minute, the P waves, if present, with supraventricular tachycardia tend to be completely obscured by the T wave of the preceding beat, making it impossible to measure the PR interval. At a lower heart rate, P waves can be identified. The rhythm is regular, with essentially no variation between RR intervals. The QRS complexes measure 0.11 second, 110 milliseconds, or less, indicating that the rhythm originates above the ventricles. Atrial flutter. Atrial flutter is a rhythm in which an atrial impulse fires at a rate much too rapid for the ventricles to keep up. The atrial complexes in atrial flutter are known as flutter or F waves, rather than P waves. F waves have a distinctive shape, resembling a sawtooth or picket fence. In atrial flutter, one or more of the F waves is blocked by the atrioventricular node, resulting in several flutter waves before each QRS complex. The rhythm may be regular, most common, with a constant, usually 2:1, conduction, typically at a rate of exactly 150, or irregular if the conduction of impulses to the ventricles varies. The PR interval will measure 0.12 to 0.20 second, 120 to 200 milliseconds, for conducted complexes. The QRS complex will measure 0.11 second, 110 milliseconds, or less. Atrial flutter is usually a sign of a serious heart problem. In many cases, it is a transient rhythm that degenerates into atrial fibrillation. Treatment generally consists of medication or electrical cardioversion, although neither of these measures is usually attempted in the pre-hospital environment unless the patient's condition is very critical and transport time is long. Atrial fibrillation. Atrial fibrillation is a rhythm in which the atria no longer contract, but rather fibrillate, or quiver, without any organized contraction. It occurs when many different cells in the atria depolarize independently, rather than in response to an impulse from the sinoatrial node. The result of this random depolarization, which occurs throughout the atria, is a fibrillating or chaotic baseline. In atrial fibrillation, there are usually no visible P waves on the ECG strip and, hence, no PR interval to measure. Instead, one of the hallmarks to identifying this condition is its irregular appearance. Because the atrioventricular node is bombarded with impulses from the fibrillating atria, it allows impulses to pass onto the ventricles in a random manner, which results in the highly irregular ventricular rhythm. The QRS complex typically measures 0.11 second, 110 milliseconds, or less. Atrial fibrillation is not usually a sign of a serious heart problem, and is a fairly common rhythm among older patients. One of the main hazards associated with this dysrhythmia is that the blood within the fibrillating atria has a tendency to form small clots, which may then become emboli and block circulation elsewhere in the body. Because of this risk, many patients whose normal rhythm is atrial fibrillation take an anticoagulant medication to prevent strokes from thrombotic emboli. They are also commonly on rate-controlling agents such as beta blockers or calcium channel blockers. Although younger patients with atrial fibrillation may be converted to sinus rhythm, older patients are typically rate-controlled rather than rhythm-controlled. Pre-hospital treatment of atrial fibrillation is usually limited to supportive care. Electrical cardioversion is rarely emergently required. Multifocal atrial tachycardia. In multifocal atrial tachycardia, multiple ectopic sites within the atria depolarize at different but rapid rates. Multifocal atrial tachycardia is characterized by a rate of more than 100 beats per minute and is, in effect, a tachycardic wandering atrial pacemaker. The rhythm is irregular, with variation between RR intervals based on the site of the pacemaker for that particular complex. An upright P wave precedes each QRS complex, however, its shape varies, indicating multiple sites of origin. The PR interval measures 0.12 to 0.20 second, 120 to 200 milliseconds, but also varies slightly based on the origin of the particular complex. If the multifocal atrial tachycardia increases to a rate exceeding 150 beats per minute, then the P wave may no longer be visible. Thus, the only indication of the rhythm may be the irregularity associated with the varying sites of origin within the atria. The QRS complex measures 0.11 second, 110 milliseconds, or less. Multifocal atrial tachycardia is most often seen in patients with significant lung disease, pulmonary hypertension, coronary disease, valvular heart disease, and hypomagnesemia, as well as patients undergoing theophylline therapy. Because therapies aimed at correcting supraventricular tachycardia are usually ineffective with multifocal atrial tachycardia, treatment is usually deferred until arrival at the emergency department. Atrioventricular nodal reentrant tachycardia and atrioventricular reciprocating tachycardia. Atrioventricular nodal reentrant tachycardia and atrioventricular reciprocating tachycardia are usually recognized by regular, narrow, complex tachycardias without obvious P waves preceding every complex, excluding sinus tachycardia, atrial flutter, and atrial fibrillation. They are often termed paroxysmal supraventricular tachycardia, which reflects its tendency to begin and end abruptly. Paroxysmal means occurring in spasms. Atrioventricular nodal reentrant tachycardia is the most common paroxysmal supraventricular tachycardia, and is caused by a re-entry circuit within or near the atrioventricular node, allowing the tachycardia to start, and then continue without a P wave preceding each complex. Retrograde P waves may follow and be hidden in the T wave. Atrioventricular reciprocating tachycardia is a similar appearing tachycardia that results from an accessory pathway that connects the atria to the ventricles, and impulses can travel in a similar circuit between the atrioventricular node and the accessory pathway. Wolff-Parkinson-White syndrome is an example of this. In most cases, the ECG alone cannot differentiate these two mechanisms, and as long as the rhythm is regular and narrow, they can be managed the same. Rhythms of the atrioventricular node or atrioventricular junction. If the sinoatrial node, the body's dominant pacemaker, fails to initiate an impulse, then the atrioventricular junction may take over as pacemaker of the heart. Because the atrioventricular junction is a secondary pacemaker, its intrinsic rate is slower than that of the sinoatrial node. As a result, junctional rhythms normally have a rate of 40 to 60 beats per minute. When an impulse is generated in the atrioventricular junction, it travels down through the conduction system into the ventricles as if it had come from the sinoatrial node, resulting in normal QRS complexes. At the same time, the impulse travels upward, through the atria, and the internodal pathways toward the sinoatrial node. There are, then, three possible circumstances, none associated with an upright P wave, in which the QRS complex appears normal. If the impulse begins moving upward through the atria before the other part of it enters the ventricles, an upside-down P wave will be visible. It is upside down because the impulse is traveling in the opposite direction from that which generates normal, upright P waves. This P wave is usually followed immediately by the QRS complex. If the impulse moving through the atria occurs at the exact same time as the impulse is traveling through the ventricles, the smaller inverted P wave will be buried within the larger QRS complex. This will give the appearance of a missing P wave, that is, the baseline remains flat until the beginning of a normal QRS complex. The impulse may start late through the atria and result in an inverted P wave appearing after the QRS complex. Because the intrinsic rate of the atrioventricular node is 40 to 60, junctional rhythms normally present with rates of 40 to 60 beats per minute. Junctional escape rhythm. A junctional rhythm occurs when the sinoatrial node ceases to function, and the atrioventricular junction takes over as the pacemaker of the heart at a rate of 40 to 60 beats per minute. A junctional escape rhythm is usually regular, with little variation between RR intervals. The P wave may be absent or inverted before or after the QRS complex. If an inverted P wave is present before the QRS, then the PR interval will measure less than 0.12 second, 120 milliseconds. The QRS complex measures 0.11 second, 110 milliseconds, or less. A junctional rhythm often accompanies sinoatrial node disease, increased vagal tone, valvular heart disease, inferior wall myocardial infarction, and other conditions, or it can occur after resuscitation from cardiac arrest. Because of the slow rate, treatment in symptomatic patients depends on the underlying cause, and may require a surgically implanted pacemaker. In the field, atropine should be considered, and transcutaneous pacing may be necessary if the patient's condition is severely compromised. Accelerated junctional rhythm. Occasionally, a junctional rhythm will present with a rate that exceeds its normal upper rate of 60 beats per minute but remains less than 100 beats per minute. In this case, the name given to the rhythm is accelerated junctional rhythm. An accelerated junctional rhythm is regular, with little variation between RR intervals. The P wave may be absent or, if present, be inverted before or after the QRS complex. The PR interval, if an inverted P wave is present before the QRS, will measure less than 0.12 second, 120 milliseconds. The QRS complex will measure 0.11 second, 110 milliseconds, or less. The patient with an accelerated junctional rhythm is usually asymptomatic. The rate is usually fast enough to maintain a reasonable cardiac output, and seldom requires treatment in the pre-hospital setting. Nevertheless, he or she should be closely monitored. Junctional tachycardia. Occasionally, a junctional rhythm will present with a rate that exceeds 100 beats per minute. Any rhythm that results in a ventricular rate greater than 100 beats per minute is referred to as tachycardia. In this case, the rhythm is termed junctional tachycardia. Junctional tachycardia is also regular, with little variation between RR intervals. The P wave, if present, is inverted or upside down but may appear to be absent. The PR interval, if an inverted P wave is present, will measure less than 0.12 second, 120 milliseconds. The QRS complex will measure 0.11 second, 110 millisieverts, or less. Junctional tachycardia is serious, but it seldom requires treatment in the pre-hospital setting because the rate is usually fast enough to maintain a reasonable cardiac output. If the rate exceeds 150 beats per minute, however, the cardiac output could be negatively affected. In such a case, the rhythm is rarely junctional and is referred to as supraventricular tachycardia. Premature junctional complex. Premature junctional complex is not, strictly speaking, a dysrhythmia, just as premature atrial complex is not, but rather an early complex that appears within another rhythm. Premature junctional complexes are also known as ectopic complexes, meaning that they arise from a site other than the sinoatrial node. A premature junctional complex also occurs earlier in time than the next expected sinus complex, causing the RR interval between it and the previous complex to be shorter. The rate depends on the underlying rhythm, and the premature junctional complex will make the rhythm irregular. The P wave, if present, will be inverted and may either precede or follow the QRS complex. The PR interval, if present, will measure less than 0.12 second. The QRS complex measures 0.11 second or less. Premature junctional complexes can be caused by many of the same problems that cause premature atrial complexes. They are rarely treated in the pre-hospital setting, but may be a predictor of future cardiac dysrhythmias. Atrioventricular blocks. After the sinoatrial node initiates impulses, the impulses proceed through the atria and ventricles and result in contraction of the heart. When they reach the atrioventricular node, the impulses are delayed to allow the atria to contract and fill the ventricles. This delay is a normal function of the atrioventricular node, and usually causes no signs or symptoms. Occasionally, however, the impulses traveling through the atrioventricular node are delayed more than usual, resulting in atrioventricular blocks. Atrioventricular blocks are classified into different degrees based on the seriousness of the block and the amount of myocardial damage. The least serious atrioventricular block is a first-degree atrioventricular block. The most serious is a third-degree block. In between are two types of second-degree blocks. First-degree atrioventricular block. A first-degree atrioventricular block occurs when each impulse reaching the atrioventricular node is delayed slightly longer than is expected and results in a PR interval greater than 0.20 second, 200 milliseconds. Because each impulse eventually passes through the atrioventricular node, generating a QRS complex, this block is considered the least serious. Nevertheless, it is often the first indication of damage that has occurred to the atrioventricular node. Because it originates from the normal pacemaker of the heart, First-degree atrioventricular block usually has an intrinsic rate of 60 to 100 beats per minute, although it typically occurs at the low end of this range. The rhythm is regular, with minimal variation between RR intervals. An upright P wave precedes each QRS complex. Its shape and size may vary, depending on the underlying rhythm. The PR interval will measure greater than 0.20 second, 200 milliseconds, and is constant in duration. The QRS complex will measure 0.11 second, 110 milliseconds. The primary difference between first-degree atrioventricular block and normal sinus rhythm is the prolonged PR interval. First-degree atrioventricular block is rarely treated in the pre-hospital setting unless it is associated with bradycardia that results in significantly reduced cardiac output. Second-degree atrioventricular block. Mobitz type 1, Wenckebach. A second-degree atrioventricular block occurs when an impulse reaching the atrioventricular node is occasionally prevented from proceeding to the ventricles and generating a QRS complex. Second-degree atrioventricular block, Mobitz type 1, Wenckebach, occurs when each successive impulse is delayed a little longer, until finally one impulse is not allowed to continue. Because it begins from the normal pacemaker of the heart, Mobitz type 1 block usually has an intrinsic rate of 60 to 100 beats per minute, although it typically occurs at the low end of this range. The rhythm is irregular, with a prolonged RR interval occurring between the last QRS complex before the blocked P wave, and the QRS complex after the first unblocked P wave. The P wave is present and upright, and it precedes most QRS complexes. The PR interval starts out within the normal limits of 0.12 to 0.20 second, 120 to 200 milliseconds, but, with each successive P wave, grows longer. It finally results in a P wave that is followed not by a QRS complex, but by another P wave. This P wave is then followed by a QRS complex with a normal PR interval. This pattern repeats over and over in the rhythm. The QRS complex measures 0.11 second, 110 milliseconds, or less. The key to identification of Mobitz type 1 block atrioventricular block is the recognition of the increasing PR interval followed by the P wave without a QRS complex. This rhythm is always irregular, and you can often easily see the wide RR interval with the extra P wave located there. Mobitz type 1 blocks are treated in the pre-hospital setting only if they're associated with bradycardia that results in significantly reduced cardiac output. Second-degree atrioventricular block. Mobitz type 2, classical. Second-degree atrioventricular block, Mobitz type 2, occurs when several impulses are not allowed to continue. It is sometimes called classical because it was well known before the Wenckebach atrioventricular block was discovered. Because it originates from the normal pacemaker of the heart, Mobitz type 2 block usually has an intrinsic rate of 60 to 100 beats per minute, although it typically occurs at the low end of this range. The rhythm may be regular, with every other P wave blocked, or irregular, with a prolonged RR interval between the last QRS complex before the blocked P wave, and the QRS complex after the first unblocked P wave. The P wave is present and upright, and it precedes some QRS complexes. The PR interval is always constant. In fact, this is the easiest way to identify a Mobitz type 2 atrioventricular block. If you see a rhythm with some non-conducted P waves, but the PR interval is constant among all conducted P waves, and their corresponding QRS complexes, you have identified a second-degree type 2 atrioventricular block. It is important to remember that this block can be regular or irregular. Sometimes several normal beats will occur without a non-conducted P wave, sometimes two or more non-conducted P waves may appear before one P wave is conducted. In other situations, a pattern develops that consists of one conducted P wave followed by one non-conducted P wave. Second-degree type 2 atrioventricular blocks are treated in the pre-hospital setting only if they're associated with bradycardia that results in significantly reduced cardiac output. Although second-degree type 2 atrioventricular block with symptoms may respond to medications, transcutaneous pacing is occasionally required. Third-degree atrioventricular block, complete atrioventricular block. A third-degree atrioventricular block occurs when all impulses reaching the atrioventricular junction are prevented from proceeding to the ventricles and generating a QRS complex. Unlike in first and second-degree atrioventricular blocks, in a third-degree atrioventricular block, all impulses from the atria are prevented from traveling to the ventricles. As a consequence, this block is also known as a complete atrioventricular block. Because all impulses from the atria are blocked, the ventricles will develop their own pacemaker to continue circulation of blood, albeit at a greatly reduced rate. Because it originates from the normal pacemaker of the heart, third-degree atrioventricular block usually has an intrinsic atrial rate of 60 to 100 beats per minute, but the ventricular rate, which depends on the activity of a ventricular pacemaker, is 40 to 60 beats per minute if the pacemaker originates in the atrioventricular junction and 20 to 40 beats per minute if it originates in the ventricles. The rhythm is usually regular, with the PP and RR intervals being consistent. The P wave is present and upright. The PR interval in this type of atrioventricular block is non-existent. The classic way of identifying a third-degree atrioventricular block is to identify the presence of non-conducted P waves, and then to be unable to identify a relationship between the P waves and the QRS complexes. Because the ventricular rate depends on the presence of a ventricular pacemaker, it is common to see the QRS complexes in a third-degree atrioventricular block that are wider than 0.12 second, 120 milliseconds. When you see QRS complexes with a regular RR interval, and totally independent of the P waves with a regular PP interval, you should suspect a third-degree atrioventricular block. If the rhythm is regular and the PR interval is not constant, it is almost certainly a third-degree atrioventricular block. One challenge in diagnosing third-degree atrioventricular blocks to be regular is the fact that if a PVC, described later, occurs within the block, it will make the block appear irregular. Third-degree atrioventricular blocks are treated in the pre-hospital setting only if they are associated with bradycardia that results in significantly reduced cardiac output. If the QRS complexes are wide, the rhythm typically will not respond to atropine, and the patient will usually require transcutaneous pacing. However, if the QRS complexes are narrow, they are usually from the atrioventricular node or high in the bundle of His and may respond to atropine. Rhythms of the ventricles. If the sinoatrial node fails to initiate an impulse, the atrioventricular junction will usually take over as pacemaker. If the atrioventricular junction cannot perform this duty, however, the ventricles may begin to originate their own impulses, and become the pacemaker of the heart. Such ventricular rhythms will have missing P waves, and wide QRS complexes. If an impulse is generated in the ventricles, it must travel through the ventricles in a cell-to-cell manner because the cell originating the impulse is unlikely to be located on the conduction system. Because impulses travel more slowly via cell-to-cell transmission than when they travel on the conduction system, ventricular-initiated impulses result in very wide QRS complexes, more than 0.12 second, 120 milliseconds, in duration. Because the intrinsic rate of the ventricles is 20 to 40, ventricular rhythms normally demonstrate rates of 20 to 40 beats per minute. Idioventricular rhythm. An idioventricular, produced by the ventricles, rhythm occurs when the sinoatrial and atrioventricular nodes fail, and the ventricles must take over pacing the heart. It has a rate of 20 to 40 beats per minute owing to the intrinsic rate of the ventricles as pacemakers. An idioventricular rhythm is usually regular, with little variation between RR intervals. P waves are absent owing to the failure of the sinoatrial and atrioventricular nodes. Because there is no P wave, there is no PR interval. The QRS complex will measure 0.12 second, 120 milliseconds, or more because it originates in the ventricles. Idioventricular rhythms are serious and may or may not result in a palpable pulse. Treatment is geared toward improving the cardiac output by increasing the rate and, if possible, treating the underlying cause. In such a case, the patient's condition is usually severely compromised. Accelerated idioventricular rhythm. Occasionally, an idioventricular rhythm exceeds its normal upper rate of 40 beats per minute but remains less than 100 beats per minute. Because the rhythm is greater than 40 beats per minute, it cannot be considered a normal ventricular rhythm. Because it is less than 100 beats per minute, it cannot be called tachycardia either. In this case, the rhythm is called an accelerated idioventricular rhythm. An accelerated idioventricular rhythm is also regular, with little variation between RR intervals. The P waves are absent, so the PR interval does not exist. The QRS complex measures 0.12 second, 120 milliseconds, or more. Accelerated idioventricular rhythms may represent serious cardiac disease, although they are most frequently seen following reperfusion for acute myocardial infarction, and suggest reopening of the occluded coronary artery. Antidysrhythmic medications are usually not indicated for accelerated idioventricular rhythm, particularly in the pre-hospital setting. Ventricular tachycardia. Ventricular rhythms occur when the sinoatrial and atrioventricular nodes fail as the pacemakers of the heart. Occasionally, a ventricular rhythm has a rate that exceeds 100 beats per minute. Any rhythm that results in a ventricular rate greater than 100 beats per minute is considered ventricular tachycardia. The QRS complex will measure 0.12 second, 120 milliseconds, or more. Ventricular tachycardia is regular, with no variation between RR intervals. P waves are not normally visualized, but may be seen buried within the QRS complexes. Due to atrioventricular dissociation, the P waves would occur at different places within the QRS complexes, and with a careful eye, may be seen. This finding helps to confirm that a wide complex tachycardia is ventricular tachycardia rather than supraventricular tachycardia with aberrancy. Ventricular tachycardia usually presents with QRS complexes that are uniform in appearance. This type of ventricular tachycardia is referred to as monomorphic, having one common shape of QRS complex. Occasionally, ventricular tachycardia will present with QRS complexes that vary in height or shape in an alternating pattern. This type of ventricular tachycardia is called polymorphic ventricular tachycardia. The most common polymorphic ventricular tachycardia is torsades de Pointe, which is usually seen in patients who have a condition of a prolonged QT interval. Torsades de Pointe may be related to a congenital prolonged QT interval, or it may be precipitated by medications or drugs such as antibiotics, antipsychotics, or quinidine. Torsades de Pointe with a normal QT interval prior to the dysrhythmia is frequently associated with cardiac ischemia. Polymorphic ventricular tachycardia is usually considered more challenging to treat than monomorphic ventricular tachycardia and converts spontaneously back to a normal rhythm or degenerates into ventricular fibrillation. Ventricular tachycardia is extremely serious, and it may require treatment in the pre-hospital setting because the rate is usually too fast and, without the atrial coordinated contraction, cannot maintain adequate cardiac output. This reduced cardiac output, in conjunction with the increased workload of the heart due to the tachycardia, usually leads to ventricular failure or fibrillation if not treated promptly. Pulseless ventricular tachycardia requires an immediate unsynchronized shock with supportive cardiopulmonary resuscitation. Unstable ventricular tachycardia, with associated hypotension, pulmonary edema, or chest pain, typically requires synchronized cardioversion, either in the pre-hospital environment or on arrival to the emergency department, depending on the extent of instability. Stable ventricular tachycardia may be treated with medication, although treatment may be deferred until arrival to the emergency department when transport times are short. Premature ventricular complex. A PVC is not, strictly speaking, a dysrhythmia, just as premature atrial and junctional complexes are not, but rather an early complex that appears within another rhythm. PVCs are ectopic complexes because they originate from a site other than the sinoatrial node. A PVC occurs earlier than the next expected sinus complex, causing the RR interval to be less between it and the previous complex. Because the rate depends on the underlying rhythm, the PVC will make the rhythm irregular. There is no P wave associated with the PVC, so there is no PR interval. The QRS complex will measure greater than 0.12 second, 120 milliseconds. PVCs may also be further distinguished as unifocal or multifocal. Unifocal PVCs originate from the same spot or focus within the ventricle, and will look alike on the ECG. Two PVCs with varied appearances are multifocal, meaning that there is more than one focus initiating ventricular impulses. Sometimes two PVCs may occur together without any pause between them. This pair of complexes is referred to as a couplet. If three or more PVCs occur in a row, they constitute a run of ventricular tachycardia. These surges are also referred to as salvos or bursts. Occasionally, these complexes will become so frequent that they alternate with normal complexes, causing a normal PVC pattern. This pattern is called bigeminy of PVCs. If every third beat is a PVC, normal PVC, the pattern is called trigeminy. PVCs can be caused by many of the same circumstances that cause premature atrial and junctional complexes, but they most often originate from ischemia in the ventricular tissue. They are generally considered more serious than premature atrial or junctional complexes. Multifocal, couplet, and bigeminy PVCs are considered more serious than unifocal PVCs. One of the principal hazards of PVCs is that they might occur at a time when the ventricles are not fully repolarized, as indicated by the T wave. This so-called R-on-T phenomenon often results in ventricular fibrillation. For this and other reasons, PVCs are considered serious and an indication of serious underlying heart conditions. Nevertheless, this condition is not usually treated in the pre-hospital setting unless it is significantly affecting cardiac output, and even then, it must be treated with caution. Treatment of the underlying causes of the PVCs, such as relief of ischemic chest pain, may be appropriate and should be considered prior to any use of antidysrhythmic medications. Ventricular fibrillation. Ventricular fibrillation is a rhythm in which the entire heart is no longer contracting, but rather fibrillating, or quivering, without any organized contraction. It occurs when many different cells in the heart become depolarized independently rather than in response to an impulse from the sinoatrial node. The result of this random depolarization is a fibrillating or chaotic baseline without indication of organized activity. As opposed to atrial fibrillation, there are no P waves, no PR interval, and no QRS complexes. Early in ventricular fibrillation, the cardiac cells have energy reserves that allow a considerable amount of electrical energy to be expended and cause the height of the chaotic waves to be large. These large waves are sometimes referred to as coarse ventricular fibrillation. As the ventricles continue to go without circulation, the energy reserves of the cardiac cells are gradually used up, leading to a great reduction of the height of the chaotic waves. This phenomenon is sometimes called fine ventricular fibrillation. Effective chest compressions during cardiopulmonary resuscitation can delay the deterioration to fine ventricular fibrillation. Ventricular fibrillation is the rhythm most commonly seen in adults who go into cardiac arrest. Fortunately, it responds well to defibrillation performed with an automated or manual defibrillator within the first few minutes of an arrest. After the first few minutes, ventricular tachycardia may not respond to defibrillation, but chest compressions help make the heart more susceptible to defibrillation, and to increase the oxygen to the myocardial cells. Pre-hospital treatment of ventricular fibrillation is common and will be discussed in detail later in this chapter. Asystole. Asystole, flatline, is a rhythm in which the entire heart is no longer contracting, but rather is sitting still within the thorax without any organized activity. It occurs when many cells of the heart have been hypoxic for so long that they no longer have any energy for any kind of contraction. Asystole presents with a complete absence of electrical activity, no P waves, no PR intervals, no QRS complexes, and no T waves. In one variation of asystole, the flat baseline associated with asystole is interrupted by a small sinusoidal complex at a rate of less than 20 beats per minute. This condition, which is termed agonal rhythm, is probably a result of residual electrical discharge from a dead heart. Agonal rhythm should not be confused with an idioventricular rhythm. An idioventricular rhythm may result in a palpable pulse, but an agonal rhythm will not. Asystole is generally considered a confirmation of death, although in certain circumstances, it may be treated, as discussed later in this chapter. Artificial pacemaker rhythms. Many of your patients will have experienced cardiac conduction system disorders for which an artificial pacemaker was implanted. When these patients are connected to the heart monitor, the presence of the artificial pacemaker is obvious. The firing of an artificial pacemaker causes a unique vertical spike on the ECG tracing. When you attach the cardiac monitor to a patient, and see these sharp vertical spikes on the ECG, you can assume the patient has an artificial pacemaker. Many types of artificial pacemakers exist, and more are being developed. Some are termed ventricular pacemakers, which are attached to the ventricles only. They cause a sharp pacemaker spike followed by a wide QRS complex resulting from the impulse traveling through the ventricles. Another type of pacemaker is attached to the atria and the ventricles, dual chamber. It produces a pacemaker spike that is followed by a P wave, and another pacemaker spike followed by a wide QRS complex. Pacemakers are equipped with sensors that can identify the rate of spontaneous depolarization of the heart. These demand pacemakers begin to generate pacing impulses only when they sense that the natural pace of cardiac impulses has slowed below a specific number, usually 60 per minute. Occasionally, a patient may experience a problem with his or her pacemaker. If the patient's pacemaker is failing, for example due to battery failure, the pacemaker spikes may still be visible, but they will not be followed by a QRS complex. This loss of capture indicates the pacemaker is not operating properly. A loss of capture may also occur if the wire connecting the pacemaker to the patient's heart becomes dislodged. In either of these cases, the patient's heartbeat now depends on the natural pacemaker, usually the ventricles, resulting in greatly reduced cardiac output. In such cases, patients need transcutaneous pacing instituted as quickly as possible. Another type of pacemaker failure involves a so-called runaway pacemaker. A runaway pacemaker presents as a very tachycardic pacemaker rhythm that must be slowed to preserve the patient's cardiac function. Usually a strong magnet placed over the pacemaker will reset a runaway pacemaker to a preset regular rate at 60 to 80 beats per minute. Other ECG abnormalities. A few other ECG abnormalities are not identified as dysrhythmias, but indicate significant cardiac conditions. For example, a delta wave is an indication of early ventricular depolarization, pre-excitation, and suggestive of Wolff-Parkinson-White syndrome. Patients with Wolff-Parkinson-White syndrome have an accessory pathway between the atria and the ventricles called the bundle of Kent. This bundle of conductive tissue bypasses the atrioventricular node and begins the early ventricular depolarization, resulting in a rapid upslope to the R wave immediately after the end of the P wave. This early upslope can be interpreted as a widened QRS complex, more than 0.12 second, 120 milliseconds, and a short PR interval. This situation, which is referred to as aberrant conduction, can lead to the misinterpretation of supraventricular tachycardias as ventricular in origin. Patients with Wolff-Parkinson-White syndrome are highly susceptible to supraventricular tachycardias. A very important rhythm to recognize is pre-excited atrial fibrillation. It is caused by atrial fibrillation with conduction down a bypass tract, Wolff-Parkinson-White syndrome or another similar condition, which results in an extremely rapid ventricular rate of greater than 200, and an irregular wide complex rhythm. All atrioventricular nodal blocking agents, adenosine, beta blockers, and calcium channel blockers, are contraindicated in this rhythm as they can lead to a more rapid rate or degeneration into ventricular fibrillation. Recognition of this rhythm is important because occasionally such a rapid rhythm can mistakenly be interpreted as regular. Treatment is by synchronized cardioversion. Another important abnormality is an Osborn, or J, wave. It occurs in cases of hypothermia, and presents as what appears to be a P wave at the end of the QRS complex. The J wave may also be accompanied by ST segment depression and T wave inversion. Generally, the more serious the hypothermia, the larger the J wave. Evidence of a J wave should be considered only an indication of hypothermia. It is not enough to make a definitive diagnosis. Electrolyte imbalances can also cause changes in the ECG that are not dysrhythmias but can be indicators of serious conditions. The two most common of these electrolyte imbalances are hyperkalemia and hypokalemia. Hyperkalemia often presents with very tall, pointed T waves. These T waves may be as tall or taller than the QRS complex. The rhythm strip for someone with profound, severe hyperkalemia has the appearance of a sine wave. By contrast, hypokalemia usually presents with flat or apparently absent T waves along with the development of a U wave. The U wave is a small wave, smaller even than a P wave, that occurs after a T wave but before the next P wave. U waves are very uncommon and may often be mistaken for extra P waves or another unknown abnormality. Other electrolyte imbalances do not cause such obvious changes in the ECG. Hypercalcemia may cause a shortened QT interval, for example, whereas hypocalcemia may slightly lengthen the QT interval. These changes would likely not be obvious in the pre-hospital environment. 12 lead ECGs. Up to now, we have considered ECG rhythm strips obtained from monitoring single and 3-lead ECGs. For purposes of rhythm interpretation, a single lead, usually lead 2, is usually sufficient. To localize the site of injury to heart muscle, however, you must be able to look at the heart from several angles, which is the purpose of a 12-lead ECG. What is a 12-lead ECG? Suppose you want to check out the condition of an used car you are thinking of buying. If you need to know only whether the motor is running, you could stand anywhere near the car and listen, just as you can use any one lead to monitor the cardiac rhythm. But if you want to know what kind of shape the car body is in, you would have to walk around the car and look at it from all sides. The driver's side might be in mint condition, but if you stroll around to the passenger's side, you might see that the entire door frame is caved in from a collision. Similarly, each ECG lead looks at the heart from a different angle. Although one lead may see a normal myocardium, another may be looking at major damage. Devices capable of recording 12 lead ECGs contain interpretation software. Such software is a good tool, but has many limitations. It is always best to determine your own interpretation, and not rely solely on the automated interpretation when reading the ECG. Think of automatic interpretation software as a nudge or hint as to what may be happening in the patient's heart. The software is very good at recognizing some things, but may not be accurate. Some devices are also capable of transmitting ECGs to the hospital. This technology enables physicians in the hospital to review the ECG prior to your arrival, and prepare specialized resources for the patient. What do ECG leads record? In the standard 12-lead ECG, you record 12 leads, that is, 12 different pictures of the electrical activity of the heart. Recall from the section on cardiac monitoring that there are 3 types of leads: bipolar limb leads, unipolar augmented limb leads, and precordial leads. 6 of the leads, 1, 2, 3, AVR, AVL, and AVF, are called limb leads because the pictures obtained by those leads are derived from attaching cables to the patient's limbs. The limb leads look at the heart from the sides, and from the feet, in the vertical plane. Leads 2, 3, and AVF have a direct view of the bottom of the heart, known as the inferior wall of the left ventricle. 1 and AVL, L stands for left, give a view of the high lateral part of the left ventricle. When a current is moving toward a lead, it creates a positive, upright, deflection on the ECG tracing of that lead. Thus, the current depolarizing the ventricles is moving toward lead 2, So what you see in lead 2 is an upright QRS complex. Recall that the QRS complex is produced by depolarization of the ventricles. If the depolarizing current is moving toward lead 2, then it must be moving away from lead AVR, so you would expect to see a negative deflection in AVR. Indeed, the QRS complex in AVR reveals a downward deflection. That makes intuitive sense. If you and a friend are standing facing each other at opposite ends of a football field, the ball thrown toward you friend will look bigger and bigger to the friend as it approaches. The same ball will meanwhile look smaller and smaller to you as it travels the same course. Similarly, leads 2 and AVR, being nearly opposite each other, will present nearly opposite pictures of the same wave of electrical depolarization. If a depolarizing wave is coming toward lead 2, it will be going away from AVR. A 12-lead ECG adds 6 precordial leads to the 6 limb leads discussed thus far. These 6 precordial leads, V1 to V6, are also called unipolar chest leads, anterior leads, or V leads. The 6 precordial leads are placed on the anterior and lateral chest walls, usually with adhesive electrodes, in the positions. These leads look at the heart in the horizontal plane, so they provide a picture of the heart obtained from the front, anterior wall of the heart, and from the left side, anterolateral. More specifically, leads V1 and V2 look at the septum, V3 and V4 look at the anterior wall of the left ventricle, and V5 and V6 look at the lateral wall of the left ventricle. You will note that none of these 12 standard views of the heart provides much information about the right side, right ventricle, or the posterior part of the heart. A modified 12-lead or 15-lead ECG provides more information about these areas. This will be discussed later. When to perform a 12-lead ECG. There are a few common indications to acquire or perform a 12-lead ECG in the pre-hospital setting. 1. Patient with suspected acute coronary syndrome with classic symptoms of chest pain or equivalent symptoms thought to be due to acute coronary syndrome, dyspnea. 2. Patient post-return of spontaneous circulation, after cardiac arrest to determine if the patient has an obvious ST segment elevation myocardial infarction. 3. Patient with suspected dysrhythmia to assist with rhythm interpretation. 4. There may be a role for use in patients with syncope, acute pulmonary edema, and other symptoms, according to local guidelines. For the patients with possible acute coronary syndrome, it is ideal to perform the 12-lead ECG prior to other treatments so that you can capture any ECG changes that are indicative of ischemia that may change or reverse with your subsequent treatment. Therefore, whenever possible, ensure privacy. Perform the ECG before acute coronary syndrome specific therapy on the scene. The 12-lead ECG acquisition should not delay scene time and other therapies by more than 2 minutes. If this first 12-lead ECG is not diagnostic for a ST segment elevation myocardial infarction, repeating the 12-lead ECG may capture a ST segment elevation myocardial infarction in evolution. Repeating the 12-lead ECG at 2 other specific times has been shown to increase the capture of a ST segment elevation myocardial infarction by paramedics by 10% to 15%, in the vehicle just prior to transporting, and upon arrival at the hospital prior to moving the patient from the ambulance. As the ECG changes of a ST segment elevation myocardial infarction evolve over time, this strategy of repeating the 12-lead ECG may result in capturing more ST segment elevation myocardial infarction positive patients. 12-lead ECG lead placement. Correct electrode placement is important to ensure that the lead is viewing the heart from the correct angle and position each time an ECG is recorded. This is particularly important with the unipolar precordial leads. Because these leads sit on a horizontal plane, their view is of a horizontal cross-section across the mid-heart. As an example, placement of the electrodes only 3 cm lower on the chest wall, 1 inner space lower, will completely change the view of the heart to the more inferior segment. This will change the morphology of the ST segments, T waves, and QRS complex and may miss changes associated with a myocardial infarction in a higher region of the heart. Accurate placement is essential to accurate interpretation. Correct placement is important because the 12-lead ECGs are compared with previous ECGs. For the comparison to be reliable for identifying existing problems or highlighting the appearance of new problems, such as ST segment elevation, the electrodes must be placed consistently. Table 30-15 outlines where the different leads look. Skill Drill 30-2 lists the steps involved in acquiring a 12-lead ECG. Skill Drill 30-2. Acquiring a 12-lead ECG. Step 1. Take routine precautions. Place the patient in the supine position. Step 2. Explain the procedure to the patient. Prepare the skin for electrode placement as you would for placing monitoring electrodes. Step 3. Attach the electrodes to the leads before placing them on the patient. Step 4. Position the electrodes on the patient. This involves connecting the 4 limb electrodes. Double-check that the correct electrode is on each limb, the LA electrode on the left arm, the RA electrode on the right arm, and so on. Confirm that the limb electrodes are on the arms and legs and not on the trunk of the body, as sometimes is the case for monitoring the ECG. Once the limb electrodes are connected, connect and apply the electrodes for the precordial leads. The 1. Fourth intercostal space to the right of the sternum. The 2. Fourth intercostal space to the left of the sternum. The 3. Directly between leads V 2 and V 4. The 4. Fifth intercostal space at left mid-clavicular line. The 5. Level with lead V 4. At left anterior axillary line. The 6. Level with lead V 5. At left mid-axillary line. Step 5. Connect the cables to the monitor. Step 6. Press the 12-lead Analyze button. Step 7. Record tracings. Step 8. Review the tracing. Determine whether additional views of the right and posterior walls, 15 or 18 lead tracings, are needed. Label the tracing with the lead recorded if the recorder does not automatically do so, and remember to put the patient's name and other unique patient identifiers on the ECG. This is the end of Skill Drill 30-2. ECG Acquisition Modes. The ECG monitor can record tracings using different electromagnetic frequency ranges. For the purposes of rhythm interpretation, the ECG is recorded in monitor mode. Monitor mode employs electronic filters to remove artifact and unwanted information from the ECG tracing. This makes it much easier to obtain an ongoing tracing as you move the patient and stretcher during transport. Unfortunately, monitor mode also skews the shape and height of the ST segment and T wave, and so cannot be used to reliably comment on those parts of the complex. A 12-lead ECG is required to comment on those morphologies and heights. Monitor mode captures electrical information typically within the range of 1 to 40 Hz. It filters out the lower frequency wandering baseline and the high frequency power line interference. Diagnostic mode is the second acquisition mode that filters out very little electrical information, making it prone to having more artifact on the tracing. However, this mode provides a more accurate depiction of the ST segment and T waves, allowing interpretation for possible ischemia and infarction, ST segment elevation myocardial infarction. Diagnostic mode is always used to record a 12-lead ECG by default, and cannot be changed. Diagnostic mode captures electrical information within the range of 0.05 to 40 Hz or up to 150 Hz. The frequency range is always printed near the bottom of the ECG tracing. How to perform a 12-lead ECG. The best way to learn how to obtain a 12-lead ECG is to practice with the equipment itself. Here are some guidelines to help ensure that the ECGs you obtain are of the highest quality possible. The patient should be supine. If the patient feels short of breath in that position, you may elevate the back of the stretcher approximately 30 degrees. Make sure the patient does not become chilled, because shivering will produce artifact in the ECG tracing. Prepare the patient's skin carefully. Remember that 12-lead ECGs are more sensitive to artifact than rhythm monitoring ECGs. Ensure good contact by shaving hair and drying the skin when necessary. Connect the 4 limb electrodes. Double-check that the correct electrode is on each limb, the LA electrode on the left arm, the RA electrode on the right arm, and so on. Confirm that the limb electrodes are on the arms and legs and not on the trunk of the body, as sometimes is the case when applying electrodes for rhythm monitoring. Connect and apply the precordial leads as indicated in Table 30-16. Ensure the patient remains very still and the arms and legs are resting. The 12-lead ECG is more susceptible to movement artifact. Record and review the 12-lead ECG. If needed, eliminate artifact and repeat the 12-lead. Perform a modified 15-lead ECG if indicated, inferior, 2, 3, AVF, ST elevation or septal, V1, V2, ST depression. Acquiring a 12-lead tracing should not prolong scene time or transport by more than 2 minutes. Repeat the 12-lead ECG at 2 additional times when you suspect acute coronary syndrome if the first is not diagnostic of a ST segment elevation myocardial infarction, in the vehicle prior to transport, and in the vehicle before moving into the hospital. The 12-lead ECG in ischemia and infarction. The ECG tells you many things about a patient's heart. For your purposes in the pre-hospital environment, keep it simple and look for any evidence that the patient is having a ST segment elevation myocardial infarction. To do so, you must focus on 3 parts of the ECG, the ST segment, the Q wave, and the T wave. Recall the sequence of events in an acute myocardial infarction. As the blood supply to the affected area of heart muscle slows to a trickle, the muscle no longer receives sufficient oxygen. In other words, the muscle becomes ischemic, deprived of blood. If ischemia persists more than a few minutes, it leads to actual injury to the heart muscle, which in turn will be followed by infarction, death of muscle, if the circulation to the area is not rapidly restored. The ECG can provide a graphic record of that sequence of events. Ischemia commonly causes ST segment depression, and may also lead to T-wave inversion. Injury may initially cause a transient peaking of T waves quickly, followed by ST segment elevation. Infarction, indicative of dead cardiac tissue, often results in the development of a pathologic Q wave. A Q wave that is wider than 0.04 second, 40 milliseconds, one small square on the ECG strip, or deeper than 1/3 of the height of the R wave that follows it and that is seen in 2 or more contiguous leads generally indicates an infarction has happened at some time in the past. However, note that an ECG may be normal or nonspecific in ischemia and infarction and that a normal ECG does not rule out acute coronary syndrome. For the purposes of this section, think of acute myocardial injury and infarction as a problem of repolarization. This will prompt you to look for anomalies on the right side of the QRS complex at the J point, ST segment, and T wave. Recall that the J point is the junction point between the QRS complex and the ST segment. It signifies the end of ventricular depolarization, and the beginning of ventricular repolarization. The ST segment begins at the J point, and terminates at the T wave. The ST segment represents early repolarization of the ventricles. The ST segment is normally isoelectric, but can sink below, rise above, or stay in line with the isoelectric line during myocardial events. An ST segment whose amplitude is significantly above, taller than 1 millimeter or one small box, or below the isoelectric line in 2 contiguous leads is highly suggestive of myocardial ischemia or injury. Myocardial ischemia may manifest itself as J-point and ST segment depression below baseline and/or T-wave inversion on the diagnostic quality tracing. Figure 30-94 shows signs of ischemia, T-wave inversion, in the leads that look at the anterolateral wall of the heart, leads V4 through V6. Myocardial injury or infarction may be recognized by J-point or ST segment elevation of 1 mm or greater in 2 or more contiguous leads with respect to the baseline. It may be accompanied by hyperacute T waves in the same leads, and reciprocal changes in other leads. Figure 30-95 depicts an injury, ST segment elevation, in the leads that look at the anterior wall of the heart, leads V3 and V4. Reciprocal changes are J-point and ST segment depression and T wave inversion seen in an area of the heart that is opposite to the area of injury. The presence of reciprocal changes is highly confirmatory of acute myocardial infarction, but is not required. The inferior leads are typically opposite to the anterior and lateral walls, and the septal wall is opposite to the posterior wall. Figure 30-96 shows ST elevation in leads 2, 3, and AVF, inferiorly, with reciprocal changes in leads 1 and AVL, high lateral. The lack of ST segment changes in the presence of acute coronary syndrome presentation is referred to as a non-diagnostic ECG. A non-diagnostic ECG does not rule out acute myocardial ischemia, injury, or infarction. It simply means the tracing is non-diagnostic for those events. And myocardial infarction can occur without ST elevation. Serial blood work and additional testing can be used to identify an acute myocardial infarction not noted on the ECG. Finally, the T wave is the most dynamic wave on the ECG. From ischemia, the T wave can become inverted, negative. Figure 30-97. Injury and infarction result in T waves that become very large, hyperacute, peaked or tented in shape, symmetric, and broad-based. It is important to look for these changes on the ECG so you do not miss an early infarction pattern. ST segment elevation myocardial infarction is recognized by clinical features, chest pain or equivalent symptoms, and characteristic ECG changes. The fourth universal definition of myocardial infarction, 2018, indicates the characteristic ECG changes are new ST elevation at the J-point in 2 contiguous leads meeting the following criteria. 1 mm or greater in all leads except for leads V2 and V3 where 2 mm or greater in men 40 years or older, 2.5 mm or greater in men younger than 40 years, or 1.5 mm or greater in women regardless of age. Posterior and right ventricular ST segment elevation myocardial infarction are recognized through slightly different criteria as discussed below. Reciprocal changes are ST depressions and T wave inversions that are seen simultaneously with ST elevations in ST segment elevation myocardial infarction, but in the electrically opposite leads. Reciprocal changes are commonly seen in 1 and AVL with an inferior ST segment elevation myocardial infarction, in 2, 3, AVF and a high lateral ST segment elevation myocardial infarction, and in V1 and V3 in posterior ST segment elevation myocardial infarction. Reciprocal changes are not always seen with an anterior ST segment elevation myocardial infarction, would be seen in the posterior leads, and sometimes in 1 and AVL. When reciprocal changes are seen, they increase the likelihood that it is a true ST segment elevation myocardial infarction, and not a mimic, but reciprocal changes are not required to confirm a ST segment elevation myocardial infarction. Look at figure 30-99 and see if you can spot the reciprocal changes, ST depressions. ST elevation in AVR is sometimes seen without other ST elevation, but in conjunction with diffuse ST depression. This is not a true ST segment elevation myocardial infarction, but it is concerning. This may be due to acute coronary syndrome with critical stenosis of the left main artery. If there is complete occlusion, it will rapidly cause death, or due to triple vessel disease, and myocardial ischemia from a non-acute coronary syndrome cause. It is commonly seen as secondary myocardial ischemia in patients who have an acute condition causing supply-demand mismatch, such as sepsis, hemorrhagic shock, tachydysrhythmias, or severe hypertension. Thus, it may be due to acute coronary syndrome or non-acute coronary syndrome cause of myocardial ischemia. If you see this pattern, consider the non-acute coronary syndrome causes, and begin management if appropriate. Notify your receiving facility, as this is a marker of a critically ill patient. Table 30-18 summarizes the leads corresponding to different locations of myocardial injury. As discussed previously, the limb leads and precordial leads of a standard 12-lead ECG provide a look at the inferior, anterior, septal, and lateral areas of the heart. However, a 15-lead ECG also provides further information on the right ventricle and posterior wall of the heart. Figure 30-98 shows ECGs with different areas of infarction. Modified 15-lead ECG. A 15-lead ECG can be performed after the first 12-lead ECG for the following indications. ST elevation in the inferior leads, 2, 3, AVF. ST depression in the septal leads, V1, V2. The 15-lead ECG is a phrase used to describe acquisition of the standard 12-lead ECG, with leads V4R, V7, and V8. The additional leads enable you to view the right ventricle and posterior wall of the heart, and determine if ischemia or injury is present. Some monitors allow the addition of the 3 electrodes, and can print out all 15 leads. Alternatively, it can be done as a modified 15-lead ECG by moving the V4-6 leads to the position of V4R, V8, and V9. Unsnap the original V4 on the left side of the chest, and snap it onto a new gel pad. Place this on the right side of the sternum in a mirror to the position of V4, mid-clavicular line, 5th intercostal space on the right. Similarly, unsnap the V5 and V6 electrodes, attach new gel pads, and move to the positions of V8 and V9 on the same horizontal level but to the mid-scapular line, and the left side of the spine, respectively. Leave all the other electrodes in place, and leave the 3 original pads in place at V4-6 so that you can keep the same position if you need to repeat the standard 12-lead. A modified 15-lead is commonly done if the monitor cannot add additional electrodes and leads. After acquiring the modified 15-lead ECG, ensure that you label it appropriately by crossing out V4-6 and writing in V4R, V8, and V9. Circle them to make them stand out. The computer interpretation cannot be used for a modified 15-lead ECG because it does not recognize that the electrodes were moved and have become different leads. In 40% of patients who experience an inferior wall myocardial infarction, a right ventricular myocardial infarction will eventually develop as well. To verify this, a 15-lead ECG, or modified 15-lead ECG, should be done. If you see ST segment elevation of greater than 1 mm in the V4R lead on this second ECG, there is a high likelihood that you have identified a right ventricular myocardial infarction. In this one instance, you can consider the inferior leads to be contiguous and require only one right side lead to confirm an right ventricular myocardial infarction. Thus, recognition of a right ventricular myocardial infarction relies on both ST elevation in the inferior leads, 2, 3, AVF, and at least 1 mm of ST elevation in the V4R lead. Patients who are experiencing a myocardial infarction of the right ventricle may already be hypotensive or may become extremely hypotensive if their preload or filling pressure of the right ventricle drops. This is referred to as preload dependent. The right ventricle relies on passive filling of the right atrium from the peripheral venous return to supply forward blood flow. If a preload reduction agent is given, the damaged right ventricle cannot contract effectively to keep enough forward flow. Thus, even a small reduction in preload will result in a dramatic reduction in output from the right ventricle. Because the left side of the heart relies on the right side output, overall cardiac output will fall, and the patient will become hypotensive. Cardiogenic shock from left side failure can be differentiated from right side heart failure in that the former will result in cardiogenic pulmonary edema, but the later should have a clear chest. Nitroglycerin reduces preload, and therefore should not be given in a patient with a recognized right ventricular myocardial infarction. For this reason, you are well advised to perform a 15-lead ECG every time you find a patient with an inferior wall myocardial infarction before administering nitroglycerin to avoid complications. You may receive an order from the physician to give 1 to 2 liters of saline intravenous for a patient with an right ventricular myocardial infarction to increase the preload even if the patient is not hypotensive. Patients with inferior acute myocardial infarctions may also have posterior wall involvement. Thus, a 15-lead ECG done after identifying a possible inferior ST segment elevation myocardial infarction will also look at the posterior wall of the heart. An inferior posterior ST segment elevation myocardial infarction is commonly found with inferior ST elevation of 1 mm or greater in at least 2 of the inferior leads, 2, 3, and AVF, plus at least 1 mm or greater of ST elevation in V8 and V9. A posterior myocardial infarction may also be seen in association with a lateral wall myocardial infarction, V5 and V6 ST elevation, and without inferior ST elevation. The clue to the possible posterior extension of the lateral myocardial infarction is by ST depression in V1 and/or V2, and possible tall R waves that are not common in V1 and V2. The ST depression in V1 and/or V2 represents the reciprocal changes to the posterior wall myocardial infarction. Thus, ST depression in V1 and/or V2 is an indication to do a 15-lead ECG to check leads V8 and V9. A posterior myocardial infarction can also occasionally be found in isolation, no inferior or lateral ST elevation, with only ST elevation in V8 and V9. In this case, it is recognized on the original 12 lead as a possible posterior myocardial infarction by the ST depression in V1 and/or V2 that represents the reciprocal changes to the posterior wall myocardial infarction, and confirmed with the ST elevation in V8 and V9. Bundle branch blocks. A QRS complex with a duration longer than 0.12 second, 120 milliseconds, signifies some abnormality in conduction through the ventricle as in a bundle branch block. A bundle branch block requires a supraventricular rhythm, either sinus or other atrial rhythm, with a blockade in the conduction system after the bundle of His. Right bundle branch blocks and left bundle branch blocks are named for where the blockade of the conduction occurs and are some of the most commonly encountered findings on the 12-lead ECG. They have specific patterns that can be recognized. In contrast, ventricular rhythms are greater than 0.12 second, 120 milliseconds, but the rhythm originates in the ventricles, and will not have these typical patterns. The names of these electrical conduction abnormalities identify where the electrical system is being delayed. And right bundle branch blocks is characterized by the presence of a wide QRS complex, duration greater than 0.12 second, 120 milliseconds, and a terminal R wave in lead V1. The second half of the QRS complex terminates in an R wave, whereas normally V1 has a negative QRS. Terminal S waves are also seen in leads 1, AVL, and V6. Common causes of right bundle branch blocks are cardiac ischemia, infarction, cor pulmonale from chronic obstructive pulmonary disease, and pulmonary embolism. Figure 30-104 demonstrates in right bundle branch blocks from a pulmonary embolism. And left bundle branch blocks is characterized by the presence of a wide QRS complex, duration greater than 0.12 second, 120 milliseconds, and a terminal S wave in lead V1. The second half of the QRS complex terminates in an S wave. Terminal R waves are also seen in leads 1, AVL, and V6. Common causes of left bundle branch blocks are cardiac ischemia and infarction, aortic valve stenosis or aortic root dilatation, and dilated cardiomyopathy. ST segment elevation myocardial infarction mimics. ST segment elevation myocardial infarction mimics represent the non-infarction processes that can result in ST elevation on the 12-lead ECG. The most common ST segment elevation myocardial infarction mimics are as follows. 1. Benign early repolarization. 2. Left bundle branch blocks. 3. Left ventricular hypertrophy. 4. Pericarditis. 5. Hypertrophic cardiomyopathy. 6. Brugada syndrome. 7. Stress cardiomyopathy, Takotsubo cardiomyopathy. 8. Post-myocardial infarction persistent ST elevation. 9. Left ventricular aneurysms. 10. Hyperkalemia. 11. Prinzmetal angina. Some of the most common causes of ST segment elevation myocardial infarction mimics are discussed below. Myocardial infarction can cause ST elevation in more than just one region of the heart. Typically, a more proximal right coronary artery blockade can cause both inferior and posterior infarction. Similarly, left main coronary artery blockade can lead to both anterior and lateral wall infarctions. There are additional examples as well. However, rarely does an myocardial infarction present with ST elevations in 3 or more regions of the heart. Consider ST segment elevation myocardial infarction mimic if there is extensive ST elevation across numerous leads, especially without accompanying ST depression representing reciprocal changes. Typically, ST elevation from an myocardial infarction results in convex ST elevation, although ST elevation due to benign conditions tends to cause concave ST elevation. Unfortunately, occasionally injury can cause convex ST elevation early before it progresses to concave ST elevation. Benign early repolarization commonly occurs in young, healthy men and is thought to be a normal variant. Recall that ventricular repolarization is due to potassium efflux. If this repolarization begins earlier, it can cause an earlier takeoff from the descending limb of the R wave at the J point. It may be recognized or considered because it typically causes concave ST elevation or J point elevation of no more than 1 mm. The ST segment typically scoops down to the isoelectric line, and the elevation is often located in the precordial and inferior leads and not just in one region of the heart, with absence of reciprocal changes. However, if repolarization is uncertain and occurs in a patient with concerning symptoms of acute coronary syndrome, then acute coronary syndrome must be considered. Left bundle branch blocks is another very common cause of ST elevation. It commonly causes ST elevation anteriorly and has a recognizable pattern of a wide QRS with predictable ST elevation in some leads and ST depression in other leads. Myocardial infarctions can cause new left bundle branch blocks, and this was an original indication for myocardial infarction recognition. However, now thousands of people have chronic left bundle branch blocks that should not be mistaken for acute ST segment elevation myocardial infarction. The criteria to recognize ST segment elevation myocardial infarction in the patient with chronic left bundle branch blocks are beyond what would be required of a paramedic. Comparison with the previous ECG may be helpful. Therefore, ensure that you can recognize an left bundle branch blocks. Understand that it may be chronic or acute and may make it difficult to recognize ST segment elevation myocardial infarction. Check your local guidelines to see if these patients are excluded or included from ST segment elevation myocardial infarction programs. Left ventricular hypertrophy from chronic hypertension, for example, leads to tall R waves from the additional muscle mass. Those tall R waves are associated with ST and T wave changes from the larger mass repolarization. It can be recognized by criteria and pattern recognition of tall R waves associated with ST elevation. ST segment elevation myocardial infarction usually leads to loss of R waves in the same leads as the ST elevation. Pericarditis is inflammation or infection involving the pericardium that can result in typical phased changes in the ECG, which include ST elevation during one of the phases. The ST elevation is usually global, concave up, and associated with PR depression, has no reciprocal changes, and has a classic appearance. The patient may have chest pain, although the description of the pain, sharp, pleuritic, worse supine and better leaning forward, and prodrome, may have preceding viral prodrome, may help to differentiate pericarditis from acute coronary syndrome. Hypertrophic cardiomyopathy is a genetic condition in which the myocardial walls become very thick. Patients often experience shortness of breath, chest pain, or syncope, which is often associated with physical activity. Patients are often diagnosed in their 30s or 40s. In most cases, the disease is inherited. In other cases, the cause is unclear or unknown. On ECG, hypertrophic cardiomyopathy is characterized by deep, narrow Q waves in the inferior leads, and high lateral leads, and very tall R waves in the left precordial leads, similar to the changes seen in left ventricular hypertrophy. It is commonly associated with ST elevation and ST depression. Brugada syndrome is a rare genetic disorder involving sodium channels in the heart. Brugada syndrome is believed to be responsible for approximately 4% of all cases of sudden cardiac arrest. It is most common in men of Southeast Asian origin. The disease is often diagnosed in a person's 40s or 50s and, often, patients are unaware of the condition until a sudden onset, in the form of syncope or cardiac arrest, prompts them to seek medical care. Brugada syndrome is characterized by an incomplete right bundle branch blocks, RSR pattern in lead V1, QRS duration of shorter than 0.14 second, 140 milliseconds, and ST segment elevation that aggressively returns to baseline. These changes are seen exclusively in leads V1 to V2, and possibly in V3. Patients with previous myocardial infarctions may have persistent ST elevation for several weeks, which may be mistaken for acute changes. Differentiation will require a previous ECG for comparison. Similarly, a complication of a myocardial infarction is aneurysm of the left ventricular wall from damage and weakness. This aneurysmal weakness of the wall can cause chronic ST elevation, usually anteriorly. Recognition will usually require a previous ECG. Prinzmetal angina is a rare cause of ST segment elevation myocardial infarction mimic. You will recall from an earlier discussion that Prinzmetal angina is coronary artery spasm without plaque disruption and thrombosis. Although it can lead to infarction, typically it responds well to anti-ischemic medication such as nitroglycerin. It differs from usual angina in that it commonly causes ST elevation that reverses with symptom resolution. Benefits of using 12-lead ECGs. The most important 12-lead finding in the pre-hospital phase of care is simply the answer to the following question. Does this patient have ECG evidence of ischemia, injury, or infarction? This information will help determine whether to mobilize hospital resources for reperfusion. The 12-lead ECG provides you with information that can help you choose the most appropriate emergency management in the pre-hospital environment. For example, patients who have an inferior wall myocardial infarction, and possibly in right ventricular infarction will not respond well to nitroglycerin or morphine. If you know which leads to check for signs of injury to the inferior wall of the heart, and do a V4R, you should be able to identify patients who might need a fluid bolus, and avoid nitroglycerin administration to prevent extreme hypotension. Pre-hospital 12-lead ECGs and advance notification to the receiving hospital can lead to faster diagnosis, decrease the time until fibrinolysis is administered or primary angioplasty is performed, and reduce mortality rates. You can efficiently acquire a 12-lead ECG with only a minimal increase, less than 2 minutes, in your scene time. The time savings in door-to-reperfusion therapy in most studies ranges from 10 to 60 minutes. As you have learned, time is myocardium. The decision of where to transport patients with acute coronary syndrome and ST segment elevation myocardial infarction should be based on current guidelines from national groups such as the Heart and Stroke Foundation of Canada or the Canadian Cardiovascular Society and be written into local recommendations. In some areas, paramedics may be involved in administering fibrinolysis. This requires a specific process of care that includes determination of a balance of the benefits of early fibrinolysis versus transport to in-hospital fibrinolysis or primary percutaneous coronary intervention. Those areas that include this therapy ensure appropriate education and support that involves physician contact, ECG transmission, and approval. Remember, the absence of a myocardial infarction on the ECG does not mean that the patient is not having one. It may take hours for changes to appear in the ECG. When you acquire a 12-lead ECG, it will usually include a computerized interpretation. That interpretation may be useful, even when you are highly skilled at ECG interpretation. The computer interpretation occasionally makes errors in rhythm identification, especially if there is any artifact, but is often accurate at calculating intervals, PR interval, QRS width, QT interval. These computerized algorithms may not recognize all ST segment elevation myocardial infarctions. They can miss some subtle ST segment elevation myocardial infarctions, but when one is indicated, the interpretation is rarely inaccurate. This is called high specificity, and is intentional so that the results can be trusted when a ST segment elevation myocardial infarction is recognized. Therefore, it is ideal for providers to make their own interpretation, but also consider and keep the computer interpretation in mind. In some areas, paramedics may transmit the ECG to a physician. This does not preclude your own interpretation, but can be used for confirmation. Management of adult cardiac arrest. Nothing gets the adrenaline pumping more furiously, in paramedics, even if not in the patient, than a code, or cardiopulmonary arrest. Most adult cardiac arrest patients have evidence of atherosclerosis or other underlying cardiac disease. However, cardiac arrest can also occur after electrocution, a submersion incident, and other traumatic events, or from non-cardiac conditions such as drug overdose, asthma, or anaphylaxis. Indeed, many cardiac arrest patients have no warning before the event occurs. No matter what the cause, cardiac arrest is a stressful event for paramedics. Management of cardiac arrest requires you to deploy a great many of the advanced life support skills that you have learned, and to do so under very urgent circumstances, in which minutes may mean the difference between life and death. It is very difficult to think clearly in such stressful circumstances, especially when there are likely to be other stressed and panicky people at the scene, the patient's family, for example. For these reasons, it is absolutely essential for you to follow an orderly, systematic approach to cardiac arrest emergencies. That approach needs to be rehearsed repeatedly in a team setting, until it is nearly automatic, and must include the steps of basic life support and advanced life support. Basic life support. A review. Basic life support is defined as maintenance of circulation and the airway and breathing without adjunctive maneuvers. Early quality compressions and defibrillation, both of which are basic life support, are the measures that have been scientifically proven to have the greatest success for patients in ventricular fibrillation. The techniques and sequences of adult basic life support should be very familiar to all paramedic students. Here, the guidelines for ensuring maximally effective cardiopulmonary resuscitation to adults in cardiac arrest will be reviewed. For a complete review of this skill, see Appendix A, Cardiac Life Support Fundamentals. Concentrate on high-quality compressions, deep, 5 to 6 centimeters, fast, 100 to 120 times per minute, and with full chest recoil, with a minimum of interruptions. Avoid excessive inflation pressures in artificial ventilation. Inflate just enough to observe visible chest rise. Do not hyperventilate. Keep your compression smooth, regular, and uninterrupted. 1. The compression depth must be 5 to 6 centimeters in adults, maintaining each compression for at least 1/2 the compression release cycle. 2. Avoid bouncing or jerky compressions. 3. Keep your shoulders directly over the patient's sternum, and keep your elbows straight. 4. Maintain proper hand position, fingers off the chest, and hands coming up off the sternum slightly between compressions to allow for complete chest recoil. 5. Change the person doing the compressions every 2 minutes when help is available, to ensure that fatigue does not affect the quality of compressions. As a single rescuer, for adults, give 30 compressions to 2 ventilations at a rate of 100 to 120 compressions per minute. With 2 rescuers, either continue with 30 to 2 or perform continuous compressions at a rate of 100 to 120 compressions per minute uninterrupted by 8 to 10 ventilations per minute given with 100% supplemental oxygen. Once an advanced airway is placed, use continuous compressions and uninterrupted ventilations as above. Do not interrupt cardiopulmonary resuscitation compressions except for rhythm checks and defibrillation. Do not interrupt chest compressions for advanced airways. In all cases, minimize the duration of the interruption to 10 seconds or less. Any stop in compressions also stops perfusion, and perfusion is what it is all about. Now consider how to integrate these well-rehearsed steps of basic life support into the sequences of advanced cardiac life support. Monitoring cardiopulmonary resuscitation quality. Good quality cardiopulmonary resuscitation is critical to successful resuscitation. The quality of cardiopulmonary resuscitation and the short time to defibrillation are the most important determinants of survival from cardiac arrest. The addition of advanced cardiac life support medication and procedures likely add very little additional benefit over good quality basic life support. Thus, do not overlook cardiopulmonary resuscitation in favor of more advanced measures. Many emergency medical services defibrillators now incorporate cardiopulmonary resuscitation quality feedback at the point of care. They provide direction and prompts on the ideal rate, depth, and recoil. Compression fraction has also been shown to be a strong determinant of survival. Thus, ensure to limit the hands-off time during cardiopulmonary resuscitation to less than 10 seconds for rhythm analysis, if possible, and perform cardiopulmonary resuscitation while the defibrillator is charging. Monitoring the quality of the cardiopulmonary resuscitation should be your key function on the scene. Advanced cardiac life support. In addition to high-quality basic life support, you will be called on to deliver more definitive therapy as well. So the skills of advanced cardiac life support must also become second nature, to be deployed swiftly and systematically in the event of cardiac arrest. What is advanced cardiac life support? The Heart and Stroke Foundation of Canada has defined advanced cardiac life support for a patient in cardiac arrest, or a patient at immediate risk of cardiac arrest, as consisting of the following elements. Effective and minimally interrupted chest compression, for cardiac arrest. Use of adjunctive equipment for ventilation and circulation. Cardiac monitoring for dysrhythmia recognition and control. Establishment and maintenance of an intravenous line or intraosseous infusion line. Use of definitive therapy, including defibrillation and medication administration. 2. 1. Prevent cardiac arrest. 2. Aid in establishing an effective cardiac rhythm and circulation when cardiac arrest occurs. 3. Stabilize the patient's condition. Transportation with continuous monitoring. Chapter 13, Airway Management, already discussed the use of airway adjuncts and equipment for artificial ventilation. The following section is on the sequence of actions in advanced cardiac life support. The last section of the chapter will describe some of the specific techniques, such as defibrillation, for restoring an effective cardiac rhythm. The Universal Adult Cardiac Arrest Algorithm. The approach to every patient in cardiac arrest will start with the same steps. These basic steps are always deployed as soon as a person is found unresponsive and possibly in cardiac arrest. The basic life support healthcare provider algorithm includes measures that bystanders should take before your arrival, such as phone 911 or emergency number, so the universal algorithm is modified a bit to make it applicable to emergency medical services personnel. Whenever you are called for a case that might be a cardiac arrest, such as man down, unconscious woman, choking, stopped breathing, carry the defibrillator with you on your first trip from the ambulance to the patient. You should also carry a portable oxygen cylinder and a jump kit that contains equipment for managing the airway. If you have enough help, Take the intubation kit, the intravenous equipment, and the drug box as well. However, if you are short-handed, do not spend the time carting every piece of equipment from the ambulance to the patient. You can send someone to the ambulance for other equipment later. As soon as you reach the patient, one paramedic should prepare the monitor defibrillator for use while the other carries out the following steps in the order of CAB. 1. Assess for cardiac arrest. Check for responsiveness and respiratory effort. If the patient is not responsive and breathing is absent or not normal, for example gasping, then start chest compressions. Patients in cardiac arrest can have agonal gasps, and this should not stop you from performing cardiopulmonary resuscitation. Pulse detection can be unreliable even in trained rescuers. 2. Start chest compressions. Chest compressions should start as continuous compressions. Ventilations should start now if asphyxial or respiratory cause of the arrest is likely. If the cardiac monitor defibrillator is ready, proceed directly to step 3, otherwise, continue cardiopulmonary resuscitation until it is available. 3. Assess rhythm and need for defibrillation. Analyze the rhythm with a simultaneous pulse check for a maximum of 10 seconds. If the patient is in a shockable rhythm, ventricular fibrillation or ventricular tachycardia, resume cardiopulmonary resuscitation while charging the defibrillator, provide immediate defibrillation, resume cardiopulmonary resuscitation, and follow the algorithm applicable to the cardiac rhythm present, and pulse checks every 2 minutes, and administer any resuscitation medication indicated. If the patient is not in a shockable rhythm, and there is no pulse, then resume cardiopulmonary resuscitation immediately and follow the algorithm applicable to the cardiac rhythm present and pulse checks every 2 minutes, and administer any resuscitation medication indicated. 4. Ensure a cleared airway, suction if required, and provide ventilation. Be vigilant to avoid hyperventilation, either too much tidal volume or too high a rate. Place an oropharyngeal or nasopharyngeal airway, and begin cardiopulmonary resuscitation with 30 compressions to 2 ventilations. If there are 2 rescuers, you can perform either 30 to 2 or continuous compressions with 8 to 10 ventilations per minute. If an airway obstruction is suspected, refer to your service's airway obstruction algorithm, and continue with chest compressions. Treatment for ventricular fibrillation or pulseless ventricular tachycardia. Cardiac arrest patients who present in ventricular fibrillation or pulseless ventricular tachycardia are the most likely to survive. The best proven strategy to improve survival is rapid defibrillation. There are medication therapies that may increase chances return of spontaneous circulation, but it is not certain if they actually improve survival. Thus, focus on excellent quality cardiopulmonary resuscitation, early defibrillation, and then the usual medications, and other specific therapies. For the steps in managing ventricular fibrillation, and pulseless ventricular tachycardia, see Figure 30-111. 1. Follow the circulation, airway and breathing approach to cardiopulmonary resuscitation as described previously and in the basic life support algorithm, Appendix A. 2. Analyze the rhythm with a simultaneous pulse check for a maximum of 10 seconds as soon as the monitor defibrillator is ready and every 2 minutes thereafter. If you are using a semi-automated system for rhythm interpretation, the ambulance must be stopped to minimize artifact and improve accuracy of the automated rhythm interpretation. 3. Remember that other factors besides ventricular fibrillation and ventricular tachycardia can produce an erratic, disorganized waveform on the monitor, such as loose ECG leads or muscle tremor. Thus, ensure the patient is unresponsive, has no palpable pulse, and you have good lead connections. Remember, treat the patient and the monitor. You must pay attention to both. 4. The patient in a shockable rhythm, ventricular fibrillation or ventricular tachycardia, needs defibrillation. The energy used depends on the manufacturer's recommendation. If the recommendation is unknown, start at 200 joules for a biphasic device or 360 joules for a monophasic device. 5. To minimize parashock pause, resume compressions while charging the defibrillator. 6. Immediately resume cardiopulmonary resuscitation after defibrillation. Research indicates that even if an organized rhythm appears in the post-resuscitation period, the return of a pulse is delayed, and continuing cardiopulmonary resuscitation may be helpful in providing good circulation, and is unlikely to cause a return of ventricular fibrillation. 7. During the next 2 minutes of cardiopulmonary resuscitation, start an intravenous line with normal saline. If you are unable to establish an intravenous line, consider intraosseous access. 8. If the patient remains in a shockable rhythm, after second analysis, a vasopressor such as epinephrine can be administered after the second shock. Epinephrine is given as 1 mg intravenously or intraosseously, 1 to 10,000, rapid push. It should be repeated every 3 to 5 minutes, every second cycle of cardiopulmonary resuscitation, for the remainder of the resuscitation. The benefit of epinephrine is to improve good neurologic survival from out-of-hospital cardiac arrest. 9. An advanced airway, tracheal tube, is usually not required and can be delayed for the first 8 minutes or longer. A supraglottic airway and capnography are a great alternative, and may be considered now, or may be delayed if ventilation is adequate. If an advanced airway is used, ventilate every 6 to 8 seconds or 8 to 10 breaths per minute with continuous compressions at least 100 per minute without pause for ventilations. 10. After the third shock, refractory ventricular fibrillation or ventricular tachycardia can be treated with an antidysrhythmic. The first dose of amiodarone is 300 mg intravenously or intraosseously, rapid push. The second dose, in 3 to 5 minutes, is 150 mg intravenously or intraosseously, rapid push. Lidocaine is an alternative antidysrhythmic. Although both medications have been shown to increase the likelihood of survival to the hospital, neither have been shown to increase good neurologic survival from out-of-hospital cardiac arrest. 11. Consider reversible causes for the cardiac arrest and institute any specific treatments. 12. If at any time the rhythm is non-shockable, but the patient is still in cardiac arrest, then move to the pulseless electrical activity or asystole part of the algorithm. 13. If the patient regains signs of life or has a palpable pulse, stop cardiopulmonary resuscitation, assess the airway, breathing, and vital signs, and support and manage as per the post-resuscitation algorithm. The steps of the ventricular fibrillation or ventricular tachycardia part of the algorithm are shown in Figure 30-111. Treatment for asystole or pulseless electrical activity. If the cardiac arrest patient is found to be in a non-shockable rhythm, you need a focused approach to provide excellent quality cardiopulmonary resuscitation, provide vasopressor therapy, and search for possible reversible causes. Pulseless electrical activity refers to an organized cardiac rhythm, other than ventricular tachycardia, on the monitor that is not accompanied by any detectable pulse. This was formerly known as electromechanical dissociation. Asystole and pulseless electrical activity share a common pathway for management. Although the survival from non-shockable rhythms is not as good as shockable rhythms, patients may still survive, especially when a reversible cause is found and managed. When the rhythm and monitor check reveal a pulseless patient with a non-shockable rhythm, any rhythm other than ventricular fibrillation or ventricular tachycardia, then perform the following steps. 1. Immediately resume cardiopulmonary resuscitation. 2. Confirm the rhythm tracing is not due to loose ECG leads or improper connections or lead selection on the monitor. Ensure the patient is unresponsive and without a pulse. Remember, treat the patient and the monitor. 3. During the next 2 minutes of cardiopulmonary resuscitation, start an intravenous line with normal saline. If unable to establish an intravenous line, consider intraosseous access. 4. A vasopressor such as epinephrine can be administered when a route is available. Epinephrine is given as 1 mg intravenously or intraosseously, 1 to 10,000, rapid push. It should be repeated every 3 to 5 minutes, every second cycle of cardiopulmonary resuscitation, for the remainder of the resuscitation. The benefit of epinephrine to improve the chance of a good neurologic outcome from out-of-hospital cardiac arrest if the resuscitation is successful. 5. An advanced airway, tracheal tube, is usually not required and can be delayed for the first 8 minutes or longer. A supraglottic airway and capnography are a great alternative, and may be considered now, or may be delayed if ventilation is adequate. If an advanced airway is used, ventilate every 6 to 8 seconds or 8 to 10 breaths per minute with continuous compressions at least 100 per minute without pause for ventilations. 6. Consider reversible causes for the cardiac arrest and institute any specific treatments. See Table 30-19. 7. If at any time the rhythm is shockable, then move to the ventricular fibrillation or ventricular tachycardia part of the algorithm. 8. If the patient regains signs of life or has a palpable pulse, stop cardiopulmonary resuscitation, assess the airway, breathing, and vital signs, and support and manage as per the post-resuscitation algorithm. Use of capnography in cardiac arrest. Capnography can be a useful tool in cardiac arrest. There are 5 main uses. 1. Verify tracheal tube placement. 2. Identify tracheal tube displacement. 3. Evaluate cardiopulmonary resuscitation quality. As discussed earlier, with consistent ventilation, end-tidal carbon dioxide will increase with increased cardiac output, and high-quality cardiopulmonary resuscitation. 4. Identify return of spontaneous circulation. 5. Determine when return of spontaneous circulation is unlikely. In patients receiving effective cardiopulmonary resuscitation, cellular respiration is able to continue. In addition to the techniques and cardiopulmonary resuscitation factors to monitor, capnography can also be used to monitor cardiopulmonary resuscitation quality. To follow capnography, the provider will require either a tracheal tube or a supraglottic airway. Higher end-tidal carbon dioxide values correspond to higher cardiac output and indicate good cardiopulmonary resuscitation, whereas lower values may indicate that it is time to change compressors or that they need encouragement to improve their cardiopulmonary resuscitation quality. If the end-tidal carbon dioxide value is decreasing, observe for chest compressor fatigue, hyperventilation, airway obstruction, or tracheal tube displacement. If the value is increasing, cardiopulmonary resuscitation is likely effective and ventilation appropriate. If the value rises substantially, this can indicate a return of spontaneous circulation. After 20 minutes of advanced cardiac life support cardiac arrest care, recent evidence has shown that end-tidal carbon dioxide levels persistently less than 10 millimeters of mercury are associated with futility. Exceptions include hypothermia. Conversely, levels greater than 25 millimeters of mercury are associated with survival. In the near future, there may be a rule for prognosis in resuscitation utilizing capnography. In the meantime, it is another useful piece of information. Post-resuscitative pre-hospital care. If an effective cardiac rhythm and pulse are restored in the pre-hospital environment, you need to take an orderly approach to supporting the patient in the post-resuscitation period. Follow an ABC approach to ensure optimization of the airway, ventilation, and circulation, as shown in Figure 30-114. After restoration of a pulse, you should use an ABCD approach. Determine if the patient requires ongoing airway and ventilation management. If a supraglottic airway was placed, this can be left in place for 1 or 2 hours, but will likely be switched to a tracheal tube prior to admission to the hospital. If the patient is making purposeful movements, an airway may need to be removed or the patient will need to be sedated. It is crucial to assess and support ventilation as required. Be cautious not to hyperventilate, this is very common and can reduce the cardiac output. Use waveform capnography and titrate ventilation to aim for an end-tidal carbon dioxide of 35 to 40 millimeters of mercury. Although it may be difficult to do until you arrive at the hospital, To avoid oxygen toxicity, titrate the inspired oxygen to the lowest possible level to achieve an oxygen saturation of 94% to 98%. The rhythm and perfusion may be problematic early after return of spontaneous circulation, and they need careful evaluation. Support hypotension initially with intravenous crystalloid therapy, and consider inotropes if the patient is not initially responsive and has an systolic blood pressure of less than 90 mm of mercury. An early post-return of spontaneous circulation 12-lead ECG may capture clear ST elevation that warrants coronary angiography. Be sure to update your receiving facility of your findings. Rhythm disturbances may also need to be managed, but may improve simply through adequate ventilation and support. Utilize your bradycardia and tachycardia algorithms if required. Once the cardiac rhythm is stable, attention turns to the brain, D equals disability, and to ameliorating the effects of cardiac arrest on it. Marked hypotension needs to be corrected rapidly because the brain will not be adequately perfused when the blood pressure is very low. Administer a fluid bolus of 1 to 2 liters normal saline or lactated Ringer solution. If the patient has marked hypotension, and the transport time to the hospital will be prolonged, in addition to fluids, you may also need to start dopamine or norepinephrine. In an intubated patient, avoid tracheal suctioning unless absolutely necessary. Suctioning tends to increase intracranial pressure. Consider elevating the patient's head to approximately 30 degrees to increase cerebral venous drainage. Therapeutic hypothermia of comatose patients with return of spontaneous circulation is very beneficial, with initiation typically taking place on arrival to the emergency department. Post-resuscitative care is complex and best carried out in a critical care setting where careful monitoring and titrated therapy can most effectively be given. If an effective cardiac rhythm is restored in the pre-hospital environment, transport should be expeditious, but initial post-resuscitative management will usually need to be started before transport. The following is a summary of the usual post-resuscitative pre-hospital care. A. Consider the need for an advanced airway. B. Provide optimal ventilation and use waveform capnography. Target end-tidal carbon dioxide of 35 to 40 mm of mercury and optimal oxygenation with a target oxygen saturation of 94% to 98%. C. Provide optimal perfusion with a target systolic blood pressure of greater than 90 mm of mercury. Treat hypotension with intravenous or intraosseous crystalloids and inotropes as needed. Treat significant dysrhythmias. Do a 12-lead ECG and look for signs of ST elevation. Findings should be communicated to receiving facility. D. Ensure optimal cerebral care by supporting all of the previous items, as well as raising the head of the bed by 30 degrees, and considering therapeutic hypothermia if comatose. When to stop resuscitation. Since the dawn of paramedic-staffed ambulances in the early 1970s, many communities have not permitted the termination of cardiopulmonary resuscitation in the pre-hospital environment. That standard was in place because usually only a physician, or nurse, is authorized to determine or declare death. Cardiac arrest patients who were not successfully resuscitated at the scene were invariably transported urgently to the hospital, with some semblance of cardiopulmonary resuscitation occurring en route. With the accumulation of vast experience from EMS systems throughout the United States and Canada, it soon became clear that transport to the emergency department of adults who did not respond to an adequate trial of pre-hospital advanced cardiac life support was an exercise in futility. Fewer than 1% who did not respond to pre-hospital advanced cardiac life support ultimately survived. This policy was also given as the example of an unethical practice in the guidelines because it instills false hope in the family. Furthermore, rapid transport of patients in cardiac arrest, with cardiopulmonary resuscitation en route, involves considerable hazards to paramedics. The risks of vehicular collisions or of injuries while working in a moving ambulance are greatly increased during urgent transport. Many EMS systems in Canada allow paramedics to contact direct medical control after failed initial advanced cardiac life support resuscitation for consideration to cease resuscitation in the pre-hospital environment. You should discuss the specific case with their physician to determine if the resuscitation is truly futile, less than 1% chance of survival, prior to ceasing resuscitation. The ALS or Advanced Life Support, Termination of Resuscitation, rule was derived by Canadian Emergency Medical Services researchers, and has been proposed by the American Heart Association and Heart and Stroke Foundation of Canada for use by advanced care paramedics. The rule excludes patients whose cardiac arrest is thought to be due to trauma, hanging, drowning, hypothermia, or toxicology. Table 30-20 summarizes the criteria that can be discussed with a physician after 15 to 20 minutes of advanced cardiac life support resuscitation, including 3 rounds of medications. There may be other extenuating circumstances where termination of resuscitation may be considered after discussion with a physician, such as persistent asystole after prolonged resuscitation. There may also be a role for ceasing resuscitation in certain situations with a provider equipped with an automated external defibrillator but no other advanced cardiac life support care. A Canadian-derived termination of resuscitation prediction rule outlines a subgroup of out-of-hospital cardiac arrests managed by trained paramedics where futility may exist, and it may be appropriate to stop resuscitative efforts in the pre-hospital setting. See Table 30-20. This rule found that only 0.5% of patients in cardiac arrest if the arrest was not witnessed by paramedics, no shocks were administered, and there was no return of spontaneous circulation in the pre-hospital environment. 3 analyses. This rule would reduce the number of transports by 50%. Contact with direct medical control in these situations allows the paramedic and physician to discuss the specific patient and situation prior to ceasing resuscitation. In addition to the BLS-TOR and ALS-TOR rules, there are other criteria that paramedics and physicians may use to determine whether to continue resuscitation en route to the hospital. This may include special circumstances such as prolonged transport time, greater than 30 to 60 minutes, or prolonged persistent asystole. A newer tool to assist in determining futility is the use of capnography, as discussed earlier. Provincial legislation and/or medical authority approval is required to permit termination of resuscitation at the scene by a paramedic. Each emergency medical services system will have to formulate its own criteria and protocols for termination of resuscitation in the pre-hospital setting. Receiving permission to stop cardiopulmonary resuscitation in the pre-hospital environment will not necessarily make your job easier. Delicate issues are involved, such as the expectations and support of the patient's family. Stopping cardiopulmonary resuscitation may also be difficult for you. You will find yourself in the unaccustomed role of having to tell a family, your loved one is dead, there is nothing more that can be done. It is much easier to transport the person to the medical facility, and leave the emergency department staff with the unpleasant task of breaking the bad news. If your EMS system is allowed to stop cardiopulmonary resuscitation in the pre-hospital environment, it will be a good idea to walk through some of the scenes you may have to face. Role-play exercises can be particularly useful in helping you to pinpoint situations in which you feel uncomfortable and develop strategies in advance for dealing with those situations. Management of symptomatic bradycardia and tachycardia. The treatment of bradycardic and tachycardic rhythms starts with a focus on the clinical assessment. Assess and manage the patient for any reversible causes before considering if the rhythm is the cause of any instability. Hypoxia, hypothermia, hypovolemia, toxins, or other clinical disorders may cause the bradycardia or tachycardia, and treating the rhythm will not treat the underlying problem. Thus, ensure a patent airway, assist ventilation if needed, ensure adequate oxygenation, 90% to 94%, have a full set of vital signs, complete the primary assessment, identify the rhythm, and then consider whether the rhythm is the primary problem or just a symptom. Dysrhythmia management depends on categorizing the patient's condition as unstable and symptomatic. Unstable is used for those patients with poor end-organ perfusion, hypotension, altered mental status, ischemic chest pain, acute heart failure, or pre-arrest. Symptomatic describes the patient who has symptoms but is otherwise stable. Common symptoms may include palpitations, dyspnea, or lightheadedness. Management of symptomatic bradycardia. Bradycardia management starts with the clinical assessment as previously outlined, with exploration of whether it is the rhythm that is causing the symptoms or the reverse. Hypoxia is a common cause of bradycardia, and the hypoxia should be corrected rather than treating the rhythm. Bradycardia is defined as a heart rate of less than 60 beats per minute, but symptomatic bradycardia is almost always less than 50 beats per minute. The treatment algorithm for bradycardia does not heavily rely on rhythm interpretation. Most bradycardic rhythms are treated the same, with only one exception noted in the following list. Once other causes have been excluded, then management will depend on whether the patient is unstable or only symptomatic. Symptomatic and stable bradycardias do not require management in the field. They should be monitored en route, and can await any further treatment in the hospital. Unstable bradycardias will require management, which starts with atropine as a first line, and then proceeds to transcutaneous pacing and/or chronotropic or inotropic support if needed. 1. Ensure a patent airway, assist ventilation if needed, and ensure adequate oxygenation, oxygen saturation 90% to 94%. 2. Measure vital signs, identify rhythm, and perform a 12-lead ECG. Establish an intravenous line of normal saline. 3. Search for and manage any reversible causes. 4. For symptomatic but stable bradycardias, no further treatment required, monitor en route. 5. For unstable bradycardias, initial specific therapy is as follows. Administer atropine 0.5 mg intravenous bolus. This dose may be repeated every 3 to 5 minutes until the heart rate is greater than 60 beats per minute or to a maximum of 3 mg. Patients with a high-degree atrioventricular block, second-degree type 2 or third-degree block with a wide QRS, may not respond to atropine, but it can be trialed while preparing for the next therapy. The increase in heart rate accomplished by atropine cannot be titrated and tachycardia may lead to increased workload on the heart. Use caution and consider pacing in patients with cardiac ischemia. Institute one of the next two therapies if atropine is ineffective, during a trial of atropine in a patient with poor perfusion, if no intravenous access is available, or in a patient with a high-degree atrioventricular block, second-degree type 2 or third-degree block with a wide QRS. Establish transcutaneous pacing at a rate of 60 to 80. Transcutaneous pacing has been shown to be effective in temporizing the patient en route to hospital. It can be uncomfortable, so the patient may require analgesia or sedation. Consider chronotropic support with dopamine or epinephrine, if the above therapies are ineffective. These medications are often successful in rapidly stabilizing the patient, but the additional actions may cause increased cardiac workload and ischemia and so should be used cautiously. Dopamine is administered at its usual dose of 5 to 20 micrograms per kilogram per minute. Dopamine is available in premixed bags, which simplifies initiation of the infusion, but be aware that these bags come in different concentrations. Always check the concentration before determining drip rate. 6. Monitor the patient en route to hospital, and alert the facility staff so that they may prepare for pacing of the patient. Patients who are symptomatic and require transcutaneous pacing in the pre-hospital environment often require a temporary transvenous placed in the hospital, and ultimately the surgical implantation of a permanent pacemaker. Early identification and hospital notification can often speed this process. The steps to initiate transcutaneous pacing are discussed later in the chapter. Management of tachycardia. Tachycardia management starts with the same clinical assessment as previously outlined. The first steps are to ensure a secure airway, oxygenation, and ventilation, then obtain the patient's vital signs, and initiate cardiac monitoring, and a 12-lead ECG. Next, determine whether it is the rhythm that is causing the symptoms or whether the tachycardia is the response to another condition. Tachycardias with rates less than 150 beats per minute are rarely fast enough to cause serious signs and symptoms. For example, the patient who is experiencing acute heart failure is almost always tachycardic, sinus tachycardia or atrial fibrillation, but it is rarely the tachycardia causing the signs and symptoms. Conversely, a patient who was previously asymptomatic but becomes symptomatic only after the onset of the tachycardia is more likely presenting with symptoms resulting from the tachycardia. It is critical to make this distinction before beginning treatment, because slowing the heart rate of a patient whose heart is compensating for a medical condition may be a fatal mistake. Once other causes have been excluded, management will depend on whether the patient's condition is unstable or only symptomatic. Unstable tachycardias will require synchronized cardioversion, whereas stable symptomatic tachycardia treatment depends on the rhythm and requires rhythm interpretation. Any patient with a tachycardic rhythm should be monitored carefully with the following steps. A heart that is stressed by the requirements of excessive tachycardia is very likely to become ischemic and is at high risk for arrest. 1. Ensure a patent airway, assist ventilation if needed, and ensure adequate oxygenation, oxygen saturation 90% to 94%. 2. Measure vital signs, identify rhythm, and perform a 12-lead ECG. Establish an intravenous line if normal saline. 3. Search for and manage any reversible causes. 4. For unstable tachycardias, prepare for synchronized cardioversion. If it is clearly irregular, narrow complex tachycardia, adenosine may be considered first, dosing given later. In the conscious patient who needs cardioversion, sedation, usually with midazolam, is a consideration. Wait an appropriate amount of time for the sedation to take effect, if there is time. Do not wait if the patient is unconscious or worsening. Be prepared for the side effects of sedation, mainly a drop in blood pressure or suppression of respiratory rate. The procedure of cardioversion is discussed later. 5. For persistent, symptomatic, but stable tachycardias, the treatment is based on whether the rhythm is narrow or wide. For wide complex, stable, symptomatic tachycardias, consider intravenous antidysrhythmics. The treatment could include adenosine, in rare monomorphic, regular tachycardias, procainamide, or amiodarone, or lidocaine, but most commonly the patient would be transported with careful monitoring. For narrow complex, stable, symptomatic tachycardias, further treatment depends on the rhythm. Sinus tachycardia would not normally be treated with antidysrhythmics. Regular narrow complex tachycardias could be managed with vagal maneuvers, and then adenosine if the maneuvers are not effective. Adenosine will not convert sinus tachycardia, atrial flutter, or atrial fibrillation. Beta blockers or calcium channel blockers may be used to slow these rhythms, but they are not commonly used by paramedics. Irregular narrow complex tachycardias can also be slowed with the latter two agents. Because the conditions of all of these patients are stable, they can also be transported with careful monitoring en route without specific treatment. 6. Monitor the patient carefully en route to the hospital, as tachycardias can cause cardiac ischemia and the condition of the patient may become unstable or change quickly. Alert the receiving facility so that the staff may prepare for the patient's arrival. Vagal maneuvers can successfully convert 15% to 50% of atrioventricular nodal tachycardias. A Valsalva maneuver requires coaching the patient to forcefully exhale against a closed airway or glottis. You can suggest they bear down similar to when having a bowel movement, and hold their breath, allowing only very slow forceful expiration. Another good coaching technique is to have the patient try to lift both legs up off the stretcher while doing the same forced, slow expiration. The modified Valsalva technique, success rate of 40%, can be completed by having a person who is sitting semi-reclined blow into a 10 ml syringe for 15 seconds, blow hard enough to just move the plunger, and then lie them supine and assist them in elevating both legs. Conversion to sinus from a relatively easy and safe technique like this is great for your patient. A technique that works especially well with infants or young children is placing a bag of ice-cold water on the face. This act elicits the diving reflex and the patient will hold his or her breath, which stimulates a reflex bradycardia. The procedure can be distressing for the child and the family, so it must be done with prior discussion and warning that the child may be frightened. Carotid sinus massage is another technique, but it is rarely used because, in some patients, such as those who have atherosclerosis, it can cause plaque disruption and embolic stroke. Carotid sinus massage may also cause syncope from a prolonged bradycardic and/or asystolic response. Therefore, carotid sinus massage is considered a high-risk procedure and is better avoided. Intravenous access before these maneuvers are performed may be safer, but is not strictly required, as patients with recurrent atrioventricular nodal tachycardia often perform these themselves before seeking medical attention. Techniques to manage cardiac emergencies. This section profiles some of the devices and methods used in the treatment of patients with cardiac emergencies. Not all of the techniques or devices described are used in every EMS system, and not all are required for certification as a paramedic. Direct your attention to the material that is relevant to your local practice. Defibrillation. Defibrillation is the process by which a surge of electric energy is delivered to the heart. Recall that when the heart fibrillates, its individual muscle fibers get out of sync with one another and begin contracting individually. As a result, the heart as a whole ceases any useful coordinated movement. Indeed, if you were to look at a fibrillating heart, you would see movement resembling that of a bag of energetic worms. The idea behind defibrillation is to deliver a current powerful enough to depolarize all of the heart's component muscle cells. Ideally, when those cells repolarize after the shock, they will respond to an impulse from the sinoatrial node, and begin organized depolarization, leading to cardiac contraction. Defibrillation needs to be carried out as soon as possible in ventricular fibrillation or pulseless ventricular tachycardia because the likelihood of its success declines rapidly with time. Perform cardiopulmonary resuscitation only long enough to charge the defibrillator, and then defibrillate. Defibrillation is not useful in asystole because there is no evidence that the myocardial cells are spontaneously depolarizing. Defibrillation of asystole is unlikely to be beneficial and may be harmful. Skill drill. 30-3 summarizes the procedures for manual defibrillation. Skill drill 30-3. Performing manual defibrillation. Step 1. Select, check, and assemble all necessary equipment, including a monitor or defibrillator with defibrillation pads, oxygen, and an appropriate oxygen administration device. Take routine precautions, and ensure the scene and environment are safe. Evaluate the risk of sparks, combustibles, oxygen-rich atmosphere. Step 2, if available, and possible without interrupting care, ask bystanders about the events surrounding the arrest. Check responsiveness. Request additional help, if needed. Step 3, assess the patient for breathing while simultaneously checking for a carotid pulse. Step 4, begin chest compressions if the patient is not breathing or is only gasping and has no pulse. Ensure an adequate depth and rate, use the correct compression to ventilation ratio, allow the chest to recoil completely, deliver an adequate volume for each breath, and keep interruption of chest compressions to 10 seconds or less throughout the resuscitation effort. Step 5, turn on the power to the defibrillator. If EMS providers have been using the machine in automated external defibrillator mode before your arrival, switch the machine to manual mode. Step 6, remove the clothing from the patient's upper body. With gloves, remove any medication paste or patches from the patient's chest, and wipe away any residue. Step 7, if using standard paddles, place pre-gelled defibrillator pads on the patient's chest, or apply defibrillator gel to the electrode surface of the paddles. If using adhesive electrodes, place one electrode just to the right of the sternum just below the clavicle and place the other on the left lower chest area with the top of the pad 5 to 7 centimeters below the armpit, or position the electrodes according to the manufacturer's instructions. Do not place electrodes on top of breast tissue. If necessary, lift the breast out of the way and place the electrode underneath. Step 8, stop cardiopulmonary resuscitation, identify the rhythm, and confirm that a shockable rhythm is present. Step 9, set the defibrillator to 200 joules, for biphasic devices, or follow the defibrillator manufacturer's recommendations regarding the appropriate energy level. Monophasic defibrillators should be set to 360 joules for the first and all successive shocks. Charge the defibrillator, and wait for it to indicate it is charged. Step 10. Clear the area. Announce, "All clear," and ensure no one is touching the patient. Press the shock button on the machine if using a hands-free system. If using paddles, depress the shock button on each paddle at the same time, and hold until the defibrillator discharges. Resume cardiopulmonary resuscitation immediately. This is the end of skill drill 30-3. Defibrillation algorithm. To perform defibrillation, attach the adhesive defibrillation pads to the chest as instructed on the package. You want the current to go from one pad to the other to travel through the heart, and not just along the skin, so think of the pads as the bread in the heart sandwich. The pads cannot touch or be too close together or the electric current will simply pass along the skin from one pad to another and bypass the heart. There are 4 acceptable pad positions: anterolateral, anteroposterior, anterior left infrascapular, and anterior right infrascapular. When not specified, anterolateral is a reasonable default position, which is the same positioning if paddles are used. Position the negative or sternum paddle just to the right of the upper part of the sternum below the right clavicle, and the positive or apex paddle below and to the left of the left nipple. Lateral pads or paddles should be placed under or lateral to breast tissue. If the patient is diaphoretic or has long chest hair, you may have to dry or shave the skin before placing the pads, but this should be done quickly so as not to delay defibrillation. Charge the defibrillator. Ensure chest compressions are restarted during charging to minimize parashock pause. If there is a nitroglycerin patch on the patient's chest, remove it and wipe the skin dry before you apply the defibrillator paddles. Although nitroglycerin does not explode, contrary to popular legend, the backing used on some nitroglycerin patches can support electrical arcing during defibrillation, producing smoke, noise, and burns to the patient. When the defibrillator is charged, clear the area so that no one, including the operator, is in contact with the patient or stretcher. The operator should then announce, "All clear." At this point, press the shock button on the machine until you hear and see the shock being delivered. If current has reached the patient, contraction of the chest and other muscles will be evident. If you do not see contraction, check the defibrillator to be certain the synchronizing switch is off and the battery is charged. Immediately after delivering the defibrillating current, resume cardiopulmonary resuscitation. Continue cardiopulmonary resuscitation for 2 minutes or 5 cycles, and then pause to check for a pulse, and re-evaluate the rhythm. If at any point you see signs of life, patient movement, check for a pulse. An automated implanted cardioverter defibrillator or pacemaker, which you may detect from the pacemaker produce spikes on the ECG or the bulge where its battery pack has been implanted under the patient's skin, is not a contraindication to defibrillation. Just avoid placing the electrode paddles or pads directly over the pacemaker battery. The defibrillator should be inspected at the beginning of each shift, using a checklist to cover all aspects of the apparatus and its gear. Inspection should include the cables and connectors, power supply, monitor, ECG recorder, and any ancillary supplies, such as pads and spare battery. Your service should have a standard checklist procedure that you follow at the beginning of every shift. This will ensure your equipment, including your defibrillator, is in proper working order. Automated external defibrillator. An automated external defibrillator is a defibrillator that can analyze the patient's rhythm itself and then advise the provider whether it is a shockable rhythm or not. The semi-automatic automated external defibrillator identifies the rhythm, and then instructs the rescuer what to do about it. If, for example, the automated external defibrillator detects ventricular fibrillation, a voice prompt may say, "Shock advised." Press to shock. The rescuer must then depress the shock button to defibrillate the patient. Thus the A in automated external defibrillator is automated and not automatic. These are the basic sequence of steps for using an automated external defibrillator in a patient without a pulse. 1. turn on the automated external defibrillator. This should always be the first step, as the device will start providing audio prompts to help you remember the next steps required. 2. Expose the patient's chest. 3. Attach the two self-adhesive electrode pads firmly to the patient's chest, the sternal pad at the junction of the right clavicle and upper border of the sternum, and the apex pad along the left lower rib margin at the anterior axillary line. 4. Stop cardiopulmonary resuscitation, and instruct everyone to get clear of the patient. 5. The automated external defibrillator assesses the rhythm, for 6 to 20 seconds, and determines whether it is shockable, that is, whether the rhythm is one that will respond to defibrillation. 6. If the automated external defibrillator detects a shockable rhythm, it automatically starts charging, which takes 5 to 10 seconds. 7. The defibrillator indicates if a shock is advised, and the rescuer pushes the button to deliver the shock. 8. The automated external defibrillator may indicate no shock advised, which means that the patient is in a non-shockable rhythm such as asystole or pulseless electrical activity. 9. Restart cardiopulmonary resuscitation, and continue for 2 minutes before stopping cardiopulmonary resuscitation, and having the automated external defibrillator analyze the rhythm again as in Procedure 5. Although a layperson would not check a pulse during the rhythm analysis, a provider should. New automated external defibrillators appear on the market all the time, and each model comes with its own operating manual. If you will be using an automated external defibrillator, train with the specific apparatus carried by your service, using the manufacturer's instructions for that machine. Cardioversion. Cardioversion is the use of the defibrillator to terminate tachydysrhythmias in a patient with a pulse. Electrical cardioversion is performed just as defibrillation, except that the synchronized setting on the defibrillator is selected first. When the defibrillator is fired in the synchronized mode, the machine monitors the R waves of the QRS complexes, and delivers the shock at a time when the R-on-T phenomenon is least likely to occur. Recall that the R-on-T phenomenon occurs when the defibrillator fires so that the R wave occurs at the top of the T wave, depolarization before repolarization, and can result in ventricular dysrhythmias such as ventricular fibrillation. By using the synchronization setting, this can be avoided so that the depolarization occurs at a safer time. In the pre-hospital environment, cardioversion is carried out only for patients whose conditions are unstable, that is, patients with rapid ventricular and supraventricular rhythms causing symptoms such as hypotension, decreased level of awareness, chest pain, or pulmonary edema. The unconscious patient will not require sedation, but otherwise sedation should be considered prior to cardioversion to reduce pain and anxiety. Medications commonly used for sedation in these circumstances include benzodiazepines such as midazolam. Follow your medical director's instructions. Be prepared for side effects of sedation given during cardioversion, such as hypotension or decreased respiratory rate. The following is the procedure for cardioversion. Skill Drill 30-4. Performing synchronized cardioversion. Step 1. Take routine precautions. Step 2. Prepare the equipment. Place ECG electrodes and lead wires in the same position as you would if you were performing cardiac monitoring or acquiring a 12-lead ECG. Either way is fine. The best lead to use is lead 2, because the R wave is tallest in this lead. White electrode, right arm or shoulder. Black electrode, left arm or shoulder. Red electrode, left leg or lower chest. Green electrode, right leg or lower chest. Step 3. Place the multi-purpose quick connect pads in the proper positions. Turn the main power on and assess the patient's rhythm. Step 4. Turn the machine's synchronized switch to the on position, unlike for defibrillation, and ensure the monitor is demonstrating synchronization marks associated with every R wave. Note that the limb leads and defibrillation pads must be in place to perform synchronized cardioversion, as the device is unable to sense electrical activity and deliver electricity through the same cable. Step 5. Assess the pulse. If pulse is absent, Re-evaluate the ECG rhythm and the need for other interventions. If a pulse is present, proceed with cardioversion. Step 6. Check the patient's blood pressure. Sedate the patient if time permits. Step 7. Confirm the rhythm and ensure that the defibrillator is synchronized to the R wave. Set the energy level as ordered by the physician or your medical directive. Charge the defibrillator and hold the shock button until the defibrillator discharges. This may take a few seconds because the charge is synchronized to fire approximately 10 milliseconds after the peak of the R wave. Step 8. Reassess the patient's condition, ECG rhythm and pulse. Repeat the cardioversion if necessary at a joule setting as per the physician order or medical directive, ensuring the monitor is synchronized each time. This is the end of skill drill 30-4. Transcutaneous cardiac pacing. Like the tiny electric currents generated by natural pacemakers, the current from an artificial pacemaker can cause the myocardial tissue to depolarize. In this way, the artificial pacemaker can substitute for a natural pacemaker that is not functioning normally. Transcutaneous pacing is often used for unstable bradycardias unresponsive to supportive management and atropine. It is not used for asystole. In transcutaneous pacing, a small electrical charge is passed through the patient's skin and across the heart muscle between one externally placed pacing pad and another. The pacer is set for a specific rate, and the energy is increased until the heart just begins to respond to the stimulus. This phenomenon, which is termed capture, is usually associated with depolarization of the ventricles, which appears as a wide QRS complex on the ECG and results in a corresponding pulse. In general, the steps in initiating transcutaneous pacing are listed here and shown in Skill Drill 30-5. Skill Drill 30-5. Performing transcutaneous pacing. Step 1. Take routine precautions. Step 2. After connecting the patient to the ECG monitor and assessing the initial vital signs, determine the need for transcutaneous pacing based on the indications previously listed. Obtain a pre-capture strip of the ECG tracing for documentation. Explain the need for transcutaneous pacing to the patient and the family. Obtain intravenous access, but this should not delay transcutaneous pacing. Step 3. Apply pacing electrodes. Often, the same pads can be used for defibrillation and pacing. The pads can be placed similarly for defibrillation, or the alternative is to place one pad anteriorly left of the lower sternum, and the other pad posteriorly just below the left scapula. Step 4. Switch on the pacer power. Step 5. Set the pacing rate. 70 to 80 beats per minute is commonly chosen. Step 6. Start increasing the current. Raise the current by 10 to 20 milliamps every few seconds. Step 7. Check for capture. Look for electrical capture, every pacemaker spike being followed by a, usually wide, QRS complex. If the QRS is not present, the pacemaker current is not depolarizing the ventricles. Increase the current gradually until there is consistent electrical capture. Check for mechanical capture, a pulse associated with each QRS complex. Step 8. Once both electrical and mechanical capture is achieved, briefly lower the current until capture is lost, and then increase it by 5 to 10 milliamperes to restore capture. The purpose of this action is to find the lowest energy setting that achieves consistent capture. Obtain rhythm strips for documentation. This is the end of Skill Drill 30-5. Transcutaneous pacemakers depolarize not only cardiac muscle, but also muscles in the chest wall beneath the pacing electrode. As a result, patients who are conscious when transcutaneous pacing is initiated, or who regain consciousness during pacing, usually experience chest discomfort, and sometimes severe pain from the procedure. Some form of analgesia, morphine or fentanyl, and/or sedation, midazolam, is usually required by conscious patients when transcutaneous pacemakers are used. Technological advances in resuscitation. The last decade has seen incredible advances in technology that affect circulation. This technology can be categorized in 3 ways: devices that replace heart-lung function to avert death, devices that support cardiac output while the heart recovers from illness or until a heart transplant becomes available, and devices that allow patients to go home pending cardiac transplant. Extracorporeal life support. When conventional resuscitation of out-of-hospital cardiac arrest is unsuccessful, it may be beneficial to place a patient on extracorporeal, out-of-body, support. This involves cannulating large blood vessels, and diverting blood to a machine that oxygenates the blood before returning it to the body circulation. Extracorporeal membrane oxygenation that is used during cardiac arrest is called extracorporeal cardiac life support. Extracorporeal cardiac life support can generate blood flow equivalent to normal physiology in a body without a beating heart. Extracorporeal cardiac life support may allow physicians extra time to reverse the life-threatening effects of reversible causes in select patients, such as acute coronary artery occlusion, refractory ventricular fibrillation, pulmonary embolism, hypothermia, myocarditis, cardiomyopathy, heart failure, poisoning, and traumatic injury, or serve as a temporary life-sustaining bridge until implantation of a left ventricular assist device or heart transplant. The ideal time to abandon conventional resuscitation and initiate extracorporeal cardiac life support is unclear. Timelines of 10 to 30 minutes have been proposed, with many programs considering 60 minutes to be the limit of benefit. The longer conventional cardiopulmonary resuscitation is unsuccessful, the less chance extracorporeal cardiac life support will be of benefit. However, the earlier you start extracorporeal cardiac life support, the sooner you expose the patient to very invasive procedures that may not have been necessary if conventional techniques had worked. Extracorporeal cardiac life support programs are complex and require coordination between pre-hospital and in-hospital teams, specialized training and equipment, and a strong systems approach to resuscitation. Most studies supporting extracorporeal cardiac life support have been done on patients who are in the hospital. Some studies of extracorporeal cardiac life support initiated on hospital arrival of out-of-hospital cardiac arrest patients have demonstrated improved neurologic recovery in those receiving extracorporeal cardiac life support, but more evidence is needed to best understand how extracorporeal cardiac life support should be employed by EMS. In systems with very limited inclusion criteria, survival has been reported as high as 54%. However, these programs are very specific in whom they chose to receive extracorporeal cardiac life support, usually excluding people older than 60 years or with comorbidities like liver failure, lung disease, and cancer. In out-of-hospital cardiac arrest programs with broader inclusion criteria, reported survival rates of 10% to 15% have been achieved, although good quality manual cardiopulmonary resuscitation in an integrated system can have similar results. The Heart and Stroke Foundation's Emergency Cardiac Care and Cardiopulmonary Resuscitation Guideline updates from 2018 state the following regarding extracorporeal cardiac life support, also referred to as extracorporeal cardiopulmonary resuscitation. Extracorporeal cardiopulmonary resuscitation may be considered for select cardiac arrest patients for whom the suspected etiology of the cardiac arrest is potentially reversible during a limited period of mechanical cardiorespiratory support. While exciting, the future of field extracorporeal cardiac life support remains uncertain as it requires a great deal of resources. Devices that support cardiac output. Emergency medical services crews may occasionally be called on to help facilitate the transport of patients on devices that support cardiac output to tertiary or quaternary care centers. We will discuss two such devices that are most common. Intra-aortic balloon pumps. Intra-aortic balloon pumps are helium-filled balloons placed in the proximal descending aorta. These balloons are synchronized to an ECG waveform of a beating heart to inflate during diastole, and deflate during systole. This is thought to reduce afterload, improving left ventricular stroke volume, and increase coronary perfusion pressure, leading to better myocardial oxygenation. Cerebral blood flow is also thought to be improved. These devices often support shocked hearts for a period of days until such time that the heart muscle recovers from injury. Primary injury can be myocardial infarction, poisoning, or infection. Transport of these patients is precarious as the balloon is tethered to the machine and nitrogen supply, and great care must be taken when moving the patient or loading or unloading the machine to ensure tension is not applied to the wires and tubes connecting the patient and the intra-aortic balloon pump. Specially trained nurses, perfusionists, or paramedics are typically responsible for the intra-aortic balloon pump, and additional support in the form of infused medications are commonly used. Many, but not all, patients with intra-aortic balloon pumps are on mechanical ventilators. Air medical principles do not limit use of intra-aortic balloon pumps on aircrafts with unpressurized or pressurized cabins. Impella heart pump. Impella pumps are percutaneous left ventricular assist device. An impeller is similar to a propeller. The difference between the two is not really important unless you engineer left ventricular assist devices. Functioning like a swimming pool pump, it has an inlet in the left ventricle and an outlet in the proximal aorta, and is capable of pumping 5 liters of blood a minute through the left ventricular outflow tract, across the aortic valve. It is continuous flow, and unlike an intra-aortic balloon pump does not cycle or require synchronization with the heart. Unlike intra-aortic balloon pumps, Impella devices force blood out of the left ventricle, offloading cardiac workload. While some left ventricular function is required, the Impella can almost entirely compensate for a failed left ventricle in a resting patient. Like intra-aortic balloon pumps, Impella devices are not permanent, but rather are meant to support the heart's usual function as it recovers or as a bridge to transplantation. Transportation of patients with an Impella is similar to intra-aortic balloon pumps. The Impella device is tethered to the patient, and careful attention must be paid, particularly during loading and unloading into the vehicle. Specifically trained nurses, doctors, perfusionists, or paramedics are responsible for Impellas during transport, along with the infusions that often accompany mechanical support. Left ventricular assist devices. Left ventricular assist devices are implanted mechanical devices that support circulation in patients with severe left side heart failure. Patients receive left ventricular assist devices to support heart function while they await a heart transplant, or as a short-term support while the heart recovers from injury. Left ventricular assist devices provide continuous blood flow. A small pump with power source and controller is worn on the patient's body, and connects to a drive line that drives blood flow out of the left ventricle, and into the aorta through inflow and outflow tubes. Left ventricular assist devices do not generate a pulse, but rather a continuous pressure equivalent to the mean arterial pressure. This cannot be measured with a traditional blood pressure cuff, and patients will often be pulseless even though their device is working normally. A hum can be heard on auscultation of the precordium. Patients must be on anticoagulants so that blood clots do not form. Assessing vital signs in patients with an left ventricular assist device is challenging. Doppler devices and non-invasive blood pressure cuffs may provide a mean arterial pressure. Pulse oximetry is often unreliable. Clinical signs of perfusion can be helpful in assessing unresponsive patients without a pulse but who may have normal left ventricular assist device function. Because unresponsive patients with an left ventricular assist device and with normal mean arterial pressures can present pulseless, paramedics must search for other signs of perfusion. Emergencies occur under the following circumstances. A clot forms that disrupts the device. One of the components becomes displaced. The driveline becomes infected at the site of skin entry. The pump, controller, or power source fail. Anticoagulants cause bleeding in the gut or the brain. Early after implant, bleeding can cause cardiac tamponade. All patients with an left ventricular assist device have access to a 24 hours on all-day support phone line. Paramedics should utilize this line to troubleshoot problems and arrange transport to the hospital where the device was inserted if patient condition allows. Patients with an left ventricular assist device and with hypotension often respond well to small fluid boluses. Tachydysrhythmias are common. Cardiac arrest is rarely survivable in patients with an left ventricular assist device. Reversible causes of cardiac arrest should be explored, including hyperkalemia and hypovolemia. If a hum cannot be heard on auscultation, the device is not powered, and should be connected to an external power source. Although the manufacturers generally do not recommend chest compressions be performed due to the risk of cannula displacement, a patient in cardiac arrest with no hum, and no mean arterial pressure or no signs of circulation requires chest compressions. Technological advancements are allowing patients with very sick hearts to live longer, receive heart transplants, and recover from cardiac arrest. These advancements may prove disruptive to traditional EMS beliefs around duration of resuscitation, importance of scene time, transport destination, and termination of resuscitation. The evolving science has raised more questions than answers, but one thing is clear. The future of resuscitation will involve more, not less, technology. Medications commonly prescribed to patients with coronary heart diseases. Patients with diseases affecting the cardiovascular system may be taking a wide variety of medications for various reasons, and it is not always possible to identify the patient's specific problem on the basis of a medication that he or she is taking. Beta blockers, for example, are prescribed for relief of angina, to lower blood pressure and hypertension, to manage chronic heart failure, and to prevent recurrence of acute myocardial infarction. Similarly, diuretic medications may be given simply to help rid the body of excess fluid in heart failure or because of their effects in lowering blood pressure. Thus, you need to look at any given medication the patient is taking in the context of the patient's clinical history, and the other medications he or she is taking. Digoxin. Digoxin is prescribed for the treatment of chronic heart failure or for certain rapid atrial dysrhythmias, such as rapid atrial flutter, atrial fibrillation, and supraventricular dysrhythmias. Digoxin acts by increasing the strength of cardiac contractions, thereby improving cardiac output, and slowing conduction through the atrioventricular junction, such as in atrial fibrillation or flutter, allowing fewer impulses to be conducted through to the ventricles so the overall heart rate slows. In at least 30% of patients taking digoxin, some symptoms of toxic effects of the drug develop, for example, loss of appetite, nausea, vomiting, headache, blurred vision, yellow vision, or various cardiac dysrhythmias. Virtually any cardiac dysrhythmia may be caused by the toxic effects of digoxin, so it is important to ask all patients with disturbances in cardiac rhythm to determine whether they are taking digoxin. Patients taking digoxin are very sensitive to calcium preparations. They are also highly sensitive to a decline in the serum potassium level, so caution must be exercised in giving agents that might reduce the body's potassium stores, such as diuretics or large quantities of sodium bicarbonate. Anti-anginal agents. 3 major classes of drugs are used to relieve the pain of angina: nitrates, beta blockers, and calcium channel blockers. All of them work exclusively or primarily on the demand side of the oxygen supply-demand equation, that is, all of them diminish, in one way or another, myocardial oxygen demand. Nitrates. Nitrates were the first medications to be used for the relief of angina. The prototype of this group is nitroglycerin, which comes as sublingual spray, rapid-acting sublingual tablets, sustained-release oral tablets, topically applied ointment, and skin patches. If a patient reports that he or she takes a medicine that is put under the tongue, that medicine is mostly likely nitroglycerin. Nitroglycerin is thought to exert its therapeutic effect by decreasing the work of the heart. The heart's need for oxygen is, therefore, decreased, as is the anginal pain that results from insufficient perfusion. Nitroglycerin usually takes effect within 3 to 5 minutes of administration. Nitroglycerin also causes significant vasodilation. For that reason, it is sometimes used in the pre-hospital environment as an adjunctive therapy in the treatment of pulmonary edema secondary to left-side heart failure. Used in that circumstance, nitroglycerin produces an internal phlebotomy, that is, a pooling of blood within the venous vessels that reduces the blood volume in the pulmonary vasculature just as if blood had been physically withdrawn from the body. Phlebotomy. When a patient reports taking nitroglycerin for chest pain, you need to find out the answers to two questions. 1. How much nitroglycerin did the patient take? 2. Did the nitroglycerin relieve the pain? Failure of nitroglycerin to relieve anginal pain can occur for one of a few reasons. The pain is not cardiac, the pain is of extraordinary severity, the pain is from infarction rather than angina, or the nitroglycerin has been open too long and is no longer effective. Fresh, potent nitroglycerin has certain distinct side effects, including a transient, throbbing headache, a burning sensation under the tongue, and a bitter taste. If the patient did not experience the bitter taste or did not experience a headache when he or she took the nitroglycerin, chances are the medication was outdated or ineffective. If the patient experienced a throbbing headache but still got no relief from the chest pain, suspect that the patient is having an acute myocardial infarction. Beta blockers. Medications that block beta sympathetic receptors are prescribed for patients with hypertension, angina, and chronic heart failure. They work by decreasing the rate and strength of cardiac contractions, thereby decreasing the heart's demand for oxygen. Taking beta-blocking medications on a regular basis usually leads to resistance to the action of beta-stimulating agents, such as epinephrine. Therefore, when such patients have a cardiac arrest, the administration of epinephrine during resuscitation attempts may not have the desired beta-agonistic effect, because the beta effects of epinephrine may be blocked. The alpha-agonistic effects of epinephrine, namely vasoconstriction, are not blocked, thus making it a useful medication in resuscitation of cardiac arrest patients, even if they are taking beta blockers. Calcium channel blockers. Calcium channel blockers, as their name implies, block the influx of calcium ions into cardiac muscle. These agents relieve angina in two ways. 1. By preventing spasm of the coronary arteries and, 2. By decreasing the force of the cardiac contraction, thereby decreasing myocardial oxygen demand. Hypotension may be a significant side effect. Table 30-23 lists calcium channel blockers. Two of these medications, diltiazem and verapamil, also slow conduction through the atrioventricular node, resulting in slowing of the heart rate. They can be used for angina and hypertension but are primarily used for rate control in people with atrial fibrillation. Antidysrhythmic medications. Antidysrhythmic medications are used to control chronic disturbances in cardiac rhythm. Thus, when you encounter a patient taking one of these agents, you know the patient has had significant dysrhythmias in the past, which justifies particular surveillance for recurrent rhythm disturbances. Patients taking antidysrhythmic medications should be monitored while under your care. Some of the medications mentioned under other categories are also used for their antidysrhythmic activity. Digoxin preparations, for example, are used to suppress atrial dysrhythmias. Beta blockers are sometimes prescribed for their suppressive effect on myocardial excitability, as are some of the calcium channel blockers. Table 30-24 lists commonly used antidysrhythmic medications. Diuretics. Diuretics, water pills, are prescribed to patients with chronic fluid overload, principally patients with chronic heart failure, but are also used as primary or adjunctive therapy in the treatment of hypertension. Diuretics trick the kidneys into excreting more sodium and water than usual, the desired effect. Depending on the diuretic, the kidneys may also tend to dump out potassium along with the sodium, an undesired effect. Thus, patients taking diuretics often become depleted of potassium if they are not given potassium supplements. Patients in whom potassium deficits, hypokalemia, develop are susceptible to cardiac dysrhythmias, especially if they are also taking digoxin. Table 30-25 lists commonly prescribed diuretics. Antihypertensive medications. As the name implies, antihypertensive agents are used to treat hypertension, high blood pressure. Many of the diuretic agents already mentioned are also used as antihypertensives or in combination with antihypertensives for a synergistic effect. Similarly, beta blockers and calcium channel blockers are also used in the treatment of hypertension. Other classes of medications that are commonly used for hypertension and heart failure are angiotensin-converting enzyme inhibitors and angiotensin II receptor blockers. These agents work by relaxing the arteries, thus reducing both blood pressure and afterload. They can be used alone and are also commonly used in combination with diuretic agents. Table 30-26 lists commonly prescribed angiotensin-converting enzyme inhibitors and angiotensin II receptor blockers. It is often difficult to regulate the dosage of antihypertensives so that the patient's blood pressure is lowered enough, but not too much. As a consequence, some patients taking these agents may have symptoms of hypotension, including weakness and dizziness. Many will experience a feeling of lightheadedness with a change in position, such as when moving from a recumbent to a sitting or standing position. This phenomenon is termed orthostatic hypotension. Every patient taking antihypertensive medications, therefore, should have his or her blood pressure checked in the recumbent and sitting positions to detect orthostatic hypotension. Anticoagulant medications. Anticoagulant medications, blood thinners, diminish the ability of the blood to clot. They are prescribed to patients who have had recurrent problems with blood clots, such as patients who have had pulmonary embolism, and to patients who might be prone to develop clots, such as some patients who have had a myocardial infarction in the past, patients with artificial heart valves or valvular heart disease, and patients whose normal heart rhythm is atrial fibrillation. Patients who take anticoagulants are apt to bleed excessively from minor trauma or even venipuncture, so you should be alert to that possibility. The traditional oral anticoagulant medication is warfarin, Coumadin. Newer oral anticoagulants include dabigatran, Pradaxa, rivaroxaban, Xarelto, and apixaban, Eliquis. Some patients also take subcutaneous anticoagulants such as heparin, dalteparin, Fragmin, enoxaparin, Lovenox, fondaparinux, Arixtra, and enzaparin, Inohep. Antiplatelet medications. Antiplatelet medications interfere with platelet aggregation and clot formation, impeding the ability of the blood to clot. They are prescribed to patients with coronary heart disease, as well as to those with a coronary artery stent. They are also very useful in the setting of an acute myocardial infarction, because they prevent more platelets from being recruited to form a new clot. Patients who take antiplatelet medications are apt to bruise easily or bleed excessively from minor trauma. The most common antiplatelet medication is acetylsalicylic acid. Alternatives for ASA include dipyridamole, Agrenix, Persantine, anticlopidine, Ticlid. Other newer antiplatelet agents that are commonly administered for an acute ST segment elevation myocardial infarction are clopidogrel, Plavix, Ticagrelor, Brilinta, and Prasugrel, Effient.